I think that would be. Much better.
Yeah.
So which one is working now? This one? Hello? Is it
So
clear?
you can go back. So go from there.
Yeah, it will be clear from here. Oh, it's okay.
Run it like
So I will.
this.
Yeah, I'll remove this one.
Yeah, much better. Touches it.
Okay. Forget. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning once again, and welcome to day 2 of our symposium here at Naufar. My name is Samira Al-Yafei, and I'm the head of Social Worker Department, and I'm delighted to continue this journey with you today as the MC for the second day. Yesterday, we explored the foundations of personalized and precision medicine in the treatment of substance use disorders, examining the roles of genomics and pharmacogenetics and how new medication-assisted treatments can be tolerated to support recovery. Today, we will build on that foundation with the sessions that go into applied precision interventions and the management of mental health. We will also address pressing challenges unique to our region. This in addition to learning about behavioral addiction and the emergence of novel psychotropic substances. A key focus of today's discussions will be the complexities of identifying and treating SUDS in professional athletes, emphasizing the need for specialized, personalized approach. We will also explore real-world outcome measurement and the use cutting-edge tools like brain stimulation for addiction treatment, and how a new approach such as wastewater analysis can inform substance use public health strategies. Finally, we will look at how research in SUDS is not only a way to advance patient care, but to shape national and international policy framework. Now, we move on session 4, titled Co-occurring and Novel Challenges. This session will address some of the most pressing and emerging issues in the field. Please join me in welcoming our esteemed moderators, Dr. Sultan Ibrahim, who is a consultant psychiatrist and MDT lead of Divergent Program and Detox Unit here in Naufar, and Ms. Dania Al-Ishaq, who is a psychologist from Naufar, who will guide us through this insightful session.
Hello, yeah. Assalamu alaikum. Ladies and gentlemen, welcome to session 4. In this session, we will have 4 guest speakers who will be discussing topics related to comorbidities and novel challenges. Our first guest speaker this morning will be Professor Faris Al-Harbi. Professor Faris is a consultant psychiatrist and addiction medicine specialist. He is currently served as the chairman of the addiction services at Dalat Namar Hospital in Riyadh. He also served lots of executive roles, including the CEO of Ma'an Medical Complex and the chairman on board of Aoun Medical Rehabilitation Center in Egypt. He will take us this morning through the polysubstance abuse in the Middle East. Please join me in giving a warm welcome to Professor Faris Al-Harbi.
Can you help me with the slide? Hello, everybody. I'm delighted to be here with you in Qatar, and I would like first to thank Dr. Mahadid and his team for inviting me to this wonderful meeting. Today we are talking about substance abuse in airport. Does it matter, and where are we? Actually, at the beginning, I was thinking to present about substance abuse in the Middle East. Then I changed my mind because, in the Middle East, we have a different culture and different ethnicity and different circumstances for each people. I will explain this in the next few slides. Actually, this is a chapter we wrote it in the Handbook of Healthcare in Arab World. And this work, I work with my colleagues, Dr. Itab Asbei and Dr. Khalid Asremi. I have no conflict of interest to declare. In this presentation object, first we will discuss the current status assessment of the substance abuse in Arab world and population analysis and the user demographic and substance overview, the most common substance abuse in Arab world. When I want to do the presentation, we go to the WHO report and United Nations of Drug and Crime report. We found that the classification of our region is different. Like WHO, they usually classified our region as Eastern Mediterranean region and doesn't include some Arab countries like Algeria, Mauritania, and others, and also include Turkey, Afghanistan, Pakistan, which may not represent our region. As we know that in Afghanistan, Pakistan, and maybe Iran, they have a lot of opioid addiction. So in the report, we found our region, they have high chances of abusing opioid, while it is not actually accurate. Also in United Nations of Drug and Crime, they classified our region in Near and Middle East, Southwest Asia category, which include Turkey and Iran and Pakistan. And we know these non-Arab countries, they have different economic policies, culture, tradition, the type of substance abuse and ethnicity, different than other Arab countries. So with this report from WHO, other international organization, their classification may be not accurate to describe the real problem in our region. So in the methodology of this chapter, we do comprehensive review of published studies from PubMed, Google Scholar database. Also, we include international reports, and we do data synthesis, integrating the finding to create a comprehensive regional picture of substance abuse. So, substance abuse in Arab world, where are we? Research evolution. The first paper we found it is 1967. But the research we found are limited in the scope and depth. Most of the study, they include a small sample size, or they include a specific population, not as general population, or concentrate on certain aspects. So they don't, usually these studies from that time till now, most of the study, they are limited in the scope and depth. There is culture context. You know, in our region, religious play a major role in our daily life. So, and the social aspect, its impact both use and report in our region. We'll find more about these issues in the next few slides. Data limitation, lack of comprehensive national statistics that hamper our understanding. We found it's rare to have a registry about substance abuse in our region. I didn't find a lot or limited. If anybody from Arab region to see if we have a registry for substance abuse, we don't. We know if we say about America, how much the substance abuse. We know each type of substance, how much is prevalence, risk factor in each age group. But in our region, these questions are difficult to be answered. So also we have in Arab world regional misrepresentation. As I mentioned before, when we see WHO classification or United Nations of Drug and Crime classification, so the classification, they are misrepresentation or misinterpretation of our region. In our region, we have culture and legal barrier to research. First, religious prohibition. We know substance use are strongly condemned in Islamic teaching, which create a huge stigma around research and participation. And even to get approval, you know, especially before a few years, even if you want to get IRB approval for any question about addiction, it will become difficult, and we have that barrier. Legal consequences. You know, criminal penalties for substance abuse in many Arab countries prevent honest reporting study. Because abusing is a criminal in our region. So if we have a study and take like a report, self-report, the people will be hesitant to participate or give you a correct answer. Gender difference. Women face more stigma than men in our region, resulting in lower representation in substance abuse research and treatment. Also, when we collect data, we found some difficulties and challenges. A lot of information are outdated. There is no frequent update of information. Misclassification, including Arab and non-Arab in the international reports. Policy misalignment, inaccurate assessment lead to ineffective intervention, as we know. Statistical distortion, higher drug use in non-Arab countries affecting the report in our region. As I mentioned, like in Iran, I just discussed with Dr. Hamid earlier, he told me that there is 3,000 clinic for methadone program for opioid. But in our region, the opioid is not so common. I think in our region, maybe cannabis and amphetamine more common than opioid. So, but if we see the presentation of our region in the international report, you find it is high using of opioid. So this misclassifications affect the report. Substance abuse in our report. If we take substance by itself, we found that cannabis is most widely used illegal substance in our report, which is not as usual in the Western. The Western, they have the first one usually alcohol. Of course, the first one is smoking or nicotine, even in our region, but I mean other substance. But in our region, alcohol is not the first. Cannabis is the first. Amphetamine after cannabis. Then opiate, it is less common than global average in our region. And sedative and tranquilizer, especially in the North Africa. And cocaine, ecstasy, there's still minimal report. We find mostly in Lebanon. But in other regions, it is less common. We see here by countries, each substance, what is the most common in countries in the Arab world. Cannabis is the most common in Egypt and UAE. In Egypt, 6.24%, and in UAE is 5.35%. Amphetamine is the most common in Egypt and Saudi Arabia. It is 0.48 in Egypt and 0.40 in Saudi Arabia. Opiate is the most common in Egypt, 0.44, which is less common than global average, the opiate. Cocaine, most common in Morocco, it is 0.05. Ecstasy, mainly in Lebanon, because you know ecstasy usually is the club drugs is associated with the parties and nightlife, and in a lot of Muslim countries this is limited, so ecstasy is less common in our region. Tranquilizer is the most common in Algeria and Tunisia than any other Arab country. This is a slide. I will not go in detail above, but we can see the down. In the down, the first one is cannabis, the first pillar. Second one is amphetamine. Third one is opioid. We see that cannabis is the most common around all Arab countries. And the second one is amphetamine, and third one is opioid. Common substance used in our board, we discussed the most four substances that we found in the literature. First, alcohol is lower consumption than the average in the whole world. Actually, our region is the lowest among all parts of the world. We'll see why in the next few slides. Cannabis is the most widely used illegal substance across all Arab countries. Opioid, tramadol, especially tramadol, misuse emerging as a significant concern, especially in Egypt. Stimulant, Captagon dominate the regional stimulant market. First, we'll discuss the alcohol. Alcohol we see around Arab countries like in Kuwait, Libya, Somalia. The annual per capita alcohol consumption is less than 0.1%. The highest in UAE, It's a 3.8 liter per capita. This is mainly because there is a lot of foreigner there. But the interesting issues that we found in literature, 95% in the Eastern Mediterranean, lifetime abstinence. They never use alcohol in their life, which is lowest around all other parts of the world. Of course, we find men more than women abuser. Why culture factor influence the alcohol consumption? We say it is the least among all other parts of the world. We try to explain that in the literature. Maybe first, for religious context, we know Islamic prohibition of alcohol consumption and serve as a powerful tool in each one that he didn't use alcohol. It's a funny story that I have. One of my patients in the addiction center, I told him, you use cocaine, amphetamine, cannabis, what about alcohol? And he said, haram. So in our region, it's specific in Quran, prevent, or it's a huge haram, it's abusing alcohol. So in our region, abusing alcohol is less than any other region in the world. Also from social pressure, the strong social stigma exists against drinking behavior in Arab world. And legal framework also, it is criminalized in a lot of Arab countries that abusing of alcohol. And restricted its availability in others, and in other countries they have high taxation, even if it's available. Special consideration for alcohol use disorder. You know, culture, context matter. Even moderate drinker in our region may consider hazardous due to serve of social, legal, and professional consequences. So even drinking a little or mild or moderate in our region is considered a huge stigma. Because of fear of detection in our region lead to secretive and risky drinking behavior and heightening risk of and user face potential imprisonment or fine or job loss or family conflict or divorce, direct consequence of alcohol use. So they start to use in the secret. And in the secret, usually it has a lot of consequences. They don't admit that they are abusing, and there is a lot of behavior associated with it. So this is the issues that I want to discuss with you. Clinical implication. Diagnosis must consider local culture norms. We don't just take the Western medicine and apply it to our region, where any consumption might be problematic rather than applying the Western standard. Do you agree with that? Let's make this point for discussion. Clinical implication. So what about opioid use in Arab world? The percentage of the people who admitted to addiction center or addiction treatment facilities, they found in general population is very low. It's 0.01 till 0.44 around all Arab countries. But the people who admitted in the treatment facilities, the most common was heroin. And it's more prominent in Oman than UAE and Jordan and Lebanon. Tunisia reports that abusing buprenorphine more than heroin in the treatment facilities. Tramadol. Tramadol, one of the opioid, and is frequently abused for recreational purpose rather than medical need. It's more prominent, especially in Egypt. In Egypt, they use it for many indications, for the mood enhancement, for delayed ejaculation, reducing fatigue, for the mood, for anxiety. When I went to Egypt, they told me that tramadol for everything. Also, UAE pattern offer 67% of UAE opioid user misuse tramadol. And even in Saudi Arabia, when we have people abusing tramadol, we said, your friend should be Egyptian. And we found it is. So it's usually Egypt. Tramadol is so common in that region. Perceived safety, wrongly believed that tramadol is safe due to the status as prescribed medication. Opioid public health implication, disability burden, major contribution of disability despite low prevalence rate. Although it's low prevalence, but it's carry a huge disability. Prescription misuse, so it's always opioid is prescribed, but sometimes there is some prescription misuse. Youth vulnerability, misconception about safety attract the young user. What about stimulant? In Saudi Arabia, is the most common substance of abuse is the stimulant. And mainly Kiptagon. I try to put the picture of each substance here. Kiptagon, the most commonly abused stimulant across the Middle East region. And methamphetamine start to growing these days, but it's less common than other parts of the world. Cocaine, it is limited use, maybe because it's expensive, so it's usually abused by businessmen. Ecstasy is less common in our region because lacking of nightlife and clubbing and parties, most common in Lebanon. Kiptagon, the number one stimulant used in our region, is typically contain amphetamine and thiophyllene, and they have combined with other substances like caffeine, paracetamol, and other substances. Production center, it's mainly synthetics, Kiptagon in Syria and Lebanon. So it's easier for them to come to our region. The traffic patterns, Saudi Arabia serves as a primary destination market for Kiptagon. Large seizure report annually. Gulf countries are major consumption market for Kiptagon. There is organized smuggling network and operate over the border, and we can see in the report, usually they may hide it in the fruits and other regions. It's like network or criminal organization rent this. Factor-driven Kiptagon preference, local production. Why Kiptagon is more common in our region? Because the local production is proximity to manufacture center. As we mentioned, it's in Syria and Lebanon mainly. Established network, traffic. There is traffic infrastructure, limited alternative, because restricted availability of other stimulant. And culture context, nightlife limitation, reduced demand for club drugs. So club drugs are not common, so Kiptagon is common. What about cannabis in Arab world? We know the most part of the world, they usually use marijuana, which marijuana is flowering top leaves used. So, but in our region, they use usually hashish, which is cannabis resin. I put the picture. The hashish is highly prevalent in the Middle East and North Africa. It's more concentrated form if you compare it to cannabis. And usually it's mixed with tobacco, and usually when we try to assess cannabis abuse in our region, we said, how much is the abuse per day? Usually they don't say it is a gram, 200 gram or something. What they say? Joint, yes, maybe joint, maybe others, because we use hashish, balatat hashish. What we say, he used galam. Galam, it's almost a slice, small slice. Or isba', it's a little bit bigger. Or نص ثمن. نص ثمن إيش معناته؟ يعني a little bit. So they try to measure it by how much they cut from the hashish. It's become like this. So cannabis prevalence in Arab world, we see the most common in Egypt, 6.25. Actually in Kuwait, I find mixed result in literature. There is some studies mention 3.1, and other studies mention up to 11% they abuse cannabis. In Morocco, 8.1. But the important issues about Morocco is the major productive and exported of cannabis resin in Morocco. contribution of 25% global cannabis seeds around the world is protection from Morocco. Cannabis and mental health. In Lebanon, studies about schizophrenia patient, they found that schizophrenia patient, 44.8% they are cannabis abuser. In Morocco, the schizophrenia patient, 49% of them, they abuse also cannabis. Is it started after they become schizophrenic or before? We don't know in the studies. In Saudi Arabia, there is a lot of study mentioned that adolescent user, they develop psychotic symptoms. And in Morocco, they link that high school student with suicidal behavior if they abuse cannabis. In North Africa, there is an interesting study. They linked cannabis smoking with lung cancer. The profile of Arab substance abuser was the profile of the abuser himself. Predominantly young, male, under 40 years of age, typically single or unmarried, and they have low educational background, often below secondary school education. Usually they are frequently unemployed. But the important issue, female substance user, they are less prevalent and more hidden due to cultural stigma. You know, in our culture, if the female is abusing and she went to treatment facilities, it may affect the reputation of the whole family. So less likely to seek treatment, the female abuser. Recommendation to improve data collection, regional reclassification, as we explained, Arab League grouping, creating cohesive categorization, reflect the culture, realities, culture-sensitive research, develop locally appropriate methodology and framework, and policy-focused study. Implication for prevention and treatment, target intervention, focus prevention effort on young, unmarried male and with limited education, because these are the risk factor for abuse. Employment program for substance abuse to decrease the risk of abusing, educational support, and gender-specific approach, because, as I mentioned, female abusers, they are less likely to seek treatment. So in summary, we explore here substance abuse pattern, demographic, and common substance in our board. Take-home message, culture context significantly influence substance abuse. With unique regional challenge, requires specialized approach. And of course, there is a lot of research needed in our region. And thank you.
Thank you, Professor Faris Al-Harbi. It was a very informative talk. Now we'll open up and we'll give the floor to the audience. Yes, Ms. Hanadi.
Hello. Thank you very much for this very comprehensive session on prevalence. My question is, okay, we know about underreporting and the stigmatization behind the substance use disorders and with patients. What about the screening among healthcare professionals? Do we have screening for substance use disorders among our healthcare professionals? Because, you know, I remember when I did my thesis a few years ago, it was about screening for anxiety and depression in chronic illnesses. And we found out that, you know, we don't ask these questions. Do our healthcare professionals screen for substance use disorders in this part of the world?
Actually, it's interesting you ask the question. Did other healthcare professional ask as a screening question for his patient that they are abusing substance or not? I don't think so. There is an interesting study, I think it's from Saudi Arabia. They ask this question to primary health care. And some answer mention, even if I know that he's abused, I don't know what shall I do with him. I don't know how to treat him or where to refer him. So I think this question, that's my assumption. It is less common or less being asked.
Assalamu alaikum. Thank you for your presentation.
Just I'm asking about from ethical side. Can we collect data from the patients or from people who are not interested to participate in research, or they don't like to disclose about their substance use disorder? As we know, there is big benefit for them if we collect data that present, as you said, there is representation from the sample, as we can use the power of court of public prosecution to collect data about that people, or from ethical side not allowed?
Actually, in research, we have to take a consent from participant. We don't force people to be in the research. This is the first, in each research you have IRB approval and ethicals. So we have to take consent for each research, either psychiatry, addiction, medical. We don't force people for studies, usually. Yeah.
Thank you so much for your excellent presentation. In another day, another life, I was, before coming here, I was the director of the Moroccan Observatory on Drugs and Addictions. So we did a lot of data collection throughout the years. One of them was the National Household Survey. And I think at this day, I think Morocco is probably the only country that has a household survey in the whole region. It was published back in 2005. It dates, of course. But then we have also, what we did is, on a regular basis, every 3 years, we do what we call a MedSpat survey, which is 15-17 at the national level. Why 15-17? Because the National Household Survey gives you a clear idea of what's going on in the country. And then 15-17 gives you what will be the problem in the future. So that you can anticipate and you can also plan for prevention, because you see new ways of using, you see new drugs, you see new patterns. I think that's the most important thing. And then one thing that unfortunately it's not done enough in our country is just report to the people in treatment. And that's the treatment demand indicator. It's very easy to do, and it gives a lot of information. And one of the things I wanted to maybe challenge you about it is how we do research and for what. Why we go after prevalences in a general population or in specific populations. And I think the most important thing is not about doing research. It's about the rationale behind it. It's about how we do it and why we do it. It's the objective and the main goal. People tend to think that by going and collecting data on drug use, actually you kind of, as we say in French, secouer le cocotier, which is really dusting the air, which is not the case. Going after data collection is to inform policy making. It's really for the sake of the population. If we go there and then we collect data, it's exactly for those people to be first to detect, and I'm going to be talking about it in my presentation, to intervene as soon as possible, to plan, and at the end of the day, to give the best treatment and the best, of course, comprehensive programs, not only for prevention, indicated and also selective prevention, but also for treatment and rehabilitation. So unless you have data, and that's this culture of data collection and the spirit of data collection is not there yet. We don't work with figures. We work with assumptions, and it's part also of, as you said, rightly said, it's part of the cultures, barriers, also the perception of what the drug is. So because the drug is illegal, using it becomes illegal, and the person herself or themselves become illicit. So you're dealing with someone who becomes illicit because the drug of use is illicit and behavior is illicit. And that has, of course, a history that dates back to the 30s of the last century.
Thank you, Doctor, for a really interesting point you raised, Doctor. You know, as you mentioned, we talk about prevalence. I think prevalence is the first step to research. So we understand how is our population? How can the policymaker or policy making to decrease these issues? Without knowing the prevalence, what substance, what the people, what's the age, education, etc., we cannot make a clear policy. It's like walking in the dark.
Dr. Tamer, yeah, go ahead.
Assalamu alaikum. Dr. Faris, thank you for this excellent presentation. But just I want to share with you and ask you about the prevalence of substance during the Arab world, because I'm finding that it is not only related to the cultural context, some political issue, some medical or health issue, or some financial issue also affects the prevalence of certain substances. Let me give you an example. In Egypt, there is some trend now in Egypt to use a novel substance which is less costly for the patient, like Astrox, like Voodoo. It is locally invented there and it's very cheap, so it become a trend in Egypt now. In Gulf area, in 2017, we face here changes from the previous prevalence of certain substance here in the Gulf area related to cannabis and captagon, and then shifted after 2017 to an outbreak of increase in use of heroin, increase of use of methamphetamine, and then during the COVID period, there is an increase of prevalence of new substance, which is synthetic cannabinoids, which is easily obtainable from outside. It's very cheap. So you know that the COVID, there is no trading or something, so you can order it online. So a lot of aspects affecting the prevalence in each duration. So if you are making a prevalence of substance for the time being, it can be changed after 1 or 2 years, which would affect, as Dr. Prof. Galal said, as a treatment of this population. So it needs a close monitoring of the prevalence every time, just to monitor what is changed in the culture. Thank you.
Doctor, actually, I totally agree with you. Substance abuse tend to change over the time. So the substances that are common now, maybe after 5 years is not common. But the problem now, if we do the literature review, we are depending on the literature published. And I mentioned the limitation of this research. I told you that it's data limited, sometimes outdated information. So from this conference, we need to make a statement or recommendation to all Arab countries. We have to do research regularly. We have to have a registry for substance abuse so we can make a plan. I totally agree on substances are changing. I just came from Egypt. They told me about stroke and others. But since there is no study published, we cannot say.
Thank you so much, Prof. Faris.
Thank you.
Thank you, Faris. So Naufar is a substance use disorder specialized center. And internationally, there is another field of addiction which is more related to the behavioral addictive disorders. We know from the literature that there has been increased interest in studying behavioral addictive disorder, specifically things related to gaming, sex, and gambling. So we are privileged today to have one of our colleagues from Asia to talk about gaming disorder and the cross-cultural expression. So it's my pleasure to introduce Dr. Lee Tong Sen, who is a psychiatric registrar at Cipatu Mangkusomo National Referral Hospital in Jakarta, Indonesia. He's a member of the Associate Professor Christina Sisti's research group, and Dr. Lee earned his medical degree from University of Indonesia and has a Master of Research from UK Newcastle University. He specializes in addiction sciences and behavioral addictions, and he had published peer-reviewed work on topics including internet and gaming addiction and clinical intervention. Please join me in welcoming Dr. Lee.
Right. Good morning, everyone. Thank you very much. I would like to thank you, Prof. Mohammed and Dr. Khalifa, for the warm invitation here. And today we're going to talk about the gaming disorder, its cross-cultural expression, how the landscape have evolved over the years, and what we've done to approach it clinically, and we'll tie it together with the symposium theme of precision medicine at the end. Right, so just to clear out the way, I'm affiliated with the MOH hospital back home. Okay, thank you. So I don't have any other conflict of interest. So just to set the scene, right, gaming has changed from like 2-3 decades ago, where you go to the arcades or use consoles. Nowadays, it's all about mobile phones. And in Indonesia, the figure in 2024, the mobile phone penetration is about 80%. If you zoom in to 15 to 24, which is the most vulnerable group for this disorder, it's 92%. And I looked over for the figure in Qatar. It's surprising that the mobile phone penetration is 140%. I'm not sure where the other 40% is from, but that's the figure from World Bank, right? And so it's becoming such a problem because it is ubiquitous. You can access online games from anywhere. And then we'll see that these games mimic some structural features from gambling that actually entices and immerses you in these games. So this disorder has been classified formally in ICD-11. There's been some categorization in DSM-5 previously, but it's still in the chapter 3 of further studies. But in 2019, ICD-11 categorized this as a formal disorder. And 3 main criteria is preoccupation. So you prioritize gaming over other things, and then you have loss of control over your gaming behavior, and you continue it despite harm. And the most important thing is that you have this component of harm and impairment to your daily functionings. And there's been some suggestions by experts worldwide that you can stratify people who are gaming, right? So obviously the majority would be non-gamers. I believe many in the rooms do not game on a daily basis. And then there are people who, you know, have gaming as a healthy life, hobby, a pastime, or some even game professionally. And then you get these people who are at risk. They might potentially get harm from their gaming. And there's a specific code for in ICD-11 as well that's hazardous gaming. And then, of course, at the very top, a small population is disordered gaming. Now, we did a study using unsupervised machine learning, and we did get this certification in Indonesia as well, while we're adapting an instrument to assess gaming disorder. As you can see that it gives us these 3 subgroups that quite match the theory that has been proposed. So you get these low-risk gamers, moderate risk, and high-risk gamers, which we think is synonymous to the healthy, below threshold of harm, and then those as hazardous and disordered gaming. And what really sets apart hazardous and disordered gaming is, again, the criteria in ICD-11, you know, where they cannot control their gaming, they lost interest in other activities, they only focus on gaming. But what really differentiates hazardous and disordered gaming is the harm. You can see that even though they have diminished performance in school or job, they continue to game. They understand that they have lost their jobs, but they continue to game. And perhaps there are other consequences, and yet still they game. Now, we really need, as mentioned before with substances as well, data on prevalence is important. It guides and it tells policymakers what to focus on and whether this is a problem or not. There's been a lot of studies prior to the ICD-11. It has been very heterogeneous. People classify it however they like. They use whatever tools there are. So you get really wide variety of numbers. But recent meta-analysis have said that worldwide you can expect a prevalence of about 3%. And in the global north, say Europe or Americas, somehow this numbers is smaller, about 2 to 2.5. And we have consistently seen that in Asia, East Asia, Southeast Asia, or South Asia, that the numbers are double of that. It's much higher, about 5 to 6%. And I tried to look for a number in the Middle East. There's not much data, but there's a group that studied in 3 Arab countries, I think Syria, Jordan, and Kuwait, and they showed over 1,500 respondents. It's about similar with Asia at 6.1%. And there's this interesting study from Mexico, right? They interviewed 7,000 students using DSM-5 and ICD-11. So on the DSM-5, you can appreciate that it's double of what if you use ICD-11, right? So they're not sure why that is, but perhaps having more criteria in the DSM-5 is not helpful. And then if we're talking about gender or sex, male, 2.5 times more likely, and children or adolescents are the most vulnerable group here. So we also did a study comparing, not just the DSM or ICD-11 criteria, but we adapt some of the instruments that are based on those criteria. So GAMES, which is Gaming Disorder Screening Test, it's based on ICD-11, developed by a Japanese group, and IGDT-10, which is based on DSM-5. This is developed by Kirli from Hungary. And we see a stark contrast with the Mexican group, right? When we use the test that is based on ICD-11, we get a higher number, double of that if we use the criteria from DSM-5. There's a moderate agreement between the two, but this is really interesting to us because we were not expecting this. And we think that it might come down to cultural differences. Because if you use the games, the question is quite simple. We just ask the participant to answer yes or no, whether you think you have it or you don't have it. But with the IGDT-10, it's a 3-point Likert scale. So you can answer 0, I don't think I have it. 1, I might have it some of the days. And 2, I definitely have it. And even in practice, when we use IGDT-10, we've diagnosed the patient with gaming disorder. We ask them to fill out the questionnaires, and they don't get the scores above the threshold. So what we see is that there's this tendency to have a central response to just score 1. And with IGDT-10, if you score 1, we don't give that a point, right? And turns out there's this very old study, right, back in 2002. They surveyed Japanese, Chinese, and Americans, and they do see that the Chinese and Japanese don't really like to give extreme answers, right? Asians don't like to stand out. We have this stigma of like, okay, if we have something, hush, hush, right? So, and this might result from, the nature of the society, collectivism versus individualism. And in market survey research, actually, this is very famous. It's called the middle response style, and it's very, apologies if it's a stereotype, but it's very typical of Asians. Right, and then there's this also beautiful study by Cheng from Hong Kong that analyzed 3 cultural domains. So they look at quality of life, how we appreciate life, and then cultural masculinity. So if the culture appreciates achievement and success over everything else. And then lastly, power gap, how you believe in there's different levels in society, right? And countries with high masculinity, as in many Asian countries, we believe in success and achievement. Turns out they don't really feel like they have interpersonal issues. So it correlates less well compared to lower masculinity countries. And we did a study on about 1,000 participants, right, when we validate these instruments. And less than 30% also indicate that they have relationship issues. They feel like their problems lie more on sleep and physical complaints. And I think this resonates very well with the program in Naufar where, sleep, physical exercises, rehabilitation, promotion of healthy lifestyle is more important. So I think this feeds very well into, having a precise, more personalized categorization of program depending on the harm that your patients are actually experiencing. And then, we've dealt with some differences culturally, but thank God, underlying it all, the etiological model is still somewhat similar, so we can have an appreciation of the disorder. We did an fMRI study on about 60 adolescents with this disorder, and we found out that there's a decreased functional connectivity between nodes in the central executive network and the default mode network. right? And there's an increased functional connectivity with nodes in the salience network. And this ties really well with the literature that you see in gaming disorder patients. There's attentional bias, there's memory recall bias, and there's this less top-down signaling and more bottom-up signaling. So this transition from liking to wanting, as in drugs, are also present here. Now, this was summarized very well by groups in Belgium. He created a model of eye pace, right? And this is just a summary of it. So you see in gaming and other behavioral addictions as well, you get this cue reactivity that feeds into the craving, and it can come from external triggers, such as looking at consoles, looking at a phone, but it also can come from internal triggers, right? From your affective state, your memory recall bias of past positive experience on gaming, and it is distorted by your cognitive bias, and of course impaired inhibitory control because there's changes neuropsychologically. Now, considering that we did find evidence for this in Indonesia as well, so we were thinking, how can we use this data to direct us in what kind of treatment approaches that we want to do? Also, in the background, COVID-19 pandemic happened, and we did a study during the after the pandemic against about 7,000 respondents. This is on problematic internet use, right? And we see that it's such a huge number, right? And about 30% of that is about online gaming as well. And I don't know if you know Indonesia, it's a big archipelago. We got islands everywhere, and it's all separated. And we got 270, 280 million people. But in the country, there's only 1,000 psychiatrists and less than 40 addiction psychiatrists. So it's a really big demand for us to provide service for these people. So what we did is we devised an online group DBT, because we think a one-to-one CBT that is the standard of care in the literature might not cut it out, right? So why we choose DBT as well? Because it has these beautiful modules that we can teach the patients. So it was actually developed for borderline personality, but they also sense this urge to self-harm, which we think if we teach that emotion regulation to serve the urge, in this case, the urge to game, that will translate well to the addiction recovery. And then there's also this module on interpersonal effectiveness, and that will teach the kids, the adolescents, for refusal skills, which is very important. So we did that, and this is just a non-inferiority study. So we find that online group DBT is non-inferior to offline individual CBT. So it kind of provides another avenue. Professor Alex yesterday mentioned about telemedicine and how we can utilize that. And I think it's quite a new pathway that we can explore how to provide care in a high demand and low resource setting. Apart from that, we've discussed about the cognitive decline, distortions that we see in these patients. So we think, could we do something about that? So we devised a cognitive training program, training them in the memory section and in the attention section. And most studies have compared this with passive control. So the control would do nothing at all. But we've seen recent studies that compared it with active controls, and they don't really find benefits of it. So we want to be really sure, and we also compare it to active controls. And turns out there's really no effect in doing this cognitive training. When we compare it to active controls, both groups receive significant reduction in game severity, in craving. Although we do a positive trend of reduced impulsivity when you give cognitive training, but it's not really significant. So this also gets us to thinking if we perhaps need to do something else for that. There's this neurophysiological changes, the circuitry is changed. Perhaps we need to do something else. We are currently doing a TMS for gambling disorder, and we're thinking if expanding that to gaming would also help the patients. Now, I understand that Naufar is a substance use disorder treatment center. So in the past studies that we had, we also asked the participants whether they've, in the past months, used any substances, right? When we devised this question, we did not initially plan to put in NPS, new psychoactive substances, because, well, we thought, why, right? But then as we brainstorm, we just put it in, and the results we kind of expected, because Indonesia is also a Muslim majority country. So the most prevalent substance is, of course, cigarette, tobacco, smoking, and you can see that alcohol is very low. And the second most prevalent is actually NPS, and it's mostly synthetic stimulants, catenones, synthetic. Also in the rise is synthetic cannabinoids. So marijuana is not legal. I don't think people like the smell of it as well. So they and there's this product very famous in Indonesia where they put the synthetic cannabinoids in the cigarette, right? So people feel like they're just smoking as usual, but actually there's synthetic cannabinoids in them. And this compares very distinctly, and I guess it is because also of the legalization of marijuana in Western countries. So most of the gamers, the disordered gamers, use cannabis in the US, in Netherlands, but in South Korea, the most prevalent is also, again, cigarette. And this paints a picture of, since we come from a Muslim majority country, when I see patients and the parents, and I tell them, oh, it's just your kid have a gaming addiction, and the parents will often say, Alhamdulillah, it's not porn addiction. I thought he was buying drugs online, but this paints that sometimes even with behavioral addiction, the patients can also misuse substances. So you need to be really careful when you interview the patients, make sure that they don't, you know about polysubstance use, but turns out people can also have behavioral and substance addiction at the same time. Right, and the last thing I want to share with you, the structural evolution of games. We've talked about how games are becoming more mobile and ubiquitous, but also, in the game structure itself, we are seeing gambling elements, right? And we call this in the field gambling-like features. There are virtual currencies, chance-based purchases. You would have heard of loot boxes, right? And then event features where not everyone can get it, and there are gambling ads in the games as well. This in the backdrop of an increasing availability of money to adolescents. We have this financial trend of BNPLs, buy now, pay later, that allows the adolescents to have access to money that they don't have, and that is increasing the financial harm that these kids will experience. Previous studies would say, and if you find it in the literature, they would say that purchasing loot box correlate very well to future problem gambling. But those studies are coming from the global north. And more recent studies from China actually shows there's no correlation at all. When you purchase loot boxes, it doesn't translate well with risky gambling in the future. And some suggest that this is because of different policy approach. So in China and many Asian countries, we limit the number of loot boxes that you can purchase. So if the system detects that you've purchased loot boxes quite a few times, they block you from purchasing it anymore, and we don't see that system anywhere else. We did a study also on online gamers who are problematic, and we asked if they've seen gambling ads, and about more than a third of them have seen online gambling ads from the games that they've played. And that's really concerning because most of these participants are very young adolescents, so they've been primed, you can say, or sensitized to this ad since a young age. And when we stratify it, those who see these ads at least once a day are proportionately higher for high-risk gambling, if you categorize it. And I guess this is also another pathway that you can see transitioning from gaming to gambling. It's not just about participating in those gambling-like features, but it's also being exposed to these gambling ads since a young age. And this echoes very well with data from Australia, where secondary students who've been exposed to past month exposure of gambling ads are at least have 2 times higher odds for problematic gambling. And an old study by Hing a decade ago also says that if you are exposed to higher frequency and a longer duration, your intent to gamble is higher. So, and you need to really be careful because these gambling promotions occur not just in the game, but peripheral to the games as well. So you have these online chats for gambling, discords, and etc. And then, people who game loves to watch tournaments. So there's live streams. And when you're watching all those live streams, usually in the right corner or the left bottom corner, you'll see all these gambling ads. It's all grassroots campaign where they attract you to gamble. And you won't expect this to be a gambling type. I don't know if you've seen Candy Crush, right? And this looks very similar to Candy Crush, but this is a gambling, sort of between gaming and gambling. This is a video, I'm not sure if, right, the sound doesn't come through, but you can see it, right? And this looks really like fruit machines in the UK back in the 1980s, 1990s. And I don't know if you've been to Japan and if you see, there's actually some sounds to this. If you've been to Japan and you know pachinko, the gambling industry really designed that with all these visual cues, all the lights and the sounds to really attract you. And that's what's happening here as well. And every time you get a match, right? Every time you get a match, you get some money out of it. And if you want to spin it again because you don't think you can get a match of fruits or whatnot, every time you want to spin, you need to add more money. So it's basically like slot machines, but they just designed it very well. Now, another group also looked whether the transition happens because of interaction with this kind of features. They don't also find it. This is by Spicers from UK. And what they find is that what explains the variance of the transition more is the development of gambling distortions. And we can appreciate before that in gaming disorder patients, they also have this cognitive biases. And some of them also mimic gambling cognitive distortions in gambling, inability to stop, illusion of control. So that might also be a pathway that can explain how from gaming there might be a gateway effect to gambling, and it won't be hard for us to see that it might also be a gateway effect to substance use, because these are really vulnerable group. Right, there's a beautiful paper by Curley explaining all these cultural differences, and they see that in Asia, we see this as a public health concern. The governments have regulations in place trying to protect the people, and there's cultural pressure because parents, we don't see games as a positive hobby. We see it as you're lazy, you don't want to study, you don't want to work, that's why you game all the time, but in the Western countries, they're less coercive, right? And the treatment process for this has been more private sector driven. This is just to give you a picture of it. So some parents in Indonesia, we are a big country, so in one of the village, the parents think their kid have an addiction to game, so they shackle him to the chicken coop for days in hope that he won't game anymore. So that's the reality that we're faced with in Indonesia. And of course, there's some policymakers here. We're talking about precision medicine. When we stratify the disordered gamers, when we get all that groups, we can tailor, make a more precise preventive measure, promotion of health and prevention of disordered gaming. And that really, I think, translates well. When you want to do actionable precision medicine, at the background, you're doing all this panomic study. But with policymakers, my experience is that they like the low-hanging fruits. You need to give them results, every now and then. So while you're doing that in the background, I think this is a very actionable precision medicine that you can do. So all in all, you really need to critically evaluate the tools. The tools might psychometrically be sound when you adapt it, but when you implement it, sometimes there's this qualitative differences that you will not pick up when you do the psychometric assessment. And I also understand that the WHO plans to do an international screening and diagnostic measures for gaming and gambling disorders, and we'll see whether that translates to our regions very well. And we need to assess comorbidities and co-occurring either, with behavior and substance abuse, because that will change how we assess and treat the patients. And psychological approaches should be tailored with depending on the culture and the problem that you're faced with. And of course, we need to investigate novel treatments. We're doing currently TMS that's hopefully will be more efficacious for the patients. And we need to liaise with policymakers for frameworks to safeguard, promotion of health and prevention is much better than treating. And of course, I think it's very important in a forum like this, where we can collaborate internationally and provide a framework as an overarching guidance. With that, I want to acknowledge the team back home in Indonesia, my mentor, Professor Christiana, and thank you, everyone.
Thank you, Dr. Lee. I would like to open the floor for questions. This is very insightful, Dr. Lee, indeed. There is a growing, in Naufar, we see a lot of comorbidities with our patients. And I think one of the reports came last year, 70% of one of the neighbor countries, people identified themselves as gamers. So it is a public health concern, millions of people. Dr. Nader, yes, please.
Assalamu alaikum wa rahmatullah. Thank you so much, Dr. Lee, for your nice presentation. My concern is the positive side of gaming, because there is a lot of studies supported that when children studied about 2,000 children went through gaming for 3 hours per day. They perform better than that who don't use gaming, especially in the cognitive function, impulse control, and working memory. How can we see the positive side from gaming, because all our kids, they are using it? Thank you.
Yep. Thank you very much for the question. It's also a concern before we before the WHO formally categorized this disorder, whether we're over pathologizing certain behaviors, right? I game myself. I think it's fun. It's a nice. I don't need to think about work and everything when I game, but with kids, sometimes you need to be careful. Also, in studies like that, they design the game in such a way that they think it can confer benefits, right? And I think that really speaks to how we need to regulate the industry and have a framework in place that ensures that the games that are being put out there and are being played by the kids, by the adolescents, are actually beneficial, right? And I guess motivations coming into playing the games would also be important, as in gambling, right? We've known about the pathway models for a long time. So yeah, I think as you can see, the evolution of gaming, this gaming industry is a multi-billion industries, right? They hired psychologists. How can we design the game to be more immersive? How can we ensure that they play 24 hours? That's dangerous, right? And I think it's how we work together as scientists, researchers, clinicians, and policymakers to put safeguards everywhere. And games can be okay for many people, but that does not disregard that there's a population that experience harm and impairment from their behavior. And I guess the idea is that by having this, then we can assess and we can help them.
Professor Mohammed.
Thank you very much. It was really, really interesting. Because I was thinking of my grandchildren and my children growing up. When you were talking, and do they have all these criteria or not? And, So, but you talked about how different, addictions, like the gambling, the gaming, and substance use disorder, that they are interconnected because of the how the system works. How in treatment, if you have somebody with all this, how are you going to approach?
Yeah.
Which one? Is it you say, okay, like people say, Alhamdulillah, you remove the substance use disorder and say, okay, go gaming. You substance. This is my first question. There is another question coming up, but after I listen to...
Okay, well, that's actually making me nervous. But so in our center, it's quite different from Naufar, right? We only see, well, we don't, but the patients that can be insured in our center is only those with comorbidities, right? They would have either another mood disorders or personality disorders. So all the patients that we're seeing are actually having co-occurring disorders. And how we treat them is, well, we manage all the disorders at the same time as well. And I believe that's what, as Dr. Rama said, have been done here as well. So when we see that the patients have gambling and substance use, as we do see now in our inpatient units, we tackle them both at the same time. So we devise with the patients, like through assessments, which part of between all that is giving you more harm and more impairment, right? And then we also assess their readiness to change, their stage of change, which will be different for the behavior, for the substance, right? And we want to make sure that they have the self-esteem that they can be better. So we would first go with the one that we assess is more actionable, the one that will see improvements quicker. And we go with that first, and then they have the self-efficacy, their self-agency becomes better, and then we'll go through with the rest. And this is a combination of inpatient and outpatient setting. So after we've been through with them inpatient, and then we have them in outpatient.
Because it seems to be you tackle the basic mechanisms that it's about addiction,
Yep.
whatever the agents are there.
Yep.
That's bring me a question, because we really had a lot of arguments in this institution, for example, about smoking. If we let's say we treat the other ones, but we say, okay, you continue smoking. We still kept an agent there that's keep that dopamine cycle going on. Correct?
Yes.
Do you think maybe we should review our policies on this? Seriously, I mean, it's. I think because that's what I'm getting out of. What's your logic in that? And I don't know. We needed an independent view. I mean, nobody gonna do anything to you. I mean, you're gonna leave us and go.
I hope not. I hope I can still get to the bus back home. But yeah, that's a very heavy question. In Jakarta, we have a lot of centers that manage addiction patients. Our hospital is not the only one. I understand that in some other centers as well, smoking for them is still allowed in inpatient. But what we do in our center is we completely ban them, right? So when you come in, and that's the commitment that we have with the patients. It's not easy being in our inpatient ward. You don't have phones, you don't have TVs. It's not like this here. All activities are done as a group in a common area. So it's really not easy, but it's one of the ways that we think will help in their recovery journey, because we're really showing them through the appropriate support that you can actually get through, say, your craving, right? It will go up, but it's like a wave, and it will go down again. So you just need to serve the urge, and it's really I think harmful if we in that process, and then they open up their drawer and lit a cigarette, and that doesn't send across the right message. Well, that's in our center.
Great, thank you. Thank you, Dr. Lee. Round of applause for Dr. Lee.
All right, our third guest speaker will be Professor Giuseppe Passane. Professor Giuseppe is a clinical psychiatrist who had personally and as a coordinator of a group carries out intense research activities in the field of clinical neuroscience, clinical psychopharmacology, physical therapies, and drug and behavioral addiction. He is currently visiting professor at the University of Hertfordshire, guest professor at the Beijing University of Chinese Medicine. Prof. Persane authored over 230 articles and organized over 50 national and international scientific conferences. Professor Giuseppe will take us through the NPS-induced psychotic, new psychopathology, and treatment strategies. Please join me in giving a warm welcome to Professor Giuseppe Passane.
So good morning to everybody. First of all, my warmest thanks for the invitation to this symposium. So interesting, so well organized. Many warm thanks to the organizer. So this is a very current topic on the interface between addiction and psychiatry. I am a clinical psychiatrist, and so my speech will focus on the clinical point of view of the consequences of the use of substances. So I will not go in depth with respect to the single substances consequences, but with respect to the general mental implication and psychiatric change we are facing in this historical moment. We are facing an important change, an evolution in mental disorders. The traditional diagnostic criteria, the traditional diagnostic categories don't meet anymore the reality of our clinical experience. The real cause of this is the widespread use of substances that are changing psychopathology and the mode of presentation of the single diagnosis. This is a general landscape scenario, a scenario of the use of cannabis, of substances worldwide. Of course, there are many regional differences in the world, like those we just heard by Professor Lardi, but this is a general overview of the present situation is that to the old substances, cocaine, cannabis, opioids, alcohol, are continuously added new substances, new classes of drugs that are generally included in the category of NPS, but we have hallucinogens, inhalants, dissociative, we'll see in depth. But this is a scenario that includes thousands of new molecules, continuously new, continuously replace each other. It is very difficult to follow it, to have in mind a clear scenario of this. What are the topics of my presentation is this. There is a weakness of all concepts like those of substance use disorder or dual diagnosis. Why? Because the complexity is increasing. We'll see better later. There is the need for new criteria for describing and going in depth about the nature and phenomenology or mental disorders is due to the increased variability. Psychopathology is changing not for quality, but for complexity, because different psychopathology dimensions, psychotic dimension, mood dimension, behavioral dimensions, present themselves all together, not just as before, clearly defined in single disorders. We have to deal with specific mental, acute, and chronic consequences of the use of substances. The symptoms are changing. The role of personality disorders is getting increasingly important. The perfect basis for the development of mental disorders, and we need new treatment strategies more adequate to the complexity of the present psychopathology. Very, very quickly, substance use disorders. It perfectly describes the behavior of the consumers, but no longer the psychopathology. It describes the craving, the need to consume substances, the harmful behavior, and so on. But doesn't go in depth respect to the complexity of psychopathology and respect to the changing in this complexity. And it is valid just for major classes of drugs. It's not valid, for example, for MPS, for novel psychoactive substances. There is some limits in the use of the concept in the present psychiatric situation. Dual diagnosis, two different mental disorders in the same time in the same person. It is a statistical concept. There's a coexistence of two disorders, but it is a weak concept because it doesn't make any reference to the reciprocal pathogenetic factors involved in the appearance of the two disorders together. It is a very weak concept by respect to the interpretation of the disorders, on the two disorders, a very weak concept with respect to the possibility to manage the disorders together. It is a concept that has been used very widely all worldwide, but the increasing complexity of the situation makes it increasingly less useful than before. In this scenario, we have to take into account the emergence of novel psychoactive substances. There are not one class. There are a lot of classes of substances, very important, with a very high potential of inducing psychosis and represent the real novelty of the last years. They are galaxy. We have thousands of new molecules, a lot of different classes. Phenethylamine, methamphetamine, synthetic cannabinoids. You see a lot, not thousands of molecules belonging to dozens of new classes of psychoactive drugs. This is the present situation. To the old scenario of cocaine, opioid, cannabis, we all know it is very, very important, of course. But we have the new appearance of this enormous class, the increasingly active, potentially dangerous, mentally dangerous class of pharmacies. It is a galaxy. It is a galaxy. It is really very difficult to be oriented in this situation. It is very difficult to know the molecules that are continuously replaced before they are recognized and declared illegal. A series for family of drugs. This is an example of the statistical distribution. You see the psychostimulants are obviously the more important, methamphetamines, catechins, and so Captagon here, and so on, hallucinogens, and so on. But the statistical is very different. The epidemiology is very variable with respect to regional situations. For example, in Italy, Europe, we have a real epidemic of use of cocaine, enormously, associated to death of alcohol and cannabis. That is not the same in this region, for example. every region of the world has its specific distribution of the use of class or substances. But this is the characteristics of the phenomenon. Chemically, by chemical point of view, they're very different. Just the one matter that the one common feature is appartenance to this gender class, but they're very different each other, of course. Amphetamines, derivatives, opioids, synthetic cannabinoids. By chemical point of view, they're completely different. Thousands of molecules, they continuously are replaced. They are built with a specific objective to create consciousness alterations and psychotic states. This is a real novelty in this field. The aim of the producers of these substances was to create drugs able to induce psychotic states, acute, transient, in theory, and consciousness alterations. This is the main unifying profile of these classes. And the distribution, it is a very widespread distribution, of course, also by direct routes, but especially by online pharmacies, by web, that makes it very, very difficult to interfere, to manage it to some extent. Psychiatric implication. The mechanism of action is continuously changing, and we'll see later. We have to distinguish between acute intoxication, the acute state immediately following the consumption, and the chronic effect, the disorder, the mental disorders following over time the use of substances, with a very high and specifically searched potential of induced psychosis. I repeat, it is the most typical profile searched by the producers of the substances. Of course, every class of drugs has its own profile. The most important phenomenon is that of polyabuse. It's very difficult to find one subject consuming only cannabis, only amphetamines, only synthetic cannabinoids. Every person consumes more than one. And this makes it extremely difficult to recognize the effects of the single drug and to manage the single consequences of the individual drugs. We have to treat polyabusers that, by a psychiatric point of view, are the most complex situation we can imagine. That's a very synthetic summary of the neurochemical actions of these families of drugs. Most of them increment dopamine activity, of course, amphetamines, cathinone, all the psychostimulant substances are, of course, obviously dopaminergic. And you know that the dopaminergic action is the main basis for the development of psychotic, acute or long-lasting psychotic states. CB1 receptor agonists like synthetic cannabinoids and like cannabis, of course, THC receptors. The stimulator or the agonist of the 5-HT1 and 2 receptors that are proper of the hallucinogen family, the old LSD, the new hallucinogen, tryptamine, herbal hallucinogen, psilocybin, and so on. And NMDA receptor antagonists like the so-called dissociative drug ketamine that now used as a drug, but in its origin a very important substance of abuse, phencyclidine-like, and so on. Kappa-pure receptor antagonist, a galaxy, of course. Taking into account that all these effects are very often shared by many substances. It's very difficult to find a substance that has just one of these. They has a series of effects differently combined in different situations. Just a very, very quickly overview the effects of synthetic cannabinoids, hundreds of thousands of molecules, CB receptor antagonist, Catenones so active in induce acute conscious alteration psychotic states. You see also before that the long-lasting effect of synthetic cannabinoids is persisting psychotic disorder, the so-called schizophrenia, an indistinguishable disorder from schizophrenia induced by chronic use of cannabinoid synthetic that persists also over the withdrawal of the substance, practically a schizophrenia induced by the drugs. Cathinone with a continuous paranoid ideation also after the withdrawal, and a lot of family. Methamphetamine is so important in inducing psychosis, induce paranoid ideation, and very important in induce the most severe behavioral alteration, the most severe cases of aggression are due not just to more than cocaine, to the use of methamphetamines. They are the drug the most directly involved in dangerous, harmful, aggressive behavior. Ketamine, we have to consider the long-lasting effect of ketamine, not medical ketamine, and of PCP-like substances, phencyclidine-like substances, is induction of a completely similar state to schizophrenia. A schizophrenic feature with positive, negative symptoms, long-lasting, also after withdrawal by other drugs, hallucinogens, and so on. So we have tried to propose a distinction between the single family of NPA, single family of psychoactive substances, and prevalent psychopathological feature, but it's just a diagram. The reality is very complex. It is not so clear the differentiation we can get. But it is an attempt to say that ketamine is more linked to dissociative experience, MDMA, to cognitive decline. Cognitive decline, we see, is a central feature of all the mental consequences of the type of classes. Schizophrenia-like disorders, the two synthetic cannabinoid, and so on. It's not so clear, of course, but this is the prevalent type, the prevalent forms or psychopathological consequences of the use of different classes of drugs. So, arriving at the clinical point, we are in front of a crossroads. The crossroads when the use of substances can have two different directions. The induction of new mental disorders in subjects that were not before. They didn't present before any type of specific disorders, and increasing more severity and a changing in psychopathology or in subjects that were before affected by mental disorders. This is the real life situation. Most of our patients, our psychiatric patients, start to consume drugs after their psychotic, their mental onset. And so we face with interaction between the presence of mental disorders and the changes in these induced by the substances. It is an extremely complex situation that we can summarize in this way. We can see to new groups of new psychopathology features. For example, the so-called schizophrenia, synthetic psychosis, lethargic sarcoma, different type of consequences of hallucinogen use, and so on. And in the same time, we see the changes in persisting psychopathology. For example, in bipolar patients, for example, in schizophrenic patients that assume substances are no longer the patients they were before. They change in their course, in their treatment response, in their symptom profile. And with this new situation, we have to deal every day. It was a change. There was where these situations exist is the world of the net, the world of psychonauts. Most of these substances are found here, not just on the street, not just in the pharmacies, but in the net. And it's very important to underline the substance abuse and substance addiction is very often linked to other forms of addiction. For example, to the gaming behavioral addictions, gaming disorders, internet disorders. It is the same world. The same people are the psychonauts that depend, addict from the net, addict to the farm, to the drugs they can find on the net. Just for example, schizophrenia, they are reminded a clinical form of psychosis practically not distinguishable from schizophrenia, chronic, long-lasting, induced by the use of synthetic cannabinoids, very potent substances, specifically created to stimulate the CB1 agonist, so that is to induce psychosis. And this psychosis very often remains, persists after all the withdrawal from the drug. It implies also a very important phenomenon of cognitive decline. Cognitive decline belongs also to schizophrenia, psychotic disorders, but psychotic disorders induced by drugs present a very quick, a severe cognitive decline just from the onset. It is a differential criteria with respect to the primary psychosis. And the treatment resistance is very difficult to treat a patient when he consumes, when he still consumes drugs. Synthetic psychosis is a new concept linked to the possibility to, it refers to psychosis induced by synthetic drugs. So very, very wide, very field. What is important to underline, it's not just probably psychotic symptoms, but the consciousness alteration, typical. A primary psychosis hasn't consciousness alterations. A synthetic psychosis, yes. This is a clinical differences. Behavioral alteration, aggression, mood swing, more important, wider than in primary psychosis, or conversely, mood flattening, cognitive decline. This all is obviously more severe in patients previously affected by severe mental illness. This concept of synthetic psychosis is very wide and not so well defined. But it's very important to understand the structural differences between primary and secondary psychosis. They tend to make a comparison. You see crepuscular consciousness that is not in schizophrenia, activity, aggressiveness, impulse discontrol, and a series of psychopathology features that can be used as to differentiate the two forms of psychosis. What is important for me to underline is the mood flattening, cognitive impairment. Synthetic psychosis implies the cognitive decline soon, very early with respect to their onset. More quickly, more before than what happens in primary psychosis. If you consider that very young people use these drugs, we can understand how serious are the consequences. In very, very young age, in early age, they start a cognitive decline that can go on over their life, and even more severe according to the continuation of the consumption. Let's say the psychoma, it is a difficult concept. It refers to the concept of mental automatism of the old psychopathology. Extraneous, a foreign body in our mind, more often following the use of hallucinogens on cannabis, a second mind in our mind that acts automatically. We listen, voices, hallucinations, thought we wouldn't have, but we have. A very, very complex situation, enormously variable among people. Hallucinations are the most frequent features. That's a model. Something extraneous, a foreign situation, foreign activity in our mind. It very often follows hallucinogens, the old LSD, new hallucinogen, ayahuasca, psilocybin, For example, high doses of cannabis, synthetic cannabinoids, all drugs that are able to induce a long-lasting consciousness state altered. This is classic the hallucinogen-induced hallucinatory persistent disorder, the continuation of chronic or recurrent hallucinatory states in subjects that have previously consumed hallucinogens. Also in this case, there are a lot of diagnostic criteria, but everything is still widely undefined. Very difficult to find precise criteria to define these clinical situations. And the second, we're at the crossroad, the second direction, not just the psychotic drug-induced psychosis, but the use of drugs in subjects that were psychotic also before. They were bipolar before. It is widely underestimated. All our patients, most of our patients consume drugs, but we don't know exactly. It's very difficult to understand, to know which drugs, how long, which dosages. It is a very obscure field or behavioral field. The most common consequences is the acute exacerbation of previous psychotic symptoms. The clinical profile is strongly influenced. The course of illness, the treatment response. These are the main topics of this field. The treatment is very difficult or not possible to treat in an inadequate manner psychotic patients that assume substances. The effect of substances is stronger than of our drugs, of our medications. And so the treatment resistance is a typical feature of these situations. Chronic course, you see, specific clinical features and treatment resistance. These are the main factors affecting this kind of profile. And this is the biggest. This is the real crossroad. New psychopathology features that may be acute, the acute stage for low with the consumption, or chronic, that is mostly in our interest. The original new psychopathology disorders, so new potential psychiatric categories. So we have to differentiate primary psychotic disease, substance-induced psychosis, and psychotic illness which come out with substance abuse. It's very important in our real-life activity to understand, to differentiate the one in each patient, one of these three categories. This is the question. Is schizophrenia the same after consumption of NPS or other psychoactive substances? A schizophrenic patient that consumes psychoactive substances remains the same? The answer is will be not. Because some psychopathology features like consciousness state alteration, mood swing, behavioral alteration, rapid cognitive decline, get worse after the use of psychoactive substances, and to some extent characterize the next course of the illness. The same for bipolar disorder. Is a bipolar patient the same after the consumption of drugs? Not at all. Because also in this case, the same new features seen in schizophrenia are even more present in bipolar. This is important. We'll see that later. The role of personality disorders, specifically of bipolar or borderline personality disorders, that is an undefined category. But represent the perfect basis for the transition from personality disorders to a real mental disorder. Most of the patients we see are personality disorder, borderline personality disorders that after consumption of drugs become psychotic, become bipolar. A real vicious circle is created. More severe personality disorders, more use of drugs, origin of psychotic symptoms, and so on, and a circle.
Yeah.
So I'm going to close, to give time to some discussion. This is my personal opinion. The use of NPS, general classes, in schizophrenia, in bipolar, in borderline personality disorders, leads to a common outcome where the specificity of previous illness decrease, and we see a common psychopathology state with rapid mood swings, behavioral, consciousness, cognitive, a unique onset, a unified onset of the interaction between mental illness and substances. The treatment, we have no time, of course, to speak about the specific treatment of single situation, but we have to take into account, we have to treat acute intoxication, acute consciousness state, the somatic consequences. We have no time to speak about them. It's very, very important to treat. We know how many fatalities occur during the consumption of this drug. The first psychotic onset, the origin, the onset of psychosis just after the first use of drugs, the chronic, paranoid affective psychosis, long-lasting chronic, the follow the use, and the cognitive decline. I should add, the behavioral alteration that constantly accompany all these symptoms. We have to treat singularly every one of these situations. Of course, we have no time to speak about it, but every antipsychotic, mood stabilizer, sedative drug can be used in the treatment of individual patient. Precision therapeutic, you will see, it's very, very difficult to get a real personalized treatment. This is an objective, but we still lack the objective parameters to understand. Final question. The precision medicine in MPS-related psychosis. This is the aim is recognize the specific mechanism of action and clinical effect of individual drugs. The drug very, very complex. The objective should be targeting the single symptoms due to the individual drug. We are clinically very, very far to get this objective. For a lot of critical issues, we don't know exactly the real mechanism of actions of both the drugs and their interactions with the neurobiological basis of mental disorders, the polyabuse, the persisting drug consumption, the persisting of addictive behavior that makes it quite impossible an adequate treatment of the present disorders, and the difficulties in discriminating the effect of the drug by respect to the effect of the primary cause of illness, which are the take-home message we can consider at the end of my presentation. The scenario change. We have an enormous number of new very potent, very pathogenic drugs continuously changing. We have to know this. This should be part of the competence and of experience of every psychiatrist. It is not yet. I speak about my situation in Italy, for example, but this is a competence that now is not yet so important, so that how deep, how it should be. New forms, psychiatry is changing, mental disorders is changing. Our diagnostic categories, our clinical presentations are no longer those that were 10 years ago, 15 years ago. Psychiatry today is different with respect to the past. We need time to go in depth, to study, to educate people, psychiatrists in this field. Psychiatry is changing. One time we have the patients admitted in psychiatric hospital. Now we have psychonauts. The world is changing, psychiatry is changing. It is totally mandatory for all psychiatrists to be updated on this field. That is really certainly the field, the present field of psychiatry, and certainly the future field of psychiatry. Thank you very much.
Thank you so much. Thank you, Professor Giuseppe Pessane, for the interesting talk. We could take only one question because of the, we'll go first with, yeah. Please tell us your name and organization, and you can tell us your question.
Yeah, John Marsden, UK. Ciao, Giuseppe. Grazie mille for your amazing presentation and an almost astonishingly difficult topic to conceptualize. And it made me focus and think on various directions. And I guess one thought that I wanted to ask you about was, there are certain, I mean, you mentioned dissociative anesthetics. Let's name one, ketamine. And it seems to me that we have to be very granular and precise about the drug, the formulation of it, the intention of using it, be it, so the formulations of ketamine, oral, extended, which has an evidence base for rapid depressogenic benefits for people with major depressive disorder, perhaps an emergent evidence for robust psychedelic doses, we will see. So then we've got the potential for medical or, frankly, recreational use. And I just wondered if what emerges from this talk, first of all, a need perhaps to focus. We made a point yesterday about how it's hard to have so much in working memory and we have to just focus. But I wonder, for example, with ketamine, whether we are now faced with the need to look at persistence of dissociative effects that may be harmful, that we need to use that, and speaking to the point of our wonderful meeting here, that maybe there are probes or phenotypic indicators that others can tell us about that would then make ketamine contraindicated, either for depression or indeed for addiction. So I wonder if, I guess briefly, there might be a reflection on clinical applications that would guide the research agenda.
You focus on the most critical situation by the point of view of a clinical psychiatrist, the long-lasting effect of the drugs, and the born of new psychiatrists phenomenology. That's difficult to say just about phenotypic. To speak about phenotype, to refer to find some specific etiological factors, we don't have a so clear idea. You know, the complexity of the situation is too vast. But it is the name of the research, of course. The problem is that the research is quite difficult. We still need some pharmacogenetic help, for example, but we don't have. Theoretically, we can speculate to find some pharmacogenetic find. We have it for example, for cannabis. No? We know that there are some COMT allele in the user makes patients more at higher risk for development psychosis, but just for cannabis, not for synthetic cannabinoids, for example. We don't have anything similar for any other substances. This is the real situation. But it's very important because we are dealing with a new problem of chronicity. This is a real problem, not just the acute states, the psychotic states immediately following the consumption. The real problem for psychiatry is the new chronic mental disorders so closely related to the use of substances. In patients, in subjects not psychotic before, not bipolar before, and even more serious in patients that were already bipolar, where the clinical feature, the clinical course becomes quite obscure. This is the real life experience we all have. We all led work in the field of psychiatry. Your question is quite centered, but my answer is quite not centered because the situation is so complex and so different. I think we have to study, of course. We need a more in-depth education to study, to educate all the psychiatric operators, the psychiatrists, because this competence becomes crucial, central for all psychiatrists. I repeat, my opinion is that this competence is not yet so adequate like it should deserve.
Thank you so much, Professor Giuseppe Persani, for the interesting presentation.
Thank you. I think the professor had a slide that says dual diagnosis, unlikely clinical concept, and that would make it difficult for Dr. Rehan to talk about dual diagnosis and comorbidities in the next session. So our next session is about psychiatric comorbidity in patients with SUD. Is it the exception or the rule? And it's an honor and a privilege to introduce my senior colleague and one of my mentors here at Naufar. I think you have to get the helmet ready because last year I was with Dr. Rehan in the ISAM conference. And if you don't know him, he's a fan of motorbikes. And I had the privilege to go on a nice ride in Istanbul. So I hope we're going to enjoy his talk and we're going to have the answer to the professor question. Dr. Rehan Siddiqui is the Assistant Chief Medical Officer, Senior Consultant Psychiatrist at Naufar, holding a specialist certification in SUD. And Dr. Rehan has a Master of Science in Psychiatry from Cardiff University, had received multiple awards, including the Research Prize from the Royal College of Psychiatry, West Midlands. So he speaks 6 languages, and he brings a wealth of experience from practicing medicine in 5 countries. So he has been a trainer and a tutor for the Royal College of Psychiatrists and has established the residency training program for substance use disorder treatment in Qatar. Please join me in welcoming Dr. Rehan Siddiqui.
Mic'd up? Hello, assalamu alaikum everyone. How's everyone doing? It's been a long morning. There's coffee at the end of this, so just hang in there. Okay. So, translator, I'm coming in nice. Translation? Great. So, I'd like to get acknowledgements out of the way first. First of all, thank you, Professor Muhammad Dr. Khalifa Al-Kuwari, for the vision to make a conference and a symposium like this possible. Really grateful for that. I would also like to thank the IREC for putting together such a comprehensive, beautiful program. Prof. Jalal, Annette, for your guidance. I would like to thank the Chief Operating Officer's office. Mr. Saleh Al-Muhannadi is not here, but his team is all here. Thank you for your work. And I'd be remiss not to mention Diana, Fatima, and Miriam, and all the countless volunteers and everything. I would like to thank the guests, our guest speakers who have come from far and wide, given us time, and have come to this little oasis of compassionate care that is evidence-led and precision medicine-based. I say oasis because I wanted to say that the term Naufar means water lily in Arabic. So I thought I'd sort of throw that in there sort of to say. So before we start, my apologies. It may be because I'm amongst friends or a combination of nervous excitement, caffeine, and sleep deprivation. I might digress and say some political sort of incorrect things, but amongst friends and sort of, Mr. Muhammad Al-Muhannadi has just left. He's our legal advisor, so I'm hoping he'll save me if there's any issue. So, without further ado, I have no actual or potential conflict of interest, but I do have a deep, dark secret. One of the slides is completely artificial intelligence generated. So you would need to guess which one of those slides I put in has been generated by artificial intelligence. So let's see if people can guess which one it is. Right, these are the learning objectives. At the end of the presentation, inshallah, you will be able to define independent disorders and co-occurring disorders, understand the relationship between co-occurring substance use disorders and other mental health disorders, understand the role of stress and trauma on the co-occurring disorders, and understand the evidence base for treatment approaches to co-occurring disorders. Overview. So this is what we'll go over. Definitions, epidemiology, both community-based and from clinical populations, association between common SUDs and psychiatric illness, factors affecting comorbidity, approaches to treatment, take-home messages. Again, this is, I'd like to share, sort of like I said, amongst friends, that this was a really difficult presentation to put together in the 25 minutes, red card, green card, because basically what the task was to basically distill 25 years of my sort of clinical experience and a vast evidence base into a 25-minute presentation. So it may not be fully comprehensible, but I'm hoping sort of we get the messages across. So sort of the discussion. So, question and answer time. So, I love doing this. So, I'll ask audience the questions. If you think it's true, raise your hand. If you think it's false, I'll give you an opportunity to raise your hands as well. So, severe alcohol use disorder is most likely associated with depression. Who thinks it's true? Raise your hands. Who thinks it's true? Okay, excellent. Who thinks it's false? I don't want people sitting on the fence. We're not going to sort of, take you to court or something. Come on, let's join the game. Okay? Nearly half the patients entering SUD treatment have a psychiatric disorder. True? How many people think this is true? Great. How many people think it's false? Okay, we have people who think it's false as well. Dual diagnosis and co-occurring disorders mean the same thing. Who's for true? Who's for false? Good stuff. Evidence supports sequential treatment of mental illness followed by treatment of SUD. True? Who's for true? Who's for false? Great. Okay. At the end of the presentation, we shall come back to these. So, first, independent psychiatric disorders versus substance-induced psychiatric disorders, and then we'll come to the co-occurring disorder bit. So, criteria. Onset has to be, so to say that it's an independent psychiatric disorder, onset has to be prior to lifetime onset of SUD or substance use, and or full criteria for disorder during periods of more than or equal to 1 month of sort of abstinence without heavy substance use, and or symptoms preceded substance use by 2 weeks. So sort of to summarize that, there needs to be clear daylight between the onset of the substance use and the mental disorder. Okay. I've put DSM here. Not my favorite diagnostic statistical. I don't like it. And again, I'm like Prof. Muhammad. I love telling a story. It's basically a North American idea which has been foisted upon the world, and we're forced to follow it. Maybe, Hamad, maybe what we should do is we should tariff it. We should put tariffs on it. And then sort of say that if we have to use it, you have to pay a tariff. And for the most beautiful word in the English language, people should probably tell the person who uses this that the word tariff actually is Middle Eastern in origin. And it was the Ottomans who introduced it to the Italians, so Professor Giuseppe. So sort of like that's how the word tariff came about. So maybe we should tariff the word tariff as well. Anyway, long story short, there has to be prominent and persistent psychological symptoms that warrants clinical attention. Temporal relationships, which means that symptoms develop soon after substance intoxication or withdrawal. And the intoxication or withdrawal must be capable of producing the symptoms. And finally, you shouldn't be able to better explain the symptoms by an independent disorder. And symptoms persist for substantial period of time, 1 month, around 1 month after cessation of use. So we said there had to be clear daylight for the previous one. In this, it should be very confusing. You should not be able to sort of tell them apart. So this is sort of like if you were to sort of completely sort of distill it, you should be able to differentiate them previously. Here, it should be muddy. So that's basically what we're saying. Finally, what the DSM says, again, is that there is no unique category for co-occurring disorders. So patients should have either 1 or more mental illness, or they should have 1 or more substance use disorder diagnostically. So they should meet the diagnostic criteria for both. So for the visual learners, middle bit is basically what we're looking at. So that's the co-occurring disorders. So people who have both and the ones who overlap, is the subject of today's talk, and this is what we're going to spend some time discussing. How big is this problem? It's that big. Again, we have information from North America, from the USA actually. 21.5 million, that's 8.4% of the adult population in the USA has a co-occurring disorder. That's huge. It's huge when you think about it. And around 50% of adults with severe enduring mental illness have co-occurring disorders. Okay? So that's the general population. So we said we'll look at clinical populations. So mental health disorders in patients entering SUD treatment. So let us say major depression. At the time of entering treatment, current history of around 10 to 20%, lifetime history of about 20 to 50%. PTSD, current, which means at the time of starting treatment, about 20 to 50%, lifetime history of about 30 to 50%, and ADHD again, 14 to 23%. So big numbers. And there is a study which separates alcohol and drugs. So I would like to sort of say that sort of on the sort of left you have all the diagnoses and the likelihood that you will have an alcohol association with alcohol or drugs. I would like to draw your attention to bipolar disorder, alcohol and drug, through the roof. Okay, so that's the one that actually is the take-home message, that much stronger associations with bipolar disorder and alcohol and drug use. So let's explore alcohol a bit longer. Let's look at what happens with alcohol and co-occurring disorders. So first of all, I'd like to sort of dwell upon the fact that if you have a more severe alcohol use disorder, you're more likely to use other drugs as well. So that's the first point. So you're likely to have a co-occurring substance use disorder with alcohol use disorder. So mild, moderate, severe, you can see that on the x-axis and on the y-axis is the odds ratio of having other SUDs. You can see that there is a linear progression. You will see a lot of linear progressions as we go along. Right. So you can see that when you have mild alcohol use disorder, your risk of having any of mental illnesses is relatively lower, but as it becomes more severe, the risk becomes higher. So severity of alcohol use is actually relevant. And, so what does alcohol use disorder to people who haven't had depression? And you can see that on the x-axis, again, number of alcohol use criteria met on the DSM, and the odds for first induced depressive disorder. So this is alcohol use disorder inducing depression. So you can see pretty linear. As you have more criteria, you're more likely to get depressed. So if you already are depressed, what does alcohol use disorder do to the course of illness? Well, I'm glad you asked, because this is what it does. It makes treatment a lot more difficult. Patients continue to sort of suffer with having persistent anxiety or depression when they have more than 6 criteria of alcohol use disorders met. So it increases your risk of developing depression. It makes it more difficult to treat depression and anxiety. Anxiety and depression persist for 2 years when you have severe enough alcohol use disorder. What if the shoe is on the other foot? What happens to relapse of alcohol when you have depression? Again, it's exactly sort of what you expect. So if you basically have depression at the time you started treatment for alcohol use disorder, if the diagnosis was at the time of treatment, which is when you enter sort of SUD treatment for alcohol, you can see that having depression actually increases your risk of relapse. And the difference is quite stark in women. I'd like to sort of say that. You see, the women flank the men. So women without depression, much better outcomes. Women with depression, worst outcomes. Men with depression, sort of, still there is a difference, but not as marked as in the women. So again, you have to be sort of careful about gender sort of differences as well. So why are we having these sort of almost intermingling and so difficult to separate sort of these things? And you'd think there has to be a genetic basis. Is it the same illness? Is it a continuum? Are these discrete entities, or is it all part of the same spectrum? Well, what we know from genome-wide association studies is that there is a significant overlap of genetic factors involved in AUDs and mood and anxiety disorders. So maybe in the future, when we sort of are able to identify these, we can use precision medicine to sort of manage them as well. And there seems to be the risk is conveyed genes engaged in neuronal development, connectivity, and signaling, but the precise mechanisms are not known. I don't know, maybe fMRI can unlock these keys. So watch this space. This is a well-known sort of topic, so I'll only sort of spend one slide on it. We all know that cannabis use increases the risk of psychosis and schizophrenia significantly. But the risk is dose dependent, which means that the more cannabis you use, the more likely you are to develop schizophrenia and psychosis. You develop these illnesses quicker. The symptoms become more difficult. They are sort of more pronounced. Your functioning sort of drops. Actually, your IQ scores also drop. There is actually cognitive decline associated with schizophrenia, psychosis, and cannabis, sorry. There is an increased risk of relapse, of course, and we can all see this. Patients tend to stay in hospital for longer when there's cannabis and psychosis or schizophrenia involved. So it is quite toxic. I'd be remiss not to talk about the relationship between stress and trauma and co-occurring disorders. So there is a large body of evidence that supports the role of stress in initiation and maintenance of drug use. Animal studies shows that stressors initiate drug self-administration. They put sort of mice in an experiment, and they gave the mice the ability to self-administer drugs. And when they stressed the mice out, they went on taking drugs. They kept on sort of initiating drug use, self-administering. So there is a well-documented sort of relation there. We all know this. Person with SUD, stress increases craving and drug use. We've all sort of seen this in clinical practice. And high correlation of stress, trauma, and SUDs on adverse childhood events and post-traumatic stress disorder. Again, a minute on adverse childhood events. I don't think we spend enough time on these. I would make this a mandatory part of history taking. If I was a trainee, if I went back to training, I would like this to be a mandatory part of my history taking. We did not focus on them as much as sort of taking a history or a narrative. This is really important stuff. So again, it's been there since the mid-90s. And the higher the ACE scores are, you have increased on alcohol use disorders, depression, and illicit drug use. These are the topics for today's consideration. But suicide attempts, multiple sexual partners, STDs, intimate partner violence, ischemic heart disease, liver disease, COPD. I mean, the whole thing is like, it's truly pervasive. There is no sort of biopsychosocial part of a person's life that is not affected by adverse childhood events. And to drive home that point, it's a busy slide, apologies, but I would like to draw your attention to the sort of linear progression as the ACE score increases. So, ever had a drug problem? The higher the number of ACE score, the more the sort of morbidity is. Same for ever addicted to drugs, for injection, and the percentage of alcohol use disorder also. Linear. Okay? Fascinating. So, PTSD and risk of developing SUD. Veterans with PTSD diagnosis, 3 times higher than similar population. So this is not compared to the general public, 3 times higher in Veterans Affairs hospitals. So there is a 3-time increase in SUD and PTSD diagnosis. Adults diagnosed with PTSD, 4.3 times more likely. Young adults with PTSD, almost 5-time increased risk of developing SUD within a year. Within a year, you have a 5 times higher risk of developing an SUD if you're a young person. Again, some misconception that veterans have higher rates of PTSD. You can see that comparatively, veterans have lower rates of PTSD, but the general public is has a much higher risk. It might be because of the preparedness theory that these people are actually prepared for what they're going to face, so they're less likely to develop PTSD. Right. What do we think contributes to comorbidity from the evidence that we have seen so far? This always goes wonky. Anyway. So the arrows kind of, they kind of shapeshift as you send the presentation across platforms. Anyway, so heavy substance use increases risk of depression, anxiety, and psychosis. It causes psychiatric syndromes, symptoms part of intoxication withdrawal, substance-induced depression, anxiety, psychosis, cannabis, and this is all things we've covered. So there is also the part where when patients self-medicate, they develop SUD, and it is basically, it relieves distress. It then leads to sustained use, and then leads to SUD. Okay? Especially depression, anxiety, PTSD, where there's a 2-fold to 5-fold increase in SUD. And in these cases, SUD typically emerges after the onset of PTSD. There's a temporal sort of relationship. What else contributes to comorbidity in co-occurring disorders? Stress and trauma, we have seen this. It's a risk factor for mood, anxiety, and SUDs. Adverse childhood events, positive correlation with SUDs, depression, suicide, PTSD, increased risk for SUDs and depression. There is a genetic vulnerability. We know that substance use, depressive and anxiety disorders, mostly independent, but some evidence of shared genetic liability. Addiction also has a heritability, and which ranges to between 0.3 to 0.7. And of course, psychiatric disorders, heritability for both depression, bipolar, ADHD, and schizophrenia. All looks pretty bleak, but how do you treat it? Okay, so treatment of co-occurring disorders, there's a large body of evidence, research that supports integrated care, which means care is simultaneous and coordinated between SUD services, mental health, and medical and primary care. I'd like to pause here. Okay, you show me one place that does this consistently, and I will show you a unicorn that shoots rainbows out of its horn. I will take you to the other end of that rainbow, introduce you to the leprechaun who's guarding the pot of gold, and talk him into giving you that pot of gold. This is rare. So this doesn't happen in real life. But look at what it can do. Increased likelihood of abstinence at 6 months, odds ratio 1.9. Increased likelihood of COD remission at 5 years. And double sort of remission rates, all co-occurring disorders at years 1, 5, 7, and 9. We should be really doing this, but we don't. And I think this is something for the policymakers and the thought leaders to consider. I think we at Naufar are in a unique situation, a unique position to maybe try to have a crack at this. And really sort of, if we want the best for our patients, this is what we should be doing. It's just an impassioned plea from a jobbing clinician. So, coming back to the answers. Severe alcohol use disorder is most likely associated with depression. False. The strongest association is with bipolar disorder. Nearly half of the patients with SUD have a psychiatric disorder. True. Dual diagnosis and co-occurring disorders mean the same thing. False. Patients often have more than 2 disorders. And evidence supports sequential treatment. Absolutely false. It needs to be integrated. So coming back to the topic. Are co-occurring disorders the exception or the rule? It's complicated. I tried to grapple with this for many hours, in fact, for many years. I tried to think that, okay, is it one leads to the other or the other leads to both? Are they part of the same illness? Depending on which study you go with, it ranges from 40% to 70%. I think, Prof. Jalal, I think you've said this. So for it to be the rule, we should establish unequivocally that it's 51%. of patients, which if you do, if you can, great. So I don't want to end on a sort of despondent, sort of dystopian note. Take-home messages. Number of patients getting diagnosed with co-occurring disorders is increasing. This is a good thing. It's not the number of cases of co-occurring disorders, it's the number of patients being diagnosed. So that means we're getting better at recognizing this. This is a Dutch study, Rama, by the way. You might know this gentleman. So when a diagnosis, and this is something that I always, my trainer's sort of words still ring in my ears. It's like, Rehan, if you find an SUD, look for a mental illness. If you find a mental illness, look closer, you will find another one. And we don't do this. We're so happy that we've diagnosed an SUD that we quite often sort of overlook. And the converse is true as well. People working in core mental health services, I've been on both sides of the divide. I kind of focus on my sort of half of the playing field. And I was like, that's addiction. I'm going to focus on depression or psychosis or schizophrenia and ignore the other. And this is precisely what we shouldn't be doing. Severity of SUD associated with higher rates of co-occurring disorders. We've established this with multiple sort of pieces of research. And integrated treatment is evidence-based and better than sequential treatment. Those are the take-home messages. And from that sort of European close, I would like to quote Eminem and say from sort of, lose yourself, 8 Mile, snap back to reality. Oh, there goes gravity. Thank you very much.
Thank you, Rehan. I actually had a flashback from 2018 when we did the work in Qatar National Health Strategy. We did a piece on co-occurring disorders. So it was a committee from Sidra, Naufar, Hamad, and that document I think is still...
And where did that go? Nowhere.
So
it's in a dusty drawer somewhere, sort of collecting dust.
I'm going to open the floor for questions. So Professor Amin.
Okay, just hang in there. Coffee's, caffeine is just around the corner.
Thank you very much, Rehan.
Thank you.
Beautiful speech, beautiful presentation. I want to return at your presentation about cannabis and psychotic.
Yes.
You have noticed the dose dependent of the risk. I wanted to add one point. It's very important. It's the quality of cannabis. Regarding the ratio on cannabidiol and THC,
yes,
this is a big challenge in the world because cannabidiol is the basis of cannabis therapeutics. And we have a big commerce-based industry with cannabidiol. In France, we have a great conflict, a great damage with a fork cannabidiol.
Mm-hmm.
And it's important to know that because it's the basis of the discussions of the legal conception of the cannabis. The quality it's almost important that
absolutely
the dose.
Yeah,
okay?
absolutely. The concentration, the really good stuff actually comes with a higher risk of schizophrenia. So let me put it that way, sort of, So thank you.
Yes,
John.
Professor.
Yeah, thank you. Well, if only I'd got all those questions right, but at least the bar was high enough for me to contribute. But thank you. It was an amazing talk. And I wanted just to ask you to, I guess it's a transdiagnostic reflection. And if we just take, for example, PTSD and alcohol, it's absurd to think that they should be treated in any other way than at the same time. Because alcohol, let's assume, is part of the maladaptive coping in response to disabling fear. So in my country, for as long as anyone can remember, if you pitch up to a community mental health team and disclose PTSD, but then report heavy, harmful drinking, that's the end of the episode.
Yes.
You're immediately diverted to the addiction service that has no trauma-focused cognitive therapy experience to offer. So it does seem to me here in this extraordinary setting and 7-star clinical facility that you would always treat them at the same time because they're intertwined in that sense. And I'm assuming that's just a simple you agree.
I do agree, yes. Yes, we do as much as possible within the sort of confines of risk management. We do offer treatment concurrently. But I have to pick you up on that. There is one setting in the UK where there is integrated treatment, and that's military psychiatry. So I have worked with Martin Deal at Donington, and that is the exception. And it's for such a small sort of segment of the population that it's almost negligible. But all the therapists are trauma-focused CBT trained, and they do offer sort of integrated care. I wish it could be expanded for the rest of the population, but thank you for your question, John. Yes.
Thank you. Do we have time for one more question?
Yes.
Two more questions? Okay, let's go. Yes.
Fadl. That's yours, yes. It's your question.
Yeah, Dr. Faris.
Thank you for the nice presentation. I want just to add to Dr. Ali when he mentioned it is multifactorial, that substance-induced psychosis or any other substance. Actually, the interesting thing is that I made a review paper with my colleague Dr. Nadil Gibali regarding the development of psychosis after substance abuse. We find like median age from starting of cannabis till starting of psychosis around 5.3 years, while amphetamine and crystal meth, it's less than 1 year. So it's a multifactorial, and also the time of using is important. We have that paper only on the psychosis, but I don't know about other mood disorder or others. Is there any time frame do you have during your review of this lecture, please?
You will notice that the one thing that I did not talk about was stimulants, because I still think the evidence is emerging. I did not come across the publication, but I would have included that if I had known about it. But yes, I think we are in a space where the sort of overwhelming sort of influx of stimulants into into services patients with these issues. I think we will see a very different picture in the next few years, and I think research will inform us as to what is the median time and what are the risks. And again, like Prof. Amin said, not all cannabis is equal. Similarly, not all stimulants are equal as well. So it would be a fascinating sort of area to keep an eye on. But thank you for your question.
Last question.
Thank you very much for your intervention.
Thanks, Alex.
Always a pleasure listening to you. And also the honesty, and the last slide is very poignant in that it is complicated, of course, another word for complex. But I think it's important really to recognize the fact that we are not going to change what traditionally has been a very polarized way of dealing with things, as John was talking about, mental health services. And of course, the reality is, patients might have forensic history, might have physical problems, so you're dealing with different types of service barriers rather than, accessibility to different types of expertise. So what has happened in Scotland, but I'm going to mention the fact that there is a comorbidity expert group in the European Drug Agency on this, and people are grappling, and there's a jobbing psychiatrist. It's important for you to at least have some sort of direction. So what's going to happen is that rather than trying to convince the general psychiatrist or the physician here and there that they should own to their responsibilities, clinical responsibilities, we went back to basics, and we're going to very soon produce this standard of care, quality of care, which is very much focused around human rights. It's a human rights approach where individuals who are accessing your services have the right to certain interventions, evidence-based interventions. One of them predominantly that the service and the environment within which they're getting their treatment is trauma-based, for example. What we realized in Scotland 10 years down the line using standards is that we, as part of the addiction services, have changed the way we operate and have owned and created a trauma-informed environment, as an example.
Yes.
Yeah, and I think that's an opportunity. So I see this as an opportunity of how do you go back to basics, patient-centered, person-centered, human rights-based, and essentially identify within your service, you and other staff members, of how can you change your service to be able to provide not just a comorbid type of service, but a multimorbid, because that's the reality.
It is.
Because there's also the time variation as well, where, as I said yesterday, things change.
Absolutely.
Morbidities change, severity of morbidity change. But thank you for your presentation.
No, thank you very much. And I think Prof. Jalal will be very keen on the human rights approach to accessing treatment. Thank you. So I would like to, any guesses on which slide was AI generated? That one.
The last one?
This one. Oh!
Oh, this one?
Yeah, this is AI generated. I'm not actually real. That one AI
nice.
generated. So the rest of it was legwork. So just, I didn't let AI do the presentation for me. But thank you for your time. Thank you.
Thank you.
Thank you, Dr. Rehan. Thank you, everyone. Now we will have a coffee break for 15 minutes. Sorry, but for timekeeping and to be on schedule, please return back at 11:45 so we can start session 5. Enjoy your coffee. Welcome back, everyone. I hope you had a refreshing coffee break. We are now ready to kick off session 5, Sports and Substance Use Disorders. Please join me in welcoming our moderators, Dr. Karim Shamari from Naufar, and he is the Deputy Director of Research Department, and Ms. Sumaya Al-Madhoun, who is a clinical exercise physiologist from Naufar, who will guide us through this important discussion. Thank you.
Hello, everyone, and welcome back. It is my pleasure to introduce Dr. Oscar Ramirez, a valued colleague and a highly accomplished physiotherapist with over 24 years of international experience across North America, the Middle East, and the Philippines. He currently serves as a physiotherapist at Naufar Hospital, a world-class center specialized in the treatment of substance use disorder and behavioral disorders. In his role, he actively assesses, plans, and implements physiotherapy interventions addressing conditions prevalent in substance use recovery. Beyond his clinical work, Dr. Ramirez has contributed to the development of rehabilitation programs, supported Joint Commission international accreditation efforts, and served as an educator in rehabilitation and movement sciences at leading universities in Saudi Arabia and the Philippines. Please join into welcoming me, Dr. Oscar Ramirez, to provide his presentation.
Good morning, everybody. Thank you, Sumaya and Dr. Karim, for a wonderful introduction. Okay. Today I'm going to talk about target physiotherapy for athletes with substance use disorder, a movement system-driven physician medicine approach. Okay. This framework is something new, and I could say Naufar helped me to develop this. Because just to give you a small story, when I started with Naufar, the first question I had was, what are you doing here? You're a physio. This is a mental health and substance use disorder facility. So I told them, I'm here to manage pain and to treat the injury. That's the first thing that came to my mind. But as I go on, because of Naufar encouragement, there's something more to offer. Of course, there are several research about physical activity and science, but I couldn't really connect my physical examination with the treatment, right? We need that. In order to practice precision medicine, targeted physiotherapy, your physical examination should be able to connect the diagnosis and plan of care. At the beginning, it was very difficult for me because there's no framework existing. I tried to contact some friends in other university. They don't have any idea. The same question, what are you doing there? So I suppose this could be a milestone for Naufar to actually talk about the framework that the physiotherapists could use to finally connect the physical examination with substance use disorder, especially with athletes, in order to have a better plan of care through the movement system-driven precision medicine. Okay, I have no actual potential conflicts of interest to disclose, and at this moment, I need my therapy. This is now my therapy for the past years, gardening. And I want you to look at the bonsai. Yeah, it is bonsai. The last one on the left, on your right, if you're facing the screen. Okay, there's some wires, and it is, I guess, thriving. It's okay. But I will we'll go back to that picture later on of the bonsai tree at the end. I will tell you something, a very nice story. Okay, I would like to take this minute to express my appreciation to the help of Professor Muhammad Mahadid, Dr. Khalifa Al-Kuwairi, our Chief Executive Officer, Anit Dale, Dr. Rama, Dr. Krim, Alina Carlston, and my line manager, Muhammad Mansi. Believe me, without their help and pushing me to do more, I will not be able to come up with this framework. Okay, now, As I said, we're going to talk about how physio deal with substance use disorder, especially in athletes, and how the physiotherapy profession or the knowledge body use the movement system framework in order to use it as a way to have a targeted physio. Because the usual problem, we see patient, for example, diagnosed with alcohol use disorder, and the next question is, what will be the physio treatment? The same thing with other medical diagnoses like left cerebrovascular accident. It doesn't give us any information because left hemiplegia is completely different from each patient to another. Okay. Of course, I'm going to discuss one case that could be a very good example how to use this framework, and he's one of the patients here in Naufar who recover completely. Okay, so why focus on athletes with substance use disorder? Because they have a unique physical and psychological demands. There's an elevated risk of injury and relapse, and underexplored intersection of sports rehab and addiction care. Okay. Their unique needs, of course, there's recovery, at the same time focus in performance, and that's really difficult to balance. Before, I'm trying to balance when treat athletes alone without substance use disorder, the balance between re-injuring and improving their performance. But this time, in athletes in substance use disorder, the recovery and the performance matters most. Now, they're also, of course, they have a pain perception response different from others. And of course, managing them will be different. The deconditioning and physical imbalance, they have the psychological readiness and motivation fluctuation, risk of overtraining and relapse behavior, the pharmacological interactions, and identity reconstructions. Because those athletes who have substance use disorder, they actually have a damaged image as an athlete. Okay. This is the core of physiotherapy practice. I graduated 1996, very long. And our practice started with the pathologic base. Then we started to move with the impairment base. And now, because of the ICH model of the World Health Organization, we're now having an identity on the practice on healthcare that we are actually dealing with activity limitation and participation restriction. Okay, just a brief introduction. Activity is the things you cannot do personally. Then participation is the thing you cannot do what the society expect you to do. For example, I couldn't walk for long distance. That's activity limitation. But the society expect me to go to work, get a job. That is a participation restriction. Now, this is the foundation that the Physiotherapy or American Physical Therapy Association introduced last 2015. So from this system, all the subspecialty of physiotherapy started to emerge. Unfortunately, nothing mentioned about substance use disorder and mental health. And hopefully, in the future, with the help of Dr. Karim, we should be able to publish this and help other students in physiotherapy to be able to have a background knowledge about substance use disorder in physiotherapy practice, especially in athletes. Okay. The movement system foundation, we believe that the movement system is actually affected by endocrine, nervous, cardiovascular, pulmonary, and tegumentary musculoskeletal. I'm not going to really touch this in detail, but I'm going to give you an example because we're very much aware how musculoskeletal affect movement, right? Now, let's go on cardiovascular. Patient who had a heart problem, okay, how is this going to affect the movement system? Because of the oxygen demand of the muscle, the patient with substance use disorder, in athlete, for example, they are in cannabis, they smoke a lot, so they have aerobic capacity problem. So what happened is maybe their long distance or VO2 max capacity is decreased. So their movement system is affected through that. So their activity is limited and their participation as well as restricted. So this is how we think. We always think and about endocrine. Okay, endocrine system, patient with diabetes, they also have limited capacity to exercise. So we have to consider that, and part of the physiotherapy's treatment, again, and movement system. But this is very big. We cannot really simply apply this in sports, right? So it should be more specific. So precision physiotherapy is actually a more personalized approach to treatment, really doing a thorough examination, finding out how the substance use disorder problem affect all of the system and how this system affect the movement, okay? So now, what are the movement system elements? We have the motion, the force, the motor control, and energy. So if we're going to back from the previous slide, so endocrine, it could fall under the energy, okay? Cardiovascular could still fall under the energy because of the oxygen demand and the heart need to pump. And if there's a poor circulation, still energy. Now, motor control is more on neurologic and how exercise or neuromuscular stimulation we use cause brain or spinal, neuromuscular or plasticity as they call it, okay? So motion, force, energy, and motor control, these are the 4 elements of movement, and any of those 4 elements are affected, it will lead to activity limitation and participation restriction. Now, let's expand this motion, energy to force. So the functional movement task will be control, like the smoothness of the movement, the amount, okay, the force, the speed, how fast you accomplish the movement, the symmetry of the right and the left, and the symptoms. These were the pain and like physical examination findings appear. Like for example, there's swelling, there's inflammation, pain, that will be the symptoms. Now, because of this functional movement task analysis that we use, the control, amount, speed, and symmetry and symptoms, now the framework will be able to use with the athletic performance. Because in athletes, we need to see how movement is controlled. Is it smooth, erratic, or uncoordinated? And the amount of force needed to accomplish the task. For example, high jump, running, or whatever. Then speed, how fast they need to accomplish the task. It is and symmetry, the right and the left. For example, later on my case, we're going to discuss about the right hip groin injury. So we look on the symmetry of the movement, okay, in order to manage them properly. Of course, symptoms, the pain, and the sign of any inflammation. Okay, I always want to talk about the sign of inflammation because there's a new pain of science that's emerging about, like it is in the brain. Okay, there's a way to know whether the pain is only a memory and if there's really actual pain. There's assessment for that. And I feel bad whenever I see patients, they were told that it is all in your brain without doing all the assessment thoroughly. Because for me, that is unfair. You're denying the patient of proper care. Just because your treatment failed, then you will conclude, oh, this is all in your brain. Now, of course, the functional movement task after assessment, you will do the qualitative observation target, then hypothesis about the dysfunction, how any problem of all the control, amount, speed, and symptoms can lead to impairment. Another example, for example, a patient who was able to walk. The speed is 200 meters per second. Okay, that is the needed speed for you to cross the street. I can say that the patient has no participation restriction. Sometimes we'll see a patient who can walk, but it's only 100 meters per second. I will just consider that as a household ambulator, but not a community ambulator, because you need at least 300 meters per second for you to be, 300 meters to be able to cross the street. If you're not, you might be able to cross the street before the stop light turn to red, okay? So that's why we need to know the speed. Then there's specific testing measure for those elements. For example, motion, force, we do manual muscles testing or dynamic dynamometer. For motor control, for energy, the aerobic capacity, we sometimes use that. And for motor control, we use the performance test, retention test, and adaptation. Because it's really very difficult to know and measure motor control because we cannot really observe brain changes. So we only infer it with the performance. So if the patient can repeat the performance after a period of not doing the same activity and he is able to do it again, he passed the retention test. So I could say that there is a retention or improvement in motor control. Then all of this will lead you to a proper intervention. For example, I noticed that there's an unequal movement on the right and the left. Is it because of force, weak muscle on the right? So I do exercise on the left, focusing on the same pattern and movement. I might also use the electrical muscle stimulation to improve the strength and movement. We all know that neuromuscular muscle stimulation can have effect on brain plasticity, okay, at the spinal cord level. So you have to use it in order for the movement to improve. Okay, usually the functional deficits in athletes with substance use disorder, they have motor control dysfunction, tissue healing delay, physical deconditioning, impact on training and recovery. Okay. Most of the research in physical activity are actually dealing with physical deconditioning, not on motor control dysfunction. They're neglecting that. So what I'm doing now, I'm using the body of evidence on Neurological Physical Therapy Association on how to use their data for the motor control dysfunction. Okay, this is the biggest picture of the movement system and patient management pathway that we're going to use throughout. Of course, through this system, we should be able to develop precise diagnostic label in substance use disorder in physiotherapy, because right now we don't have it. Okay, we have for the neurologic, electrophysiological, we have for cardiovascular, we have for integumentary, we have for women's health and public health, but we don't really have with the substance use disorder. So this is a body of knowledge that is still not there. So enhancing communication and consistency in care, importance in personalized physiotherapy planning. Okay, these are the common biophysical agents we use. When I was a student, we used the word electrotherapy. Now they changed it into biophysical agents to cover most of the biophysical agents that are now emerging. Like for example, a new one is transmagnetostimulation and transcranial electrotherapy. When I was practicing, it was not existing at all. So now, the next one is neuromuscular electrical stimulation for strengthening the muscle. We use also the transcutaneous electrical stimulation for pain management, cryotherapy, ultrasound, laser. Then, a strategic application to complement movement-based therapy. Okay, we use biophysical agent as an adjunct to encourage the patients to move. We cannot simply keep patients telling them move, walk, if there's inflamed joint, if there's pain. They will not be able to carry out the physical activity that you recommended. I still remember when I attended the conference about heart disease, and they're all talking about physical activity. And one physician, he's a cardiologist. He mentioned the importance of physical activity in cardiovascular diseases. He said the common problem he encountered is the patient don't comply. The reason, they have knee pain, they have back pain, they cannot really move. So I guess using this adjunct physical agent, we should be able to use this in order to encourage our patients to move and our athletes to get back to their sports sooner. Okay, also parts of physiotherapy practice in precision medicine, we use technology. Okay, it could be your smartphone, smartwatch, smart ring, or smart patch for glucose monitoring. Okay, I love watches. Since I developed diabetes recently, I switched to smartwatch, and it helped me monitor the number of steps I walk every day. So it keeps me on track, and it keeps me aware if I'm getting lazy that day. So technological integration in our practice should always be considered. But of course, there are challenges, okay? Data security, data privacy, device durability, device robustness, and regulatory barriers. Yeah, I would like to mention this about, Samsung Watch, they have a capacity to measure blood pressure, but some countries, they would not allow it. It is not activated because of regulatory barriers. Okay, now let's talk to my patient. This is a case insight on how I use the movement system framework in order to arrive to a diagnosis and a targeted physiotherapy approach or inspired by precision medicine. So this is a case of a 29-year-old male recreational football player who presented with a 10-day history of right groin pain after an abrupt lateral cut during a weekend match. And he reported an immediate pulling sensation but continued playing. Okay. Since then, he experienced discomfort with sprinting, kicking, and side lunges. He described the pain as dull ache that intensified with sport-specific movement, then sought physiotherapy for early management to expedite return to play. No imaging was performed. Clinical evaluation suggested a grade 1 adductor longus strain. Now, the task selection. This is very important. When we see patient, for example, I have low back pain. Yeah, you have low back pain. But the next question the physiotherapist should ask, what you cannot do because of your low back pain? Because this thing will guide our treatment and will guide our monitoring of progress. Okay, now, for this particular case, this is a right groin pain. I use the sign lunges. I just ask the patient to do this. How does it feel? What do you think is the problem? So, using the cast and key observation, during the side lunge task, the following were noted. Control, mild trunk sway towards the opposite side, the amount, decreased depth in the lunges on the right compared to the right. So it could be amount of range of motion. It is decreased on that side. Then speed, slight hesitation, and slow return to standing when loading to the right leg. Symmetry, asymmetrical stride with and depth between side. Then symptoms, pain rated 2 to 3 over 10 in the right proximal groin at full lunge depth, no pain on the left. Okay. The hypothesis, there's a force impairment, as we could see, because of affected muscle. The motor control deficit, because of the impaired movement on the hip. There's a trunk compensation and decrease in depth. Motion impairment, likely due to protective stiffness or guarding injury. Then the physical exam findings, of course, there's a tenderness at the right adductor origin, painful resisted adduction at 0 degrees of flexion, adductor squeeze test, and hip range of motion, reduced abduction on the right with mild discomfort at the end range. So over the 8-week period, the pain reduction was significant. Then strengthening, progression from isometric to dynamic adductor work. I used also the neuromuscular electrical stimulation to encourage early contraction adductor despite of pain and injury, and movement retraining, side lunge technique with mirror feedback to restore symmetry, education, load management, and gradual returns to cutting drills. Okay, the limitation of this actually is the symptoms of pain is not, and others part of the examination is not included in the framework. And the proposed model does not have a means of explaining the reason why the musculoskeletal problem seek care. Okay. what the physiotherapy needs, elevate practice with movement system framework. The physiotherapy should think about movement system framework. It is not our role in pathology or illness. This is our role in movement system. Collaborate across discipline for substance use care, especially for physio and exercise. This is a new field to us. Okay, continue research and advocacy, of course. Okay, now, toward a long-term wellness, okay, precision medicine and healthy living medicine. I believe that physical therapy can be a bridge between the two. Okay? Because in healthy living, these are the key points: body weight, body mass. We're doing it here with body composition analysis, diet and nutrition, physical activity, sleep quality, and blood pressure. In all these areas, I believe physiotherapy has a role, and exercise therapies, because it encourages us to have a healthy living. Remember, after you recover from substance use disorder, you need to keep your healthy living in order to sustain your recovery. Okay, the key takeaways: a movement system-centered physiotherapy is effective and essential. Precision tools plus evidence-based practice will result to optimal outcome. That is the void or absent in practice of physiotherapy for the meantime. Okay, as I said, I'll give back the picture. So that is my bonsai. There are wires around it. This tree dropped everything before. It almost died. Okay? I almost gave up. I almost threw it away. I watered and waited. One day, there was a bud and it started to thrive again. I guess sometimes things need to fall apart to grow stronger. So don't trust. Trust the process. Recovery is possible. So just carry on. Okay, thank you for listening.
Thank you, Dr. Oscar, for this great presentation. We're now open for questions in the audience. Yes, please.
Thank you, Oscar, for this very nice presentation. We all know that exercise and movement are very important, and this is why God created joints in us, because we have to move. My question is, are there specific assessment criteria or even management for the movement for various types of substance use disorders?
Like you're asking about if there's any specific...
Yeah, guidelines for example, patients with specific type of, for example, we know that some patients, they have some complications due to the substance, the type of substance. So they cannot do the same level of movement or exercise as other patients, So do you have specific guidelines for specific type of substances or specific type of patient population?
I believe right now there's not much specific practice guidelines. That's why I really love to talk about, can we go back to my slides? The movement framework. Through that movement framework, we should be able to know how the substance use disorder affect the movement system. Just to give you an idea how we do it in our physical assessment, for example, someone who smokes cannabis, okay, they might have a chest problem, so they might have a poor aerobic capacity. So from that movement system, so the patient will come to me, tell me, I cannot walk for long distance, but it doesn't tell me anything, right? I don't know, he cannot walk long distance because of pain, he cannot walk long distance because of muscle weakness, or maybe poor balance because of neurological problem. But in the case of cannabis, I will do chest examination and everything. So I will know, okay, the patient cannot walk for long distance because of pulmonary impairment. So from there, I'm going to design a treatment program addressing the right problem. So it's not really what I call a cookbook. a cookbook planning when it comes to substance use disorder, especially in physical therapy practice, because the impairment varies so much that you really need to apply the movement framework, okay, in order for you to give the patient the correct treatment. You can give a generalized, for example, treatment. For example, alcohol use disorder, they're very known to have a bone density problem or poor bone density. So you could include those exercises in general. I usually do that before. But for me, that's a mistake on my part because I tend to forget other issues that patient could have an issue. An example I want to give to you. I saw one patient, he said, I don't want to go to the supermarket. So I was asking, what other reason do you have why you cannot go to the supermarket? So I dig further. I just found out he has an issue with vestibular problem. So when he's at the supermarket, there's 2 shelves on both his side. He couldn't go through that without losing his balance. So that's the reason. So that's why we could have a program developed for each substance use disorder, but I believe it should be more on the stages of the recovery that we design the program, but not actually the level of medical diagnosis. For example, substance use disorder in alcohol, the physiotherapy will give this treatment. I believe that we should follow what Naufar is doing now, is by stages of recovery. Then from this stage, we'll do this. From this stage, we'll do this. And of course, we just need to identify later on, like the cluster of signs and symptoms that will benefit from that. Okay.
Thank you, Dr. Oscar. Thank you for your questions.
Thank you. Thank you, Dr. Oscar. Now, it's my pleasure to introduce Dr. Karim Khaledi. Dr. Karim Khaledi is a clinical psychologist, sports psychologist, having worked many years with athletes on their performance, recovery, and also mental health. Dr. Karim Khaledi is also a sleep expert, which is very important. Karim has worked many years in sport, with federations, clubs. Yes, this is prevention of fall and injury. And he has worked many years with sport clubs and federations. And here now we will have the chance for, please listen to this. This is called Silence. And we have the title of his speech, which is Breaking the Silence, with a wonderful talk about mental health in athletes. Thank you very much.
Thank you so much. Good morning. Assalamu alaikum wa barakatuh. Today we share together a specific topic, but in the same line with the main topic of the symposium, breaking the silence, mental health in elite athletes. I do not have any thing to disclose, and mainly we will share together 3 complementary learning objectives, evidence and approaches of mental health disorders. Second one is barrier to seek care and support. And the last one, how to work all together in interprofessional teamwork and to get the right support for our population. Imagine today, right now, we receive a specific news that one famous elite athlete had an injury. It could be knee, it could be shoulder, experience of concussion. Is well recorded and well accepted. It's part of sport. Second scenario, imagine same space, same time, different news. One of the famous elite athletes had experience with chronic depression or psychosis episode. What do you think? Do you think we will receive the same information, the same behavior? Totally no. It's mental health, it's something scary, people. Because long term, we build a specific image of elite athletes. They are strong, rich, powerful. Mental health is here to discover, to let you to discover what's happened beyond these not right images of this population. As you can see on that slide, mental health in elite athletes is not long a taboo. In 2019, in that systematic review, they reveal very important information started by experts in IOC, International Olympic Committee, to inform us that elite athletes are suffering from mental health disorders, and they are weak and vulnerable to different psychological factors. Now, to define what is mental health and what is well-being, the definition is clear to start with clear understanding of what is important in our topic today. Mental health, based on definition of World Health Organization, is the condition of people to work, to be happy, to be engaged, to face stress, and to overcome problems, and to be part of the society. In different way, well-being, just to make it very easy, it's the feelings that you feel that you are good. And based on that definitions, how we can imagine in our mind what is mental health? Is it dissociated for mental health disorders and well-being is something else, or it's a continuum? Based on science, evidence, and this is very simple model. We have a lot of different models of what is mental health. It's from two extremities: mental health disorders in case of problems, or very significant event in the life of elite athletes going through resilience. Resilience means the capacity to adapt and to overcome problems, and also flourishing and to improve self-own development. Now the question, mental health disorders risk factor. How can we identify the factors? According to research, we have different factors. The first one, individual factor. It means the type of profile, type of cognitive style, the way how you explain the event in bad way or in a positive way. The second factor is genetic factor. It's about family history. Your mom had experience with depression, there is high risk you can get depression. The third factor is environmental factor. It depends about your relationship with people. If you are isolated, you don't have a lot of friends, you are at risk to develop some issues. The last one is sport factors. It depends about overload, injuries, the relationship with your head or your coach, with teammates, could be important factors to take in consideration. What are the potential consequences in sport? If you have someone, elite athlete, is struggling with mental health disorders, what are the potential consequences? As you can see, is admitted and recorded that psychological disorders are significant, are severe and disabling, and may lead to delayed recovery and decreased quality of life, and is very, you need to take attention, pay attention, because there is a relationship, strong relationship between mental disorders and poor performance, and there is high risk to increase the rate of injury risk. Let's take some real examples based on science. What you can say about mental health disorders. In that article, anxiety and depression in male team sport has a percentage of 45%. For another research, in prospective research in all elite athletes, psychology disorders, it's about 35%. And what's about the female collegiate athletes, depression and eating disorders, rated or with percentage with 25%. Let's go deeper in different research. As you can see, most prevalent mental health disorders among professional athletes. This is a research of Goddard in 2019. Prevalence rate of mental health disorders, we can see alcohol misuse, psychological distress, eating disorders, sleep disturbances, anxiety, and depression. And what we can say about mental health issues by sport type, rugby has the higher percentage of alcohol misuse, and for e-sport, we have 82% of depression. And we need to keep in mind with different high-risk factors like injuries, chronic pain, performance, pressure, career transitions like retirement, or weight management demands, especially in weight class sports. Let's talk about substance use, how elite athletes deal with substance uses or misuses, how they deal with it. It means in terms of mental health, anyone or elite athlete is struggling with that. What are the main strategies? The main negative coping skills is alcohol consumption. The most population in that domain, rugby players, they have a higher percentage of alcohol consumption. Second position is cannabis. In terms of gender patterns, females are prone to develop depression, anxiety, and for male, higher alcohol consumption and drug use. What's about sport-specific trends? Rugby, as mentioned already, highest alcohol use, and for post-retirement, increases in football and hockey. Who are more prone or vulnerable to mental health disorders in professional athletes? As you can see on that slide, demographic risk factors, female athletes, younger competitors, career transitions, individual sport at risk to develop psychological disorders. We need to keep that in mind. With primary stressors, performance expectation, injury cycle, training overload, financial issues may lead to substance misuse pattern. What are the main coping strategies for athletes in high-stress sport? How they deal with it, with that kind of disturbances? As you can see, professional in general, they can seek for help. We have a few percentage of them, they can ask for help. For individual mechanisms, they go through spirituality or mindfulness practices, or, as you know, mental skills like goal settings, self-talk, positive self-talk, imagery. What about some others, elite athletes? They can ask for institutional support. And for specific population, for combat sport, they use toughness and they are in control of their emotions. For team sport, they can find out some support from the team, and for individual techniques like positive self-talk, clear goal settings to manage stress. Now, how can we identify and to screen mental health disorders? Based on this paper, 2019, IOC, with experts, they developed two different tools. The first one is SMART. Sport Mental Health Assessment is dedicated for medical staff they can use to identify elite athletes in case of struggling with psychological disorders. The second one, Sport Mental Health Organization, Tool 1, is mostly for coaches, for athletes, and surrounding friends and teammates. Let's provide more information about that screening. As you can see, the SMART, the one, is between the hands of physician, medical staff, they can identify in early stages in 3 steps. The first one, imagine you are the athlete we are talking about. You need to fill out the APSQ. This is question about stress. If your score over 17, you need to go through 6 screenings for anxiety, general anxiety, depression, sleep issues, alcohol, and drugs misuse, and eating disorders. In case you have moderate symptoms, you can get some support as education, mindfulness, and follow-up. In case you have higher score or significant score, we go through a deeper investigation, and you'll be requested to see a psychologist, a mental health expert. This is just to recap out to provide you with a summary. We have an amazing tool developed by experts based on IOC agreement that we have now a new tools to identify athletes at risk to develop mental health disorders or struggling with mental health disorders. Now, how we can manage the mental health condition in sport? Based on science, based on evidence science, as you can see, we need to identify all the barriers assessment phase. The second one, in terms of training or competition, to get free access to mental health or support. And should be easy to get this support and to work on personalized approach with team coordination, and surely to be in the collaborative care with physician, psychologists, physiotherapists, surgeon, and other stakeholders. Now, how can we identify barriers to free the space or to encourage our athletes to get some support? As you can see, this is amazing paper to provide a holistic approach about the barriers and the facilitators. Now, in terms of barriers based on research to athletes seeking treatment, some of the athletes, they have a lack of problem awareness. He's not aware he has an issue. This is true. Some of them, they denial for problem. Some of them, difficulties to express their emotions. Some of them, they are very worried about impact on performance. Some of them, they have some fear of negative consequences, perhaps their images. And some of them, not sure whom to ask for help. And some of them, they have belief it's not useful. And some of them, they will say, I don't have enough time to see a psychologist or care expert. Or some of them, they don't have any information how to access that support. Now it's about if we identify all the barriers. Now you need to understand what are the facilitators factors. The first one, we need to get access to this support and to get also tools to screen mental health disorders and to get a support network. It means mental health disorders should be a regular culture within sport domain, and we need to spread education and awareness about that, and surely to maintain and to make safe that environment for our population. But we stuck with one important, significant factor or barrier. As you know, or may know, it's cultural influences. Okay, we identify the barriers, we facilitated the access of the support, but still your coach is not convinced. Because as an elite athlete, you are very strong and you are very rich. We can't accept that you have any issues. We need to change that to provide right information, to be part of the sport domain, and to promote a positive mental health culture. Now, how can we optimize and to maintain that establishment? As you can see, we need to go through preventive foundations, educations, workshops, tools to identify mental health disorders, and to identify elite athletes or athletes at risk of developing mental disorders, and to do it in early stages. And we identify the expert in that domain to help our population. Let's to provide you an overview. The best practice in terms how to provide the right help in the right time. Best practice number one, mental health screening should be part as a physical screening. The mental health is not dissociated from the physical aspect. Is even more important. And we need to do it in early stages, because if we not do anything, we can see the condition, mental health condition of our population worse and worse. Let's to provide you with the concrete, real example of identification of mental health disorders. The National Collegiate Athletic Association in US mental health screening questions, they set up very easy tool with few questions, but smart questions. And the athletes will go through physical well-being to measure the sleep, mental state. It's about stress and self-confidence, and the self-perception, how the athlete is perceiving himself, it's important, and what's about his emotional control. In case any answer with yes, the elite athlete is requested to see the medical staff to do a further investigation and to help the athlete to fix his issues. Best practice number 2, create and maintain an environment, safe environment. All coaches, physiotherapists, physicians, you are experts in your domain, but you need to understand that mental health is something important, it's part of sport, and we need to spread the culture of mental health as part of performance. There is specific performance, mental performance. In case you are ready to play an important match, you are an amazing player, very known player, you have everything, and you have some issue with your concentration. Do you think you can do something? No.
Karim?
With the focusing skills or to control emotions, the player is nothing.
Karim, can you please conclude in 5 minutes?
Sure.
Thank you very much.
Best practice number 3. We need to reinforce multidisciplinary work and took in consideration the input of all stakeholders. Multidisciplinary, this is the key. Let's conclude, Mr. Professor Karim. Our mission to promote and develop safety, excellence, and wellness in wellness in athletes and foster lifelong physical and mental health. This is first point. The second point is too much important. There is no redundancy. But mental health is not just related to our population, elite athletes, for all stakeholders, physician, physiotherapist, massagist is too much important. And you need to know, mental health disorders is contagious. You fix the problem of your athlete, but still your coach is stressed, is struggling with his personal life. In the end, mental health, this is your own performance. This is your power. Thank you.
Thank you. Thank you very much, Karim. So, for the ones who are not Arabic speakers, do you know what's the meaning of Karim? Karim means generous. You see, Dr. Oscar exceeded his time by 10 seconds, and Karim gave him back 4 minutes. So we have 6 or 7 minutes to be in time for the session. So the management will be happy of Sumaya, Karim, and Oscar. A question, please? Dr. Rehan, please.
Yeah, now it's on.
Thank you very much, Kareem. I have 2 points to make, in fact, if I may. I think the first is a comment that disclosures are important. And you do see this in elite athletes, for instance, in the NBA and other leagues where successful athletes actually acknowledge and say that I've had help, and that is why I've done well, and they've thanked their therapists, etc., when they've won championships, etc. So I think that is important. I don't know how far it will take for this part of the world to be able to come to that stage where athletes actually feel secure enough to disclose. The second is that we talk about elite athletes, but quite often the sport is what's keeping things together for them. And the risk actually is substantially higher when they finish their careers or when they retire. I think Gaza's struggles with alcohol use disorder, Paul Gascoigne, as he's known for the rest of the world, and the Hollyoake brothers, who are cricketers, I think they're well publicized. So I don't know if there are any services for elite athletes at the end of their careers, or whether they're just consigned to the scrap heap as to no longer sort of, somebody who's of use to the professional sporting industry. I'd love to know what you think about that.
Okay, just to make it more clearer, for your first question.
Sorry, first question, have there been any disclosures sort of within the region where elite athletes have actually come out and said that I've had help and I am successful now? So that's the first.
This is my main and major work. I'm working in hospital as clinical and sports psychologist as well, sleep specialist. This is our job, daily job. Over 25 years in France and in Qatar. This is the main job in hospital, to listen to the athletes in terms of qualitative listening. Okay, for injuries, it's a high risk of mental health struggling. This is a core main job as psychologist. I provide good services. How we can say it's good services? Because you have some feedback from physician, for physiotherapist. For the second question, it's we have 2 different pathways for high elite or for retired athletes. They can go through their own help, family help, or professional, or it could be within friends, or you see, they have a lot of different ways to get help. But as mentioned before, we have a lot of barriers. A lot of barriers. It's good to know what are the barriers to get out to help this population.
Thank you, Kareem. Any a question? Okay, while waiting, Ms. Hanadi, please.
Thank you, Kareem. I ask a lot about exercise because my father was a football coach, so I'm interested in sports a lot. And my question is, you showed us prevalence in international. I think it was a worldwide study. I don't know if you have the prevalence of mental illness in this area of the world. My second point is about the opioids, because we know that it is somehow common to see post-injuries to have patients started on opioids and unable to stop afterwards. So I don't know if you have any the prevalence of opioid use disorder among athletes. And I like the title of the session, Breaking the Silence, because this is very important for anti-stigmatization of mental illness, specifically substance use disorders in our region, because many of our adolescents have fans, athlete fans, and they get and I think Dr. Rihan meant when he asked this question, is it publicly publicly announced, not only seen in Aspetar, but to have it publicly said, we have this problem and we got treatment and recovery, and to have everyone know about it.
Okay. Karim, can you please answer in 2 minutes, please?
Yes.
Thank you very much.
Less than 2 minutes. The first one is if we have data about mental health. Yes, I have been designed to be the head of research about mental health in AFC, Asian Football Club. We are performing that study. Okay, we have clinical outcomes in hospital. For the second question, sure, we have some cases of patients when they got injured. Some of them they can use opioids, and some of them they can struggle to stop it. That's true.
Last question, Dr. Vidya, please.
Just to answer your question, Hanadi, and also we have a program now that is starting. Rama is not here, but it's with NSMP, and you know about it, Karim. And it's really to look at mental health amongst the elite athletes, look how many of them self-medicate or start in that way, and usually with cannabis, but with other things to overcome. And also Sumaya is sitting up there, and she's published on a couple of case studies exactly showing that from data from here. So it's here. We do see that connection. It's there. And for the second question that Rehan asked, what's happening to people who have retired elite athletes? IOC is setting up a huge program at the moment. I'm in the Medical and Scientific Commission, and Jane Thornton, the new person who's taken over, they're certainly going to pull this together and try and make sure that, once you've been this famous person, suddenly you lose all of that, and you lose people like you looking after them. What's going to happen? And hopefully they will announce a program soon for them.
For the second question, we have some cases when they retired to keep going the relationship and the follow-up to help them. For the first question about research, I think I can make some people unhappy today. Sorry for that. I will take the risk quickly.
So thank you very much, Dr. Karim. I'm looking at my watch. The MC will be very happy. 29 minutes and 4 seconds. So you have 55 seconds from Karim's to you for your lunch. Please, MC, thank you very much.
Thank you all. Lunch is served now from 1 to 1:45. Enjoy your lunch, and please come back at 1:45 sharp. We will be starting the next session. Thank you.
Check.
that. If I'm not careful, I'll try and... Oh, that's just... Sorry, I'm on. Hello, hello. I'm open.
Welcome back, everyone. I hope you had a great lunch. Now, we are ready to dive into session 6, Measurement of Outcomes and Innovation. Let's give a warm welcome to our moderator, Dr. Rahma Kamal from Naufar, who is a senior consultant psychiatrist and the director of research department and the clinical head of ladies service. She will guide us through this session. So welcome, Dr. Rahma.
Good afternoon, everybody, and thank you for coming back from lunch. We are going to have a very interesting session, as said, talking about outcomes measures, but also innovation in that perspective. I'll have the honor to introduce all the speakers today, and actually on behalf of Dr. Abdullah and Dr. Maria, who were not able to be with us today. For our first presenter would be Annette Dale. Annette is our Chief Executive Officer. She told me in the break to keep it short, but I tried. I couldn't keep it short. She started her career with a psychology degree in University of Leeds in UK. And from that, I think a triangle went fast from being a psychologist, manager in residential rehab, a research fellow, director of policy and practice for drug scope in the national NGO umbrella, and then being also an executive director of quality, adding to that being the strategic director and for Central Northwest London. I think she said somewhere yesterday to Alex, I was the person who was torturing you. So went to be a UK governmental advisor, and then had several years, I think, for the last 7 years, she has been also doing some work, for 7 years, has been doing some work as consultant in UK with her own remit of work in with a lot of national and international agencies, saying not the least of them with WHO, UN, working in training for the Colombo Plan and a lot of other things. Please welcome her on the stage, and we'll hear a magnificent thing about outcomes measures.
Okay, good afternoon, everyone. I'm delighted to be able to speak to you all at the second symposium, and I'm delighted to see everybody in the audience and hopefully people online, and to be able to talk about a very important topic for us all, and that's what outcomes do we actually have in terms of the patients in substance use disorder treatment, and what outcomes can we expect from this disorder. I've got acknowledgements at the end, but just a huge thank you to Professor Mohammed for the honour of actually being here and being in my position and being able to present on this and having faith in the whole team to take this new vision of precision medicine forward. So thank you. Thank you to Dr. Khalifa. Okay, so let's get into this. I've got no actual or potential conflicts of interest to disclose. But this is what we're going to be covering in this talk. What outcomes do we expect from people with substance use disorders and from substance use disorder treatment? And then we'll look at why Naufar has picked a particular outcome measurement tool, look at the development of that tool and the implementation of it in Naufar. We'll give you the first 2 years' data, management statistics from that tool, so our outcome data. We'll talk a little bit about what we'd like to do in the future in terms of the research on QTOP, as we call it, and then a little bit of summary and conclusions. Okay, so what outcomes can we expect from substance use disorder and substance use disorder treatment? Now, this is a question that we ask our staff when they join Naufar and when they come for our induction treatment. So those of you that have been through that process will be well aware of this. And as you all are also aware that have been through that process, we do actually get a wide range of answers to that question, despite everybody coming from backgrounds in addiction, mental health, etc. And it's a complex topic. It's a difficult question to answer, and it's a difficult question. It's a difficult question, I think, because substance use disorders, as all the previous speakers have said, is a complex biopsychosocial health condition. Substance use disorders are also spectrum disorders, and this is the diagram here, which is from WHO. And what that means is it's not one thing. There's a range of different things encompassed in substance use disorders. And they range from use or intoxication that might cause harm, but it might be a one-off use, all the way through to a regular pattern of harmful use, all the way through to what we call dependence syndrome, or we sometimes say addiction. And this is the sphere that Naufar mainly operates in, though we do operate in the harmful use area as well, and brief interventions for people that have just started using. Many speakers have spoken about this. So substance use disorders can be a chronic health condition, particularly at the dependence end, requiring long-term treatment and management. And outcomes can be difficult to achieve. And it's interesting going to other services around the world and looking at other services. Many don't really measure their own outcomes and reflect on their own outcomes and reflect that back to the staff or reflect that back to even the patients to look at how they improve, how they can improve. So, and I think that we've got a duty to do that with our patient group. I think the other thing to say here is the second concept of recovery. Prof M spoke about Naufar Vision, and Naufar Vision is to help people impacted by substance use disorder reach their full potential. Now, Naufar model that Dr. Khalifa will talk about on the last session has this concept of recovery. And what we're trying to do is help our patients achieve recovery. And recovery is a really important concept. It's more than just treating an illness. So it's not like you break your leg, you go in and you get your leg fixed and then you're fine. Recovery's got three parts to it. The first is helping people gain voluntary control over their substance use, with an emphasis on the voluntary. Okay? The second is improving health and well-being. And the third is about social integration and helping people really become an active member of society and giving back to the society. And whether that means improving outcomes around education, jobs, housing, family relationships, being a community member, etc. So it's a high ambition, particularly when people have other co-occurring disorders or have been impacted by many years of substance use that many of our patients have. Okay, so other outcomes other than just substance use are important when we talk about outcome measures. Now, it's a difficult question to answer in terms of what outcomes are achieved by people with substance use disorders, because the published studies are of incredibly variable quality and method, and they often measure slightly different things. Now, how outcome, and so it's very, very difficult to compare across the studies. And the study populations are very heterogeneous, they're very different. So we're not comparing, in England we say apples and pears, in this region we might say, I don't know, dates and bananas. We're not comparing the same things at all. The other thing is there's a very heavy bias in the research, particularly a lot of the research is from the US, from North America, from Europe, and there's very little research from this region. So we really need to add and build to this, the research. And there's very, very few long-term studies. So I've tried to compile together the headlines from some of the reviews and the systematic reviews, because just as a way of condensing this very quickly. One of the first key points to make is that multiple studies indicate that there's different levels of remission or abstinence from different substances. So different substances seem to be associated with different levels of dependence potential and recovery potential. There's a seminal review done by Professor William White, and this was published in 2012. And he reviewed 276 studies of outcomes, and they were of very variable qualities. And the key finding that he found was the average remission rate was around 50%. Okay, that's 49.8%, but with a wide variation between studies. Now, you're probably wondering why I'm talking about remission. Because remission, we associate it with cancer, we associate it with different health conditions, etc. And the studies do talk about different things. Now, remission in these studies means that somebody is no longer meets the diagnostic criteria for dependence. That tends to be the definition of remission. And that's different from abstinence. Some studies did look at abstinence, but others looked at remission. And what that meant was that people still might be using, but below the threshold for dependence, or they may have swapped substances. So they might not be totally abstinent. Very key difference in the studies. Okay, population studies, and these are ones that look at these huge data sets and population, and they look in there to see whether or not somebody met the criteria of dependence and whether that differed over time. And these are mainly American studies. They found remission rates of between about 44 and 80%. So again, big variation. But there was a big range in severity of dependence in there. So that captures quite a lot of people that had mild to moderate substance use disorders. 50 studies of adults published between 1970 and 2011 differentiated between the abstinence and remission kind of criteria. They found the average remission rate was 51%. The range was big, it was 20 to 80%. And the abstinence rate was less, at around 30%. Now, the clinicians in the room won't be surprised at this. I think that you'll kind of recognize that. There was 17 studies with a sample size of more than 300, and the average remission rate there was 44. And 8 studies had a follow-up of more than 5 years. Okay. And the average remission rate, and I've lost it there. So I'll come back to that. One of the interesting points from the White research is that he found that the average remission rates appear to improve over time. So the studies were done back in the 40s compared to the 2005 to 11. The studies done here found higher rates of remission. Now, whether that was we're getting better at the technology and better at the treatment, or whether that's an artifact, he wasn't sure about that. Okay. Looking at slightly more rigorous reviews, so let's look at some systematic reviews. So systematic review of remission in amphetamine, cocaine, opioid, and cannabis dependence, this is 2010, found there was only 18 studies met that criteria, and they found a highest remission rate for amphetamines, but it was only 1 study. Then opioids, then cocaine, then cannabis. Okay, systematic review and meta-analysis, so again, higher level of rigor going on there, of substance use disorder treatment that lasted more than 18 months, found the longer the treatment, the better the outcomes. And again, I think that's something that the clinicians in the audience will really kind of echo and relate to. Systematic review and meta-analysis of 21 studies with a follow-up of at least 3 years. Found that remission occurred after about 17 years from starting in about half of the people. The rest were longer. Now that means that if somebody started using when they were 15, they only started to get into remission when they were 32. So there's this big delay. All right, opioid use disorders are worth a separate mention. The long-term studies of opioid use disorders, one of the key findings from these studies is the awful rate of death that occurs in this population, mainly through overdose. And we see this in particular North America, US and Canada. And if you look at those long-term studies, the US study there, a 30-year study, after 30 years from when they started, they had a 50% mortality rate, half had died. And then with a UK study, 22-year follow-up, had a mortality rate of 33%. And previous speakers, Alex, spoke about the mortality in Scotland. So this is something that we always have to be mindful of. So some key points: recovery is a process. It's not necessarily a destination. Some people may never reach that destination, but that doesn't mean to say that we shouldn't keep helping them make their lives better and strive for them to reach their full potential. And outcome research is very complex. All right, let's move on a little bit to the outcome measurement work that we've done at Naufar. So Naufar was looking at an outcome measurement and how we should do it. And there's different ways that we can measure outcomes from substance use disorder and substance use disorder treatment. It generally involves taking the baseline behaviour and then looking at that behaviour change over time. Now, we can do this in different ways. We can do it with biological measures, such as urine drug screening, blood screening, that will take a very tight capture of what happened to that person in a very tight time frame. We can do doctor diagnosis and re-diagnosis over time and look at electronic medical records. We can do repeated administration of assessment tools, particularly those used for diagnosis. Or we can use a specifically designed outcome measurement tool. And when Naufar embarked on this journey about looking for an outcome measurement tool, the team got together and we discussed what we wanted, really. And we wanted something that had been validated, and been validated in a number of countries if possible, rather than just one country, or rather than just the US, and that had been found to be reliable already. Okay? We wanted a tool that was clinically useful, and that was for the staff, but also for the patients, and something that could be used that would enable a therapeutic relationship between the staff and the patients, where the staff could regularly sit down with the patients and help them reflect upon how far they'd come or not, and then help them plan for the future. So we wanted something that was therapeutically useful, and also something that would give us good management statistics. I wanted things that would give us good management statistics so that we could all reflect on what we were doing. So this is what we were looking for. We also wanted something that wanted to measure things wider than just substance use. So we wanted something that would measure health and well-being, social functioning, etc. And so we wanted also ideally to try and compare what we do in Qatar with other countries. This is how we decided on TOP, or the treatment outcome profile. So let's go into a little bit about TOP, treatment outcome profile. So it's well published. So there's been numerous validity and reliability studies. TOP was developed and research undertaken in the UK initially. I'm delighted to have Professor John Marsden in the audience, who is I almost said gave birth to TOP, but that sounds a bit strange. He was one of the creators of the team that actually did all of the created TOP, tested TOP, etc., etc. So TOP was developed, and then research was undertaken to test inter-rater and retest reliability, and then its validity compared to other measurement tools and urine drug screens. So there's a biological element in there. And lots of publications. Now, this tool was then picked up, very interestingly, and taken, and it was culturally adapted in 3 other countries. And similar retest reliability, validity studies were done. And the 3 other countries were Australia, and the Australians have been quite prolific in their publishing in relation to the treatment outcome profile. They call theirs ATOP, Australia Treatment Outcome Profile. Chile picked it up, translated it, adapted it to their population, and published on that in 2015. And then China, a group from China has also picked it up and looked at specifically their opiate population and done a validation and reliability study there. Okay, so we've got now multiple studies from 4 countries in peer-reviewed journals. And the general headline is that TOP is already a reliable and valid tool. And what it does is it measures substance use in 28 days prior to the measurement being taken. So we try and capture that, what happened in the 28 days prior to somebody going to treatment as a baseline. And then it looks at other measures, health and well-being, crime, social functioning, etc. Okay, so, and it's been validated for a range of different substances. The list is there. It's also been validated in a range of different SUD treatment settings, inpatient, outpatient, opioid treatment centres, etc. The Australians have also validated it for telephone administration, and they're starting to use it as a follow-up tool for long-term outcome studies. So that's really interesting. And then different countries have also looked at whether or not it's valid with different ethnic groups, and particularly in Australia. What does it look like? Okay, so I actually couldn't find the Chinese one. I don't think they've ever published what it looks like, but this is what it looks like. It generates 20 to 26 data items. It uses timeline follow back. So the data items are the items generated there. Okay, so the clinicians sit down with the patients and they look at the substance use in the previous 28 days, and then they look at injecting behaviour as well. They look at health and well-being scores, etc. Okay, and there's also questions at the bottom on social functioning and crime. So it's kind of one page, and the content does vary slightly according to the different countries and what's validated or not, or what's important to the country or not. Okay, so Naufar's journey in relation to QTOP. Okay, autumn 2022, Naufar culturally adapted TOP for use with our Qatari patients. Now, what did that cultural adaptation mean? Well, we translated it. We translated it into Arabic and Qatari dialect. We included the substances that were most utilised amongst our treatment population and used those names. So we have a lot of methamphetamine use. We call it shabu. So QTOP talks about shabu or methamphetamine use, for example. We changed slightly the housing status and the crime categories because they really didn't accord with some of the other countries' housing and crime categories. And we added 2 categories. Now, this is where our data is not reliable, and we're not going to pretend it is because we've got to test this yet. But we did add the inclusion of sleep and whether or not people were getting regular sleep in that period before treatment and then at the reviews, and then also exercise. So we've got some work to do in relation to that. It's very interesting. And then good implementation. Okay, and what does that mean? We included it in Naufar core data set. We produced protocols, and I'm thanking the clinical leads that I'm seeing sat in the audience for the clinical protocols and the training that we produced, and we trained all the clinical staff on how to use QTOP at assessment and review and in a therapeutic way with the patients. QTOP was undertaken on all patients in Naufar in November, December 2022. And then we systematically implemented it from then. And the start top is supposed to be undertaken between 2 weeks, first 2 weeks of treatment episode, baseline data, and then every 3 months thereafter. And I mean, Dr. Rama and I think that we do torture the clinical teams about, okay, you've got to get the QTOP data done on time, because implementation of these things is not easy, particularly when you've got patients coming and going, you've got some dropout, etc. So it's an interesting journey getting systematic implementation of this kind of an outcome measurement tool. Okay, so this is from the management statistics. So we haven't done yet the research, but this is the management statistics, and I'm going to focus on the data and the data categories that have been previously validated in other countries and found to be reliable. Okay, so Naufar, we've got 288 start QTOPs, and that relates to 1,534 unique patients. So we call this we do this by treatment episode, and a treatment episode is when a patient comes into treatment and they stay in a treatment until they leave treatment or they drop out. Okay? And then, in terms of the review QTOPs, 531 reports related to 500 unique patients. Okay, now we did have more data, but they didn't make Dr. Rama's in terms of getting them in the right time period. Okay, and then we grouped the patients into different groups in order to do the analysis. And this is also so we could compare to other countries. Now, the first thing to say is patients use multiple substances, and we look at this one substance at a time. Okay, so we looked at all episodes, patients using opioids, stimulants, opioids plus stimulants, because we know that from the other data, those patients have poorer outcomes. Sedative, hypnotics, alcohol, cannabis, and then we did add synthetic cannabinoids in 2024. Okay, so what was the start QTOP sample sizes? They were all pretty healthy, so you can see the sizes of those. Actually, and then let's have a look at this. So what did the start QTOPs look like in terms of substance use? So out of the reports, the episodes, we had over 1,000 episodes reported with stimulant use, and the mean days use, so how many days did they use in the last 28 days? For stimulants, it was 13, opioids 9. Opioids and stimulants, the patients are using the 2 drugs, so it's 18 days for the opioid use, 11.8 for the stimulants, 13.4 for the sedative hypnotics, 9 for alcohol, 13.3 for cannabis, and then the new one, the synthetic cannabinoid use. Okay, now the pattern matched what the clinicians were saying they found in the assessments. So that was a big relief, to be honest with you. Now, word of caution with this data, because we can only compare with the published data. But let's have a quick look at what this looks like. Oops. In terms of different countries and mean days. This is the start. Okay? So the country's data represents that study, not the country, apart from the UK, which has a very big sample size of 90,000. So you can see the different kind of trends in the different countries. So, for example, England, the heroin use days in the past 28 days is 22.2. Qatar was 9. But it's a much similar profile when you get to the opioid plus stimulant use. So this really reflects the different levels of use. Okay, so review. Okay, where did we get to at review? So the sample size here is 531 reports. Again, reasonable kind of sample size there. Okay, what were the results? Okay, the first thing I'd draw your attention to is that first big red piece here. So this is the percentage of patients using that, the percentage of episodes that were abstinent at the review. So in terms of stimulant use, 55% were abstinent at the review. The review was between 3 months and 5 months. Opioids, 66%. Opioids and stimulants, both drugs, 57%, etc., etc. And this is the mean days difference as well. Okay? So the good news is we are having a positive impact on our patients, that 55 to 66% of patients had become abstinent from a specific drug review, and the reduction in days average ranged from 8.8 to 0.2. The only thing that increased over the time was the synthetic cannabinoid use. That went up, so it went in the wrong direction. Now, we've got a lot more work to do to dig into this data. And we've got to really do some research to look at whether or not the synthetic cannabinoid is reliable, because that's new, and whether or not this is reliable change, or whether or not it's a statistical artifact. Okay, let's compare with the only country that we could get the data on to compare. Let's compare with the UK. So general key points are that Qatar generally had higher rates of abstinence from each substance at review, except for stimulants, where really we didn't do quite as well. But caution, it may not be the last data that the UK have, and this is not public data. Okay, health and social functioning. Again, we've got some positive impact on health and social functioning. We can see the patients are reporting improvements all of the way through, and it's slightly better than the UK. And similarly, social functioning and crime. The crime profile is very, very different in Qatar, and it was mostly about traffic violations. And if you've been driving on the roads, you can see that there's a tendency, the driving is very interesting. Okay, so QTOP research, current and future. This year, if we get through ethics, and if we get through IREC, which I'm hoping that we do, we're going to do some studies. We're going to look at the convergent validity and test-retest reliability of QTOP. We're going to look at the validity of the 2 additional outcome measures of sleep and exercise. And then we're going to look at whether or not we can measure the synthetic cannabinoids correctly. And then we'll do the research and publish on outcomes. And then we'll do what looks at reliable change. In the future, we think there's a lot of things that we can publish in the future. Part of the data set for precision medicine, looking at long-term outcomes, etc., etc. So summary and conclusions. Outcome monitoring is complicated, but it's very important. The international data on top reflects the different countries and the populations in the different countries. Naufar, we have been able to implement into clinical practice. We are using it for management statistics, and we reflect it back to the teams and the staff on a very regular basis. We can demonstrate positive behavioural change in substance use and in health and social functioning, and more research is planned for 2025. And then finally, we're really looking to other countries to see whether or not they'd like to collaborate in relation to QTOP, particularly GCC countries, where there's almost no data published on outcome measures. So thank you to everybody. And this is a Naufar family effort. I mean, it really is a whole organisation effort. So thank you very much to Professor Mohammed and Dr. Khalifa. The clinical leads have all played a big part in this, in helping implement. I've got highlighted Rama. We've sat down for hours looking at this data. Hala and James, I know we've driven you crazy looking at the analysis on this, thank you. But also all the clinical teams that have implemented it, it's really important. The IT team, Health Information Management team, the research group, I hope you're all going to publish, and then finally Naufar patients, and a special mention for Professor John Marsden. So thank you very much.
Thank you very much, Annette, for this comprehensive journey that you took us in it. I'll keep my question, but I think I was told that I have only a possibility for one question, so I don't know who's the lucky winner will be. Yeah. Any questions?
Sorry, Doctor. So you spoke a little bit about the sleep and exercise being an added outcomes out of this culture. Why those was chosen?
Why did we choose sleep and exercise? I think it was a kind of a joint decision by the clinical team, actually. We thought that these things were really important to brain health, and therefore would be important to recovery. Whether they are, we'll have to wait and see. We are seeing increased sleep, increased hours sleep a night, and also increased days exercise at the review point, so the data is pointing in the right direction. But it was a joint clinical team decision to add those two elements in.
Any other questions? I just have the tendency, maybe somebody has a burning question. Okay. So thank you, Annette. I think we go to the next presenter. Our next esteemed presenter will be Professor John Marsden, a professor in addiction psychology, head of the addiction department at the School of Academic Psychiatry and Institute of Psychiatry, and at King's College London. Professor John, I just read this and I thought, okay, I got intimidated. So really a career to be proud of, but is a board-certified practitioner, clinical academic researcher, focused on all the difficult substances and subjects, starting with novel pharmacotherapeutics, psychological interventions, being a lead in research and an advisor to everybody, I think, reading it. Is a scientific advisor of the Office of Health Inequalities and Disparities, is also the advisor of the academic advisor of the U.S. National Institute of Drug Abuse Center. And he's the one who says no to all of our articles, as he is the editor-chief of Addiction. We'll hold you accountable after this. Thank you for being here with us, and please enjoy his talk about outcomes monitoring again, but from another aspects of applied research.
Dr. Rama, distinguished professors, Naufar team, I'm so honored to be here. It means a lot to me to have contributed to this second important event, and I'm just so inspired. The program has been absolutely amazing. I'm tempted to use my allotted time to tell stories, but I think what I ought to do is see if I can do something that I think is a bit difficult. The kind invitation was to talk about some foundational research in England, and I want to lay background to my talk on those studies that changed my life. In the way you look back sometimes and think, there was a design to this madness. I then want to weave in some reflections on experimental therapeutics that we've done that bring in some of these other important recovery supporting measures, both outcomes but also as mediators of some of our core therapeutic outcomes in SUD. But then I want to come right back at the end, if I have time, and talk about the power of observational studies. And maybe there's some synergy along the way. But I might try and smuggle in just a brief story if I've got time. These are some affiliations and disclosures. I don't think I have conflicts of interest today. So I'm going to summarize 3 or 4 areas of foundational research that look back over time to the genesis of the treatment outcomes profile for England, as Annette has summarized, and then roll the action forward slightly and tell you about some of the additional subsequent studies that we've done. They're slightly fragmented, but to me, they begin to build a philosophy for patient-centered and measurement-based care, but also discovery. One of the things that we've been doing in England is to identify gaps in knowledge, and then we've been then using, if you will, the gold standard randomized controlled trial design, which we need to do if we're to bring certain novel therapeutics to the patient, but then build up a measurement model which we can feed back into our day-to-day routine capture of outcome monitoring. So if we start with the national outcome monitoring, the first thing that Annette and I and others did is that we published in The Lancet a study looking at the response to treatment. This takes me back to the optimistic days of 2009. And this is quite a large sample, just over 21,000 people who began treatment in all of the 149 local treatment system areas in England in a particular time for opioid and other substance use disorders. But they all received a medication for opioid use disorder, which is, in our culture, back then, daily, full or partial opioid agonist therapy. And then after 6 months of treatment, we look at the outcome performance for that national cohort. So you can see that the abstinence rate is encouraging. It could be higher. You can see that the reduction, this is a reliable improvement in the use of heroin, so reduced days of use. is encouraging. You can see that towards a third of people haven't made any changes. That's an actionable finding. And then you can see a few folk are heading perhaps in the wrong direction. You'll note on the right, as has been summarized at various points, endemic to England, in our treatment system, every second patient with OUD presents with OUD and cocaine use disorder. And you can see the way cocaine moderates outcomes for OUD. And that's a theme for later in my presentation. So really focusing on population heterogeneity in terms of response, imagine you're then the government and you're thinking, well, we've got to hand out the money to 149 areas. How do we do that? Because the providers put their hand up and said, well, we work in a very impoverished inner city environment, and we're not the same as leafy Cambridge, for example, or Hertfordshire or other places. How can you do that? So we were interested in thinking about risk adjustment. Surgical outcomes are risk adjusted for patient-level markers of disease severity. Could we do the same thing in addictions? So we took top data. You can see quite a large sample, national sample of over 65,000 people. And we thought about, well, what are the factors that are associated with outcome, that are covariables with it? And some of these are causal, and some of these are coincident and perhaps independent, but they, if captured by a patient in a particular area, would confer less likelihood for abstinence. So you can see some associations with the likelihood of being less abstinent. So daily heroin use, daily injecting, frequent, as Annette was saying, frequent crack users, 3 previous unsuccessful treatments, and living in the most deprived area in the locality. And what we did was we drew a funnel plot, and there's 149 black dots in there. But what we found was that before risk adjustment, 36% of areas were outside the funnel plot. So that means that they were either better than the national average or worse. But we could shrink that down to just 21% with risk adjustment. So it begins to be a more, if you will, fair way of allocating money. And it also starts to key into, at times of fiscal depression, public accountability and fairness and equity of distribution of resources. So another thing we thought was, what about longer term? So we did a study that I don't think has been done before, certainly not at the scale we did it. We looked at towards 8,000 people that had never left opioid agonist pharmacotherapy for 5 years. They didn't leave for a day. And in our culture, we would never push someone out. They stay as long as they need. And we drew some complicated growth charts using structural equation statistical methods. And you can see here with top measures over 5 years, so just half yearly, all the way through to 5 years, there is a really different response profile. We saw a growth chart like this yesterday. And I'll just make one mention. It looks pink to me, is a group that had an initial regressive response, but never, ever used less heroin than 15 days in the month for each review. So we're starting to think we've got unmet need among people who are retained. What can we do better to reach that group of retained and non-responding patients? We've developed another instrument that we use for clinical case conferencing and care planning, which is called the ADAPT, and I'll only briefly mention it, but it covers some of the measures that Annette was focusing on. So we've got measures of SUD severity, we've got measures of complexity. So these are physical characteristics, personality correlates, relationships, risk, and these, of course, are either consequences, causes, or independent of the patient, but they make the care planning process much more challenging. And then we've got measures of a sort of asset-based recovery approach to the person's sort of strengths. And we use that clinically in our service as a language. So when we're doing a multidisciplinary case conference, we can say, okay, I've got my ADAPT profile for this particular patient, and we can say whether they are high severity, low complexity, high strengths, or whatever the markers are, and that's the instrument there. Well, while we were developing that, we started to think about, we've got to do some experimental science. So I want to move on to just map out really briefly the sort of past and present and future business plan for my clinical academic group. So we've been doing some opioid studies, some alcohol and some cocaine studies. And I'm just going to pounce on a couple of these to make a couple of key points as I move on. So the first one on the top left is about, well, what about if we recruited a group of patients that weren't responding and we randomized them to continued treatment as usual or to a personalized psychosocial intervention? So we did that in a study that was published a few years ago now, Lancet Psychiatry, and we asked patients if they'd be interested, completely voluntary, and we had a kind of toolkit-based approach to interventions. We basically went to all the manuals that we had on our shelves and took out the change methods that we liked. Someone did that earlier today on Marshall Linehan's DBT protocol. I was rather charmed to hear about. And the interesting thing is that we had an effect size. We had a positive effect for days used of heroin in favor of the intervention, days used crack, and also work and social adjustment. This little scale always, as we say in London, does the business. It somehow captures functioning that's improved by a treatment effect. We didn't get an effect for a brief neurocognitive appraisal, nor for depression and anxiety. And we'd hoped that those would be kind of measurement-based care interventions, indices that we could use. And they've been a bit elusive so far. But leveraging changes in the person's social economic functioning looks really, really important. So the next thing we did was we thought, okay, when I came into this field, we focused on training, and we kind of thought that people were not ready to be employed. And that, you know, we used to say that in Liverpool there was many, many people trained as forklift truck drivers, but then there was nothing on the docks to do, you know. So we did a trial, and it was actually really quite a large trial, and we used an American intervention called individual placement and support. This is not a training-focused intervention. It's a competitive job-targeted intervention based on interests, assets, preferences. And we compared that to treatment as usual. And in my country, that's what we used to call the job centre, which is a sort of offer from the state to get you a job. And it's an employment specialist-driven intervention. So the person meets with the employment specialist, and the employment specialist is a real can-do, real dynamic character, and she or he will drive the patient to a job fair, or they'll go meet a supervisor in a local factory, for example, where there's an identification of a vacancy. It's really inspirational. And you can see that we randomized people to advice, essentially, or to IPS. It's quite a big study. We powered it to be capable of a robust effect, but also to detect outcomes for opioid, alcohol, and other drug use disorders that are in this cohort. And the primary outcome, we used the Taxman's database in the UK, HMRC. We got an anonymous extract, so it was real precision outcome measurement. No self-report was harmed. And we found a really nice effect. And I'm going to briefly mention a story that I've never forgotten. And I went to Sheffield. That's a real industrial town with a big unemployment rate. And I spoke to a participant in Sheffield who'd taken part in our study and attained a job. And I sat down with her, and she was just wonderful. And I said, well, what's it meant to you, taking part and getting a job? And she said, I'll tell you, for the first time, I've taken my family on holiday. Bang! You know, that, I'd never forgotten it. But the reason for doing this is to leverage money for IPS. So what we did was we took these findings, we went to the Treasury, which is our national bank, if you will, and we said, look at these findings, guys. And they said, okay, look at that. 95% of local areas now have an IPS service for people with SUD in England. 95%. Allocated funding, this is the Southwest, this is Devon some of the Southwest and Devon, Somerset and Devon, I think. And then a few areas in London that have been unable to accept funding, but now are beginning to. So we translated these clinical trial findings into treatment delivery. The interesting thing is that our job attainment rate from the trial was good for alcohol and other drug use disorders, and it wasn't good for opioids. And it looks like we need IPS plus, some additional intervention, because for many of our opioid use patients, they have never been in work, whereas for our alcohol patients, they were often getting back to competitive employment. But I'm really proud of that, and it's a huge collective effort. So another thing we did was we looked at the opportunity of studying injectable buprenorphine. And at the time, this wasn't available in England, and we randomized patients to the Sublocade Indivior product or to treatment as usual. And I just wanted to use that study to highlight data visualization, which I've become, in my old age, rather fascinated by, and also very dissatisfied about the way we visualize our data. And it's a trial that's, it's the first superiority trial. We randomized people who were not responding or bored, if you will, or also at new admissions to this treatment. And we had a 24-week outcome measure. So the outcome measure was every single day over 24 weeks determined as being abstinent from opioids or not. Okay, so it's just if you will, a green or a red square for each day. Very nice superiority signal. And what we did was we then thought, okay, we'll draw a heat map for the control group. And that's a heat map, and it's got 24 weeks. There are 156 people in 56 people in that group, so each row is a person. And it's ranked by abstinence and also retention. The big grey bite is retention. So what can you see there? Well, it looks pretty good. There's a whole chunk of people at the top that are not using at all. This is treatment as usual. And then we encounter, I mean, I've been hypnotized by this, so that it looks as if there's repeating patterns of occasional use. And then when you get to the kind of waistband of the heat map, there's a bunch of people that never left treatment after randomization, and they used every day. Not many. And then you can see a group of people that had a mixed response with less than complete retention to 24 weeks. It looks pretty good. And then you think, okay, well, what does it look like if we bring in the experimental group? And I used to annoy my statistician. I'd say to her, well, we don't need stats then, do we? We just put up the heat maps. So look at that. Much more abstinence, much less periodic, possibly repeating occasional use, and much greater retention. So I'm a real fan of heat maps and visualizing, because what otherwise, when you channel the average treatment effect and the population mean, you don't see these subgroups. And I think they enable us to ask some really important questions about response and non-response that we can dig into with secondary analyses. A big therapeutic target for me clinically as a CBT practitioner is craving. And you can see for the injectable arm a really nice reduction in craving frequency, but also a turning off of craving completely. Some of our patients say to us, will you stop asking about craving? We measured it every 2 weeks. I'm not craving. So that's a 0. But so this depot appears to be really, really good at turning craving off. And that's got me thinking very much. Okay, so I just want to do a couple of more things. The career goal for me is to develop a medication for cocaine and stimulant use disorder. We've got no FDA, EMA, or any other licensed medication. NIDA and others have devoted a ton of dollars to that endeavor. And I got to a point where I stopped looking a while ago, and I thought there's no medications. And then systematic reviews begin to bring a story back. So we're doing a study, we're about to kick off, where we're going to randomize patients to 2 pills, a morning pill and an evening pill. Some of them will get an active drug, lisdexamfetamine, and some will get an active evening drug, mirtazapine, an atypical antidepressant. And it's a 2x2 factorial. So we're interested in the individual as well as the combination effects for cocaine. And our patients, when we met with them, this is co-designed, they said, leave no one behind. And so this, if you remember 50% prevalence for OUD, CUD, this is going to be available to people who are on the depot who have CUD. Does that make sense? So we've got, thank you, we've got a complete package. I'm increasingly fascinated by treatment effect modification and outcome mediation. So we're going to be looking at fMRIQ reactivity for our findings. We're going to be looking at treatment effect modification. So that's the immediate patient and other characteristics that precede randomization but affect the treatment. They affect the way the treatment is offered. They affect the way the patient accepts it. You could include ACEs. So they're temporally prior, and therefore they can be causal in the model. And then outcomes. I also believe I think good things flow from sleep architecture. So we're going to measure sleep as a mediator of the outcome effect. We're going to measure ADHD symptoms. And as you might imagine, that can partially explain the outcomes. So the sort of way I think of longitudinal studies now, this is experimental, but I'm going to finish up with how we can do it observationally, uses a directed acyclic graph. So in the Medco cocaine trial, there's the direct effect on, and we'll do the same heat map driven outcome measure. So it's a count of abstinent cocaine days. We've got our favorite. So there's the direct pathway, there's the mediators, there's our treatment modifiers, so they can affect treatment, but they could also predict the levels of the mediator and outcome. We might have some colliders. These are variables that are caused by 2 things, but not the mediator. And then we'll measure unmeasured confounding, which is the size of a variable that you didn't measure, and whether it's big enough to upset the apple cart and change your conclusions. So finally, I want to bring this right back and say, okay, the problem with RCTs is that they're really expensive, they take a long time to do, and they may not even be doable in the first place, but we still have to keep them rolling. But once we've got a treatment that's RCT supported, well, what do we do with that data? And it seems to me we can emulate a randomized controlled trial quite closely. We can structure the data. We can define the eligibility criteria, the treatment assignment. We can make sure we've got the right count of days, so we're not making the usual biases in terms of how long follow-ups are. Now, the tricky part, of course, is that we haven't randomized. And in the real world, people are selecting. Sometimes the treatment is selected for them, etc. So that is tricky, but, and I think it's been a wonderful theme over the meeting, we have now got theory-driven AI and machine learning-based techniques, propensity score matches, inverse probability weighting that can help us. And if we think of using our AI friends, imagine the data that you guys have got now and will have in 2 or 3 years. What about a propensity score matched comparison group? And that would enable you, I mean, just going through the steps of logistic versus, classical versus AI statistics, if that doesn't offend anyone in the audience. We might be able to emulate a trial using the same temporal mediators. There are problems. It might discard data. It might nevertheless be the fact that we haven't adjusted for things that actually are important. So we need to have a sober, sensible approach to it. But I think this is frontier research, I think, in target trial emulation. So I think there's a wonderful synergy between experimental and observational therapeutics and outcome monitoring. I'm personally very, very focused on craving, sleep, mood, and cognition. I think these are fundamental targets. I believe they will be the mediators of many of our novel therapeutics you'll hear about in a moment. RCTs are always going to be pivotal for discovery, but it's the cohort studies where treatment is in day-to-day delivery where the knowledge lies. Thanks very much.
Thank you so much for this interesting and challenging talk. I don't know if there's any questions. We have several minutes to challenge John, if we could, with questions.
Hi, John. Fantastic. Thank you so much. That's a fantastic presentation. I have a slightly naughty question and want to sort of put this out there. I was doing my sort of higher specialist training in 2008, 2009 when this piece of work was done. And we all know that the reason why this was done was the global financial crisis and the sort of squeeze on public funds. So there was a correlation. Since the global economy is not doing so great currently, what do you think will be the next step? Where do you think things are going sort of in rationalizing treatment for substance use disorder? Sorry, I thought I'd give you an opportunity to tell a story.
What was interesting was that you said you might drift into politics, but you never did. And there was an incredible grip on temptation, which I may not now be able to achieve. I believe in the power of precision research, patient-clinician collaboration, and making the case. And I have had a career in which at times I've had to suffer the strong opinions held by certain groups about singular solutions. But generally, the governments in the UK have been interested in evidence and making the best decision about deployment. And I've not really found that to be dispiriting. So I can only really speak for, backdoor, local, back garden, local context. I would worry that we are in some quarters an era of suspicion about research. I hope that's only a brief wrinkle in what otherwise I think is just a really powerful, and it's an exciting, and it's patient-based. But it recognizes that when some of our treatments are expensive. The therapeutic burden is not without cost, and we do have to show a return on investment. That funnel plot is one of the mechanisms for that. So I hope we continue to do that. But the problem we have is a workforce one. This all sounds fine, but actually in a lot of day-to-day services, they wouldn't be able to help manage ADHD and sleep architecture problems.
John, I have a small question for you because I know how you advocate for integrated care. Seeing the outcome outcome measures that you have presented was actually funneled towards only the substance use. What is your thoughts about other outcome measures that also take in consideration the psychiatric and the psychological status of the patient, meaning depression, anxiety, and other things there?
Thank you. I've been trained really as a cognitive case formulation practitioner. So I think that then is an idiosyncratic testable hypothesis collaboratively with the patient as to why is this problem not gone away? Why is it still here? What's maintaining it? What are the bottlenecks for change? One of the things I would have loved to talk about, we've got a protocol for people with alcohol use disorder who are also depressed. And so the idea then, we're going to offer, if we can get funding, oral tablet ketamine 3 times a week for 6 weeks for the depression, and then 6 more weeks for CBT for alcohol. Interwoven, but the idea then that the MADRS or the BDI, whatever we'll use, is the measurement-based care outcome. So it's a proximal outcome, but if we're not raising the depression, they're not going to get better for alcohol. And it is slightly in sequence, in spite of what I was sort of exchanging discussion earlier. But at one level, the top, I think, gives the minimum data set that we can live with. But clinically, yeah, I want a measure of pain. I want a measure of mood, better measure of mood probably. I want more subjective measures of personal growth and recovery. And you just have to kind of be disciplined, I think, about using that. But as a clinician, you can have those as long as I think they're, as we've been saying, they're clinically actionable.
Thank you so much for elaborating in that. Hopefully that will be, I'm sure it's going to be an inspire for us to do something in that context. We'll have the next one. Our follow-up speaker is Dr. Hamad Ikhtiyari. Dr. Hamad is a psychiatrist with, I'm just trying to make this short, I don't know how. He is the director of the International Network of Neuroimaging and Neuromodulation. Again, a big lab working in neuromodulation and addiction, psychiatry, transitional brain work, as we said. Hamad is serving everywhere. He's a co-chair in the ISM, is a co-chair in the WBA addiction psychiatry. He inspires junior researchers and junior doctors in addiction medicine. He's leading inspiring teams working in neurodevelopment and neuromodulation. With no further ado, I think, Hamad, you need to start. Again, we're not starting with Q&A. We'll just listen to you and see your slides.
Awesome. Bismillah ar-Rahman ar-Rahim. Salamun alaikum, Masa al-Khair. It's just fantastic to be here. And thank you very much for Professor Muhammad, Professor Jalal, Annette, Professor Vidya, all the people who made it possible to be here. My first time in Qatar, very impressed with what you are doing in Naufar. It's just fantastic center, and it's really inspiring. So my name is Hamad Ikhtiyari, and work in the University of Minnesota. And I'm going to talk a little bit about how to use brain imaging-based, circuit-based, individualized targeting for addiction treatment using brain stimulation technologies. So that is the main target I'm going to discuss about today. No conflict of interest. Many thanks to my colleagues at Laureate Institute for Brain Research. It's a unique center because it has 2 MRI scanners attached to a psychiatry hospital, and it's devoted to use brain imaging for psychiatric care. And I heard that you have an MRI scanner here in Naufar. So if you have an MRI scanner in Naufar, you are probably the only addiction treatment facility in the world that they have MRI scanner, which is fantastic. So this is a great opportunity. Hopefully, the thing that we are going to discuss about is going to be a basis for lots of things that you are going to do here. So from Laureate Institute for Brain Research, I moved to University of Minnesota. And University of Minnesota is a place that the first fMRI scans happened there. So there are two largest brain imaging centers in the world, one in Harvard University, the other in University of Minnesota. So we have 8 MRI scanners in a center, and the largest scanners, we have a 10 Tesla scanner, which is quite the size of this room. So there are really large scanners. And we try to use those scanners to basically dig into the brain circuits and how to develop neurotherapeutics. And you probably heard that Minnesota is also the origin of Minnesota model of care from Hazelden. So there are lots of addiction background. And also, Minnesota is the place that most of the large companies that are working on brain stimulation, like different Boston Scientific, Medtronic, all those major companies, they are located in Minnesota. So there are lots of really good combinations, and they attracted me to Minnesota to be able to do the research that we are doing at University of Minnesota. I have a lab that is focused to use brain stimulation, specifically for developing treatments for addiction, and I'm grateful of my postdocs who basically made it happen, and data I'm presenting are the works of my postdocs in the lab. So people who are here, how many of people who are here are working directly with patients? Those who are clinicians, those who are actually seeing patients. Okay, good. And those who are scientists, who do not see patients, but they basically provide science. Okay, cool. So majority of people who are clinicians. So from these brain stimulation technologies, so there are varieties of different brain stimulation technologies that we are using right now in clinical practice. How many of you have ever touched one of these stimulation devices? Okay. So can I go, Lee, you are using TMS, right? Okay, good, good. What are the other devices that you touched so far? ECT. Which one are you using? ECT, okay. So ECT is probably the oldest one, the most traditional one that we use in the daily clinical practice. But I'm going to talk about some sort of less invasive technologies that we call them transcranial magnetic and electrical stimulation. ECT is actually a type of transcranial electrical stimulation, but the level of energy that we are using is something like 800 milliamp, right? So that is the dose that we are using. But with small t, the one that basically we do something like a 2, 3, 4 milliamp. So the intensity is significantly lower. But we are discussing about these technologies, specifically in the field of psychiatry. And the number of studies that are happening with these technologies, with TMS, is expanding over time. It started around something in 1987, and then for electrical stimulation around 2003, and just expanding over time. So there are lots of new advancements in the field. Do we have any FDA approval using transcranial magnetic stimulation in psychiatry? Yes. What are the areas that we have FDA approvals? Depression, yes. What else? Nicotine dependence, OCD, what else? Headache, okay, what else? Okay, so 2008, the first approval was for depression. This is something that we are using in the clinical practice, daily clinical practice right now. OCD, August 2018. Smoking, 2020. Anxious depression, 2021. And then there's a new protocol, it's called SANT protocol. Who has heard about SANT protocol? Okay, SANT protocol is the first time that fMRI is approved in a clinical practice for psychiatry as a part of a treatment program. So they do fMRI first, define the circuit, and then they do treatment for depression. And I'm going to discuss a little bit about that. That's a kind of a new protocol for treatment of depression. Instead of 6 weeks of treatment, they do treatment in just 5 days, and the response is even better. So it is an interesting new advancement in the field. And then there is a new age expansion. So now we can do TMS for depression from age of 15. And now in some of our substance use treatment program for adolescents, especially those who have depression, but they want to treat their depression, and especially when they have families that they really do not want to start medication for them, so we start them with TMS. So there's another kind of interesting things. And there are new advancements in the field that are happening. So probably the next one is going to be alcohol, opioid stimulant, PTSD. So there are new applications in the field that are basically added to psychiatry. Have you heard about any CE approval for addiction using TMS? And CE is basically the European one and has a different level of a standard in terms of approving a treatment. And there is one specifically called on psychoactive substance. I'm not sure what does it mean, psychoactive substance. I mean, every substance use disorder is psychoactive, right? So what they call it psychoactive substance use disorder. The evidence comes from cocaine use disorder studies to not really good quality trials, but they have been able to receive CE approval, and I'm not going to go to the details, but there's a specific protocol for that. So these are the things that are happening in the clinical practice. But the other really important topic that is happening, this is a paper that was published in American Journal of Psychiatry just a few weeks ago, discussing about those who have substance use disorder and have depression, how to treat their depression while they have substance use disorder with TMS, or OCD, or psychotic, or trauma-related disorders. And the final recommendation is just we definitely can use TMS for comorbidities among those who are using substances with some considerations. And we do not like some of the components of that, so we submitted a new letter that's going to be published in American Journal of Psychiatry discussing about some of the nuances of what they put there in the guideline. But this is something, an ongoing discussion in the field in terms of how to use neuromodulation in the field of substance use disorder. But if you want to go this is the clinical overview. But what about science? How much we actually know about doing neuromodulation, specifically in the field of substance use disorder? Do you have any estimate how many trials, randomized clinical trials, people have done for using TS or TMS in the field of addiction treatment? How many clinical trials? 10? Any other estimates? 5? 1,500, okay. Good, that's good, yeah. What else? Okay, so 242 trials end of 2024 that people have done, and John mentioned doing randomized clinical trial is a really hard job if you want to do them in a really good quality. But interestingly, the number of these trials is just expanding over time. So from 2003, the first ones, to 2024, the number is increasing over time. And people tried on different things from nicotine, alcohol, amphetamine, and cocaine and opioids. So there are multiple trials that people are doing in the field. And if you put them together in a sort of meta-analysis, all the numbers of participants that you have, and those who have craving or consumption as an outcome measure. I mean, we have been discussing about outcome measures as an important area in the field of addiction psychiatry. So those trials that they targeted craving or consumption, these are the number of participants that we have in those trials. If you look to their effect sizes, overall, electrical stimulation and magnetic stimulation, blue and red ones, there is a significant impact on craving and consumption. Effect of craving is a little bit larger compared to consumption, as you can imagine. Effect of TMS overall is a little bit larger than electrical stimulation. But it's a kind of small to medium effect size that we have here when you put everything together. But there is a challenge here. If you look into the details of those trials, 242 trials, they targeted different circuits in the brain. So there is no one single area. I mean, there are different parts of the brain, so they explore different parts of the brain. So they are targeting different parts of the brain. But the question is, what is the right circuit for addiction treatment? That is the question. Specifically in the field of depression, there is almost a conclusion in the field that the best targeting biomarker is the connection. Anybody knows that? What is the best neurocircuit in the brain that is related to depression? And if you target it, you can be helpful in the field of basically changing people's mood. So the best circuit is considered as the connection between subgenual cingulate cortex and dorsolateral prefrontal cortex, okay? And people realize that if you find the most negative connectivity between dorsolateral prefrontal cortex and subgenual cingulate cortex, and subgenual cingulate cortex is important for your negative affect. When you have rumination, negative things that are happening inside your brain in a circuit, then your subgenual cingulate cortex is involved. So if you basically stimulate DLPFC, the area that is negatively connected to subgenual cingulate cortex, you can down-regulate subgenual cingulate cortex activity and be helpful for depression. So that is a biomarker that people realized. And then even there is a new company that made a patent out of finding individualized circuits using fMRI to target that circuit. So this is an advancement in the field that people are investing on using fMRI for doing this sort of individualized targeting. But the question is, what is the right circuit for addiction? What would be the area that we are going to target for addiction? Nucleus accumbens. What are the other areas that are important for us? Okay, what are the brain areas that you want to target? Prefrontal cortex, ventrolateral, tegmental area. Okay, good. So, first of all, brain has multiple areas that are connected to each other. The model that I really like among the other models is considering brain as some large circuits, networks that are connected to each other, okay? So there are 2 or 3 major large networks in the brain. One is called default mode network, and the other is called executive control network. When you are in executive mode, so you are delivering, you are doing the job, your attention is focused, you are doing lots of executive tasks, your executive control network is activated, and default mode network is down. When you are sitting somewhere and not doing anything, and you're doing introspection, then your default mode network comes up and executive. So because there's not enough blood in the brain to support both networks. So you need to decide which network, and then based on the network, your brain gear would be different, okay? So people realize that when you are in craving mode, your default mode network goes up and your executive control network goes down. And when we talk about default mode network, many subcortical areas that you are discussing, nucleus accumbens, amygdala, all those areas are all connected to default mode network and being receiving feedback from default mode network, so they go up. So you have activation in default mode network that includes some frontal part of the brain and then some kind of parietal part, and then executive control network that has dorsolateral prefrontal cortex here and posterior parietal cortex. So these 2 pieces are working together in that specific executive control network. And then when you bring back control, then the networks will be different. So then your executive control network would be activated and suppressing all those subcortical areas that we are discussing, limbic areas that are deep in the brain, so they can suppress that. So that is a model that we are trying to optimize for targeting for addiction. How do we do that? So right now, this is the type of stimulation that we are doing. Ashkan, one of my postdocs in the lab, putting the electrodes and trying to focus electricity on those networks. This is the frontoparietal stimulation, activating that network. And now we have developed a completely new protocol being engaged engaging that network, and then being able to do that inside MRI scan. So my team of people who are doing that inside MRI, so we can even record frontoparietal connectivity inside MRI scanner while we are doing the stimulation in a setting that we recently developed to be able to record and stimulate at the same time inside the MRI scanner. Why? Because people have different types of executive control network to find the individualized network that in each individual person is working. And then what we call, we close the loop between stimulation and recording. How? We record how the network is engaged when they are seeing drug-related cues and they have craving. And then, based on the response of the stimulation, we kind of record again, and then we optimize the stimulation. Optimize the stimulation, record again, to find what is going to work for that specific patient to engage that frontoparietal network. So it's called closed-loop online electrical stimulation inside a scanner to be able to find individualized. So these are the first trials in the field. We just submitted something for Nature Medicine. Hopefully it's going to be, fingers crossed. But yeah, these are the first trials in the field of addiction trying to engage that network. But going back, I'm going to start from kind of 10 years or 50, something like 20 years kind of before of getting to that level of advancement. So this is the first trial that we did with electrical stimulation in methamphetamine use disorder, published in 2014, okay? 30 participant, a small trial crossover design, and we showed that basically 2 areas in the brain targeting dorsolateral prefrontal cortex. These 2 areas in the brain, we showed that these 2 areas could be stimulated, and we showed that craving could go down with targeting these 2 areas. And then over the time, we realized that if we do this, putting the electrodes on the dorsolateral prefrontal cortex, the highest level of electricity is in the middle. That was interesting. And then we started to look in each individual patient with methamphetamine use disorder and showing that people have, if you put the electrode on the same area, do the same amount of electricity, people will receive different levels of electricity in different brains. So people need different types of stimulation when we do the stimulation inside the brain, and the response would be different. And we showed that the level of response would be related to level of electricity that we can put in that part of the brain. So we have been working on this area and trying to understand better. And one Saturday morning, I received an email from New York Times. I was thinking, New York Times, Saturday morning, and I was thinking, okay, probably it's a phishing email. And I was checking the email address, and the guy who sent the email, I realized that this is a kind of authentic email, so it's some kind of a real email. So I replied back, and they have been asking for help for understanding a paper that was supposed to be published on Monday on Nature Medicine. Asking that, okay, the editor-in-chief of New York Times is interested to write a piece about this paper that's going to be published, and we cannot understand the paper. Can you just help us to understand the paper? It's Saturday morning. I was, oh my goodness, I'm going to use my Saturday, Sunday, enjoy with my family. But okay, I told them, okay, I'm happy to do that. Send me the paper. And the paper was 40 pages with supplements and other things. I was thinking, these days we usually do not read the paper. We just read the abstract and some parts of them, not the entire paper. But I kind of sat down and read the entire paper and helped them, and they basically published a piece and they added my name there. So if you look and Google my name and New York Times, you can find the piece. That was an interesting piece. But the interesting part, this is the paper that was published in Nature Medicine, discussing about what would be the brain lesions that if we disrupt them, what will be the circuits if somebody have a stroke? There are people when they have a stroke, they stop smoking or they stop drinking alcohol. What will be the circuit that if a stroke happens in that circuit, people stop drinking alcohol or smoke cigarette? And they showed that the areas that are connected to this part of the brain are the most important areas. So, and then when I was looking at the paper, I realized that is exactly the area that we have in our studies that has the highest level of electricity in our previous trials. I was thinking, that is cool. So after the publication of the paper on Monday, on Tuesday, I sent an email to Michael Fox, the head of that paper, and asked him, okay, Mark, are you happy to share your data? And Mark was happy, so he sent his data, and I was comparing that with our fMRI studies from methamphetamine use disorder, and I realized it's the same area that they have in the lesion in alcohol, but they didn't have alcohol and smoking data. So I asked another colleague, she shared her data, and we showed that this is the same area that we all are discussing about. And we have been able to bring in the data from brain stimulation studies and showing that this is the same area that other studies that they targeted, they have positive results from their trials. And this paper ended up to the cover of American Journal of Psychiatry last year, discussing about this specific area, which is a part of default mode network, okay? And we show that this is one of the areas that we can target. And then, over the time, we showed that we can do individualizations on these targets. I don't have enough time to go to details, but showing that we can, these are individualized patients, these are 60 individual patients with methamphetamine use disorder, that we target different areas, that we showed that individualized targeting could be related to the level of craving response and reducing their craving. And now we are using robotic arms to target this area and basically optimizing the stimulation and helping people in the process of recovery, okay? So I'm looking to my time from the start, 23 minutes. So So I'm trying to remain on the time. So that platform is already published and it's available in addiction biology. So just a few weeks ago we published the entire platform in terms of targeting frontopolar to amygdala as an individualized targets for brain stimulation. And then we are showing that not only frontopolar cortex, but also DLPFC in a sort of a model. If we stimulate DLPFC and suppress dorsolateral prefrontal, the frontopolar cortex, these are the two targets that can activate executive control network and bring down default mode network, okay? So that is the model that we have. But the last slides. When we want to use this brain stimulation stuff, we need to communicate with patients. So without patient education, you cannot use this technology. They are scared in terms of what you are going to do. So you need to have communications about brain and brain health, okay? So we develop different materials in terms of discussing about brain and recovery with patients. And we would love to share those materials with those who are interested to have those materials. So those materials are publicly available. Over time, people in different institutions, they translate them in 22 different languages. And we have the Arabic version as well, if people are interested. And we are definitely happy to have them in Qatari dialect, if people are interested to have them in Qatar. And it's just a whole system of brain and recovery and brain stimulation and those technologies. Okay, my take-home notes. First, we discussed about circuit-based targets and potentials for doing circuit-based targets and the amazing things that you can do with using brain circuit-based therapeutics for addiction. Not only addiction, but also comorbidities that you have with addiction. If you have a patient, when you do clinical practice in addiction, everybody who has addiction, they have a comorbidity, right? We have been discussing that with Dr. Rehan. Depression, anxiety, PTSD, sleep problems, they all have something, okay? How can you address those other things that already have FDA approval for clinical practice, and there are evidence-based practices that people are doing, and you can help your patients for that? There are potentials for individualizing way of targeting. You have MRI scanner in your center, so you can do a fantastic job for that. That is going to be a great opportunity. And then you can have optimization for those contexts, and then providing a neuroscience framework to not only do brain stimulation, but combining your behavioral intervention with that. Your medication, how medications are going to kind of change this circuit base that we have been discussing, how we can do behavioral interventions that could just help. So bringing everything together and what we call a neuroscience-informed precision addiction services that includes everything, not only brain imaging, but also kind of genetics, all the other things that you have, putting them together, and also providing neuroscience-informed psychoeducation for your patients, and potential for interdisciplinary and multi-omics. You have lots of genetics studies here. Dr. Vidya has been discussing about all the other things that people are doing. So how you can bring them together with fantastic registry that you are discussing, about 2,000 patients. That is a large population. So you can do a fantastic job. And there are definitely potentials for global collaborations. In the field of addiction, brain stimulation, the trials, if you look at trials, just 22% of them are from the US. Around 80% of these trials are happening in other places around the world. So we made an international network of those who are doing these trials to help them to work together. Joint publications, 70 authors from different countries collaborating together, 52 different labs that are working together. So it's not something like somebody from the US is coming to teach you guys that you are doing to do this. It's just a group of people who are working together. And we have a YouTube channel. We have kind of there. We have annual meetings that we discuss about the collaboration, lots of kind of network activities, and also what we do in International Society for Addiction Medicine. On May 25th, we have a meeting specifically on innovations for addiction therapeutics. If you are interested, that is an opportunity, and thank you very much.
Thank you very much, Hamad, and I think your talks are always inspiring to hear more about neuromodulation and neuroimaging and all of these things. I think I'll have a space for 2 or 3 questions. So please, Khaled.
Thank you so much for your presentation. What are your thoughts about using neurofeedback as additional tool in that domain?
Neurofeedback has lots of opportunities. And what do we mean by neurofeedback? By neurofeedback, we provide neural data for the patient and ask them to learn from their own neural data to basically optimize their behavior. We do fMRI neurofeedback. Like we put the people inside the scanner, show them drug-related cues, and then show them the activation of their nucleus accumbens. So they can see, okay, now when I see the drug-related cues, my nucleus accumbens activity is going up. Or we can show them, when they have anxiety, we can show them the level of activation in amygdala. So they can see inside the scan, okay, now my anxiety is going up. And then they try to learn how to bring down their anxiety or how to try to bring down their craving. We can do that with other measures like EEG as well. There are 2 problems with neurofeedback interventions. First, the signal that you are showing the patient should be a reliable and valid signal. fMRI can provide a reliable and valid signal, but it's pretty expensive. EEG can provide data, but it's not that much reliable and not that much valid. People are starting to try to combine fMRI, EEG. That is the one challenge with EEG-based neurofeedback. There are areas like attention that probably EEG signal provides enough reasonably good data. So if you do attention training with neurofeedback using EEG data, you are moving towards the right direction. But it's not functioning really well. There is a specific area for PTSD that there is a new company that is making EEG-based signal for neurofeedback-based training and received FDA approval recently for PTSD. And they initially did fMRI and then did EEG, and now they show that the signal is helpful. So people are trying to optimize the signal. The second challenging part is the patient should be able to learn how to regulate their cognitive functions based on the signal that they have. In my clinical practice, 1/3 of the patients can really good learn that and use that in their daily life. 1/3, no way, they cannot learn anything about that. 1/3, they might make kind of some benefits. So there are many patients that it's hard for them to regulate their brain when you give them kind of markers of their brain activity. So these are the challenges for neurofeedback. The good thing about brain stimulation, we remove that patient part. In terms of patient is not supposed to actively contribute and do that. We do the stimulation ourselves inside the brain, and that is making it a little bit easier in terms of just do the hard work by the brain stimulation, not by the patient. So that is the difference between what we do, especially with closed loop electrical stimulation inside the scanner.
Hearing the answer, I don't know if we have a possibility for another question, but I think I'll cut it off, Mark. But I'll give the
I would be to share my slides. Whoever wants to have my slides, those organizers, I'm happy to share my slides with anybody who's interested, and we would definitely be happy to help, especially young people who are sitting mainly on the back. If they are interested to be a part of this process, that is something that's going to be exciting about the future.
There is one last question before you just drop down.
Yeah.
So we'll hear it and then try to be short in your answer.
Just a quick one. I just wanted to know from your or within your treatment protocols, have you experimented, for example, treating comorbidities like depression and SUD, like targeting SUD modulation at the same time within the same treatment, or is it something that you have?
I work in an interventional psychiatric program, okay? And we see the sickest of the sickest patient in Minnesota. In our program so far, we have treated 1,000, something like 200 patients with TMS for depression, okay? Most of our psychiatrists so far, they have not been interested to touch people with substance use. Okay. Because of many reasons. I mean, there are many psychiatrists that are not interested to add. So they say, okay, go and just stop drinking alcohol for a month and then come back for, I mean, who can just, it's just not like that, right? I mean, the clinical practice, if you just tell people, just go stop your drinking alcohol and then come back for your depression treatment. This is not the reality, right? So we can definitely start their treatment even when they are using substances. There are some technical challenges in terms of how to optimize the dose. We usually ask them, okay, if you are drinking this amount of alcohol, you are supposed to not change the level of drinking that you have.
Thank you, Hamad.
And things like that. So I will be happy to discuss about that. But final message, it is technically doable. Thank you.
Thank you so much. And I think all of us will be interested to ask you in between about all the marvelous work he's been doing. Our second speaker, last not least, Dr. Khalid. Dr. Khalid Mahmoud is a professor, research director of the Environmental Chemistry and Microbiology Program, and lead investigator at the Qatar Environment and Energy Research Institute, affiliated or working under Hamad bin Khalifa University. He's been leading a lot of fantastic work there, seeing here, and his group has contributed really good to the One Health and water-based epidemiology, which is actually recognized by the leading national and wastewater-based pathogens. He did marvelous work, I think, during COVID in surveillance of that and using all the technology of water-based and waste-based epidemiology. He's published several articles with high impact papers. I see now 150. I'm jealous. With books, chapters, and has been a really announced scientist in his field. Please welcome him.
Thank you, Dr. Rama and Dr. Maadil and Dr. Khalifa for the invitation, and thank you so much to Naufar for this opportunity. I'm sure many of you is asking now what this guy is doing here. I mean, how many chemists in the room? Okay, so at least I'm not alone. Okay, so very good. So ideally, I'm a chemist, and I deal with the water research in Qatar, and I'm leading the water center in Hamad bin Khalifa University, and we deal with all aspects of the water management and water quality and everything. So as part of that, we looked at the wastewater, and we realized that wastewater is actually has a wealth of information, as everybody knows, like every community and public consumption and all of the activities that happens in the community end up in the waste, and at a certain point ends in the wastewater. So you can get a lot of information from the wastewater. That's why we looked at the wastewater-based epidemiology as a tool for trying to find a way to like maximize the benefit of the wealth that's happening in the waste. So ideally, we talk about wastewater-based epidemiology, which the analysis was to analyzing the wastewater at the population scale for exposure, whether to pathogens or to chemical or any activities that actually end up in the waste, where every activity goes end up in the same place where there's a wastewater treatment plant, and then represents the population at the population level. So one of the early utilization of wastewater epidemiology was the actually monitoring of polio. And this is what happens around the 40s, and it was a successful tool for trying to find the level of the infection of polio at that time, and help the clinical studies at that time. And then after that, I don't think water-based epidemiology was being recognized for many years until the beginning of COVID-19 and the 2020. So the wastewater-based epidemiology actually is a very good way of trying to make this triangular understanding whether the public health significance, where like what is the potential of the disease, and even also the chemical use in the public, and then also the significance of the analytical feasibility, whether the water-based epidemiology is the right tool that they give us either qualitative or quantitative measure that can actually we rely on as a measurable data side by side with the clinical practices, and then also usefulness of action. What is this data is going to be utilized for, and can it replace the clinical surveillance, or it can actually complement the clinical surveillance, and as we're going to see later on. So this framework was actually very useful to make people, or at least the practitioners, to understand the usefulness of the wastewater surveillance and try to utilize it later on. So Qatar, one of the countries was like in our lab, we took the lead of using wastewater surveillance. This is an example of the pathogens monitoring, specifically COVID-19 monitoring. So we looked at the major wastewater treatment plant in the greater Doha. And as you can see here, we did not look at the rest, but this is actually almost 98% of the population represented here in this region. And we were able to actually start looking at the pandemic spikes at the early stages since the beginning of the pandemic. Like the first peak in Qatar was around April. So usually what we do is that we collect wastewater from the wastewater treatment plant. We do the disinfection process, like do heat treatment, because again, when you were looking at the virus, we don't worry about whether the virus is live or not. We're just looking at the certain the type of like a piece of the gene, and these gene fragments are robust and can survive. And after that, we actually take the samples into the lab, concentrate composite samples of 24-hour composite samples, and collect that in just a small volume of 10 microliter of extracted RNA. And then after that, we do the usual PCR that you are all know about. So then after that, as I mentioned, all of this process that I just mentioned earlier, and this is the results that we can get. We can segregate by zone, by locations, and we know the level of infection in each zone. So instead of looking at the whole country or the whole city, and we try to do clinical surveillance in every house, and we follow the patient's infection and so on, we can collect one sample that could represent 200 or 300,000 population, and we know like approximately the level of infection. We cannot give an accurate data because of all the complication that happens in the wastewater, but at least you can get the trend of knowing like whether there is a spike, whether they're increasing or declining, or as I'm going to say later, we can trace actually the type of variants in there. So as you can see here is one of the one of the examples here where multiple wastewater treatment plant, and you can get from a day to a day or from a location to a location what is the concentration of the virus that looks like. And of course, we can look at the variants of concerns. We do the sequencing, and we do whether the variants, whether alpha, beta, and other types of variants of concern. And luckily, we were actually able to be more accurate that we can predict the type of silent variants that's actually not yet predicted in the clinical cases, at least 2 weeks of early prediction. So that can be actually a preceding measure to help the clinical setups to follow up and be prepared for a certain variant. And of course, you can do cross boundaries measurements of cross boundaries measurements. So you can know whether these over flight, we collect samples from flights, and we know that the traveling pathogens, where they go and where they ended up and so on. So wastewater surveillance was actually extremely helpful for monitoring COVID-19 in multiple places, including Qatar. We have published this, and we even use this during, of course, this is not Qatar, I mean, 20,000, it's like a big, so, we use it at the World Cup and the 2022 World Cup, where people were not required to do pre-testing. So all the fans were welcome, and we were able actually to utilize wastewater surveillance for monitoring the spread of the virus or potential spread of the virus before the World Cup, during the World Cup earlier, and then after the World Cup. And that was actually a huge piece of information that was useful for the ministry and the organizing committee to understand whether we are actually in control of the level of infections or not. So it was very useful, and we actually also compared with the clinical values and the clinical cases as well. Of course, we monitor other variants, and we even also monitored enteroviruses and polio viruses. And we're still monitoring COVID-19 and other respiratory viruses until date. We have luckily, we have a good baseline, but it's good that we keep monitoring for preparedness for, God forbid, a new wave and so on. So, of course, there are challenges for wastewater epidemiology, including, for example, the sensitivity of the measurements, the accuracy, whether you are predicted the accurate number of population that's been infected or not, and of course, population dynamics. People are moving from a place to another, so you cannot rely on the 100% on the data, but at least, as I mentioned, you could have a good baseline. If there is a spike, you will see it and you will be ready for it. So, using this to monitor pathogens is also a good way of monitoring other substances actually in the water. And a group of substances, actually the drug, the pharmaceuticals, all of the chemicals that have been consumed by humans that can also end up in the wastewater, whether are the fully metabolized, partially metabolized, or unmetabolized chemicals. So it was water-based epidemiology also was a very useful tool, and it's been actually used in multiple countries in the world. Sometimes it's really sensitive information. So for some places that difficult to actually reveal the data or talk about the data or the infection, you are the expert in the room about the addiction and the level of addiction at the community level and so on. So, but it's actually a useful tool to be used in the background, in the backstage, to monitor the infection rate of certain narcotics or certain drugs, or even infection or utilization of different chemicals. So this approach is actually regularly followed by European monitoring centers, and even the American with Australians as well. They publish monthly or bi-monthly reports about the addiction level in the countries. But as I mentioned, it's not all countries actually use this. And as you see that the way it goes, like the illicit drugs has been utilized and consumed by human and then excreted into from the human body into the waste. And then, of course, they could actually go to the water bodies and continue the cycle if the water treatment process is not efficient enough to remove this. So besides a human impact, it also have a huge environmental impact. So it's very useful also for the wastewater treatment plant to know that whether the treatment process that's actually being utilized in the country is useful or efficient enough to remove or to destroy these chemicals or not. And as this is no surprise to you, you are actually familiar with this kind of map. Many countries actually they trace and they monitor, regularly monitors, and some other places actually the monitoring is absent. So this is the key message here. Do we really need to monitor these narcotics? At least in the backstage, you don't have to publish all the data, but at least you should actually know what is the level of addiction at the community level as well. So we follow the same practice. We collect the samples from the wastewater treatment plant, and we have done this actually during the FIFA World Cup time as well. And the only difference is that we take the sample, we concentrate, we do chemical concentration, and we do remove the interfering substance. And then after concentration, we measure by the mass chromatography mass spectroscopy, and we were able to monitor the concentration of the chemicals. This is the process, as I mentioned, and after the analysis, you can go to calculate the target by concentration, microgram per day, and then followed by estimation of the population. You normalize to the milligram per day by 1,000 inhabitants, and you can even take the mean dose, and you go end up with doses per day by 1,000 inhabitants. And of course, the techniques that we are using, where we are using the like electrospray chromatography with tandem mass spectroscopy, using SRM or standard reference material, and of course, like in our lab, we have about over 130 standard material, but I'm sure there are much more drugs than this, but at least we have the baseline for the analysis. All right. So this is the technique. We take the chromatography, we do the QA/QC, we do a good recovery of the peaks, and we have a good calibration curve. And from that, we start spiking the real sample after the solid phase extraction, and we calibrate against the calibration curve, and we get our results, and we do the normalization, as I mentioned, per 1,000 inhabitants. So these are the how the spectrum looks like and what do you expect from the spectrum. And the idea, like the message here is not really showing a quantification of the data, but at least to show you the potential of this method or potential of this technique to be utilized as side by side with the clinical addiction clinics to understand the level of infection. So And we can know from one community or one zone to another whether there is an increase of the addiction or not. We can even go to the resolution of the manhole of a school, and we can screen this as well as a type of an investigation. So it's an extremely useful tool. Of course, we remove the concentrations for some confidentiality and the location as well. But as you can see here, this is the way you get. So as you can see, for example, ephedrine, and I think this is the type of stimulant, but I think it's still classified. But if you look at for example, drugs like cocaine appears, for example, in certain days that were not seen previously, or even at lower concentration, and then you see a spike at a certain date. In some zones, the profile is a little bit different. So you will know, for example, that there is actually an activity of cocaine in this area versus the normal baseline in other areas. So the clinics can actually go and try to target these certain areas. This is very important to reduce the resolution or increase the resolution of analysis and measurements, and that's a big relief on the cost of clinical surveillance, if you may. Few more examples, as I mentioned, and then we give as it's just a few examples of what type of drugs and so on, and you can see all of the drugs. The drug consumption is a fact, and it's there, and it's normal. But at least you will know that there is a certain spike, for example, morphine or methamphetamine and so on, and then you can take the intervention. So it's really useful tools and useful measurements that can be used as a side-by-side. It cannot replace again, like as I mentioned, for the pathogens monitoring, it cannot replace the clinical surveillance or clinical monitoring or patient surveillance, but at least it will tell you the level of the intervention at the community level, so it can be able to at least be prepared for certain activities. And this is how the outcome, and you can see the consumption trend for one chemical. So what we're doing is that we're doing a dashboard. Of course, dashboard that actually can be kept and can be a dashboard for the authorities. But for COVID and pathogens, it was a publicly open dashboard that actually people can go and click on the link and see whether there is a COVID spike in Qatar or not, and whether there is a spike in certain zones or not. This will be publicly available, but a certain dashboard that can actually also for illicit substance can be useful for authorities and so on. And we are developing this dashboard. And this is the type where you can click on the type of drug. You can see the prevalence of a certain drugs in certain location or at a certain time and so on. So this is really useful for a hospital in Qatar like Naufar that can be utilized, and we can actually match the trends and match the trends. How many patients are coming for certain drug addiction versus what is been seen in the community and so on. With this, I'll just acknowledge the team that actually been working. I'm sure there are more team members beyond this one in other areas, but at least those will be involved. And of course, I'd like to thank the collaborators who've been working with us in these measurements. And thank you so much.
Thank you. Thank you so much, Dr. Khaled, for this. I was told that we are not going to be able to take any questions. I'm so sorry for this. But please approach. I think it's an innovative approach that we should be looking at in Qatar, and it is going to shape some of the future of treating, I think.
Thank you so much.
Of course, public health interventions. So thank you so much. And thank you all for listening here. And leave the floor with the MC.
We will now take a quick coffee break. Please be back at 4:20 so we can start our final session at time. See you soon. Welcome back, everyone. I hope you had a great break. We are now ready for our final session, Policy, Collaboration, and the Way Forward. Please join me in welcoming the moderator of this session, Dr. Sharif Al-Imadi, who is the Executive Director from Doha International Family Institution in the Qatar Foundation. Welcome, Dr. Sharif.
Thank you very much, Samira. It's an honor to be the moderator of the last session in this fruitful conference. And I want to take this opportunity to thank the organizer of this conference. And we want more like these conferences. Please, Dr. Mohammed. Thank you very much. We have in this session two very special experts. The Professor Jalal Tawfiq. It is our pleasure to welcome Professor Jalal Tawfiq, a distinguished expert in psychiatry and addiction medicine with a training across Morocco, France, and USA. Professor Tawfiq has held key leadership roles in mental health and addiction services, both nationally and internationally. He currently serves as a president of the United Nations International Neurotic Control Board and as a chief medicine officer at Naufar Hospital. Today, he will share insights on the global drug situation and the urgent need for president's policy to address the growing challenges faced by policymakers worldwide. Welcome, Professor, please. And you will have 20 minutes, but I will give you 5 minutes just because we are just, you are a new join of Naufar. That's
Thank you so much. We've been bargaining like a Moroccan does usually. So she gave me 40, and then we ended up with 35 minutes agreed on, right? No, I'm just kidding. Thank you so much.
Don't tell them the secret, please.
Thank you so much. Thank you for giving me the floor. Thank you. Really, it's an honor and a privilege to be here. I would like to first thank Professor Mohammed, really, for having me. Thank you. And thank you, Dr. Khalifa, for your trust. Thank you, Annette, for your support. Thank you all for your support. Since day one, I'm really feeling home, to be honest. I'm feeling home, and I'm calling home. And my wife was like, so when are you going to visit? I said, well, please come because I'm home now. So this is my new home. Even if I don't have a dog here, because they said, your home is when your dog is, right? So I'm considering it. So thank you so much. And it's, again, it's a privilege. And this is my first conference in Naufar. And there's a little story behind it, because when I was told to give a lecture, it was another subject, totally different, that Professor Mohammed told me to do. And then I went back to him and I said, well, can I do something else? And he kindly agreed. And then I didn't know it was about precision medicine, to be honest, because I was in Vienna at the time. And then I found myself drawing something totally different. And then I had to find a way to link it to precision medicine. And I did find a way, and that's going to be my last slides. This is a regulatory statement that we need to do when you work at the UN. So I'm not presenting on behalf of the INCB. So that's very clear for people in the auditorium and also people online. But I'm proudly speaking as a CMO of Naufar. And that's the most important thing, no conflict of interest. These are my documents I worked on preparing my presentation, and these are the topics I'm gonna go through. I will Kalashnikov you with 64 slides, and I'm serious. They were 92, cut them down to 64 slides. So I'm really sorry, but I'm gonna go very quick because the most important ones are the last ones. There is an increase. See, the last ones are the most important ones. There is an increase in world population leading. This is an obvious statement, and we're around 2.5 billion people with alcohol use in the world, 1.3 billion with tobacco use, and then almost 300 million people with drug use worldwide. And almost 300 million, as I said, that the vast majority, really it's cannabis, people with cannabis use, and then followed by opioid, people with opioid use. 64 million are presenting a substance use disorder, and only 1 in 11 are in treatment, actually. And of course, men have access and more access to treatment than women. Drug use by injection continues to drive the spread of HIV and hepatitis C, as you can imagine. An estimated 1.6 million, I think, people, equivalent to 1 in every 8 people who inject drugs, actually are living with HIV or were living with HIV back in 2021. The global trend, of course, consists of the increase of stimulants. That's something you see here in Qatar on a daily basis, especially amphetamine and methamphetamine. Looking at the trend index, you can see clearly strong increase in 2022. And no wonder why amphetamines are one of the main drugs that are seized in our region. And I went on UN missions to 4 countries in the region. I can tell you that methamphetamine are becoming really the drugs that are most seized in our region. These are the main synthetic drugs used in our region. You can see it. I'm sorry. You can see it's tramadol, opioids, methamphetamine, amphetamines, ecstasy, NPS, synthetic ketamine, and ketamine, along with sedatives and tranquilizers. There are 3 major issues globally to resume, the situation. The surge, of course, of synthetic drugs, supplanting plant-based for many reasons. Illicit manufacture of and use of precursors and precursors. You can, then not even under control, international control. So you can buy them. Anyone who has a little knowledge in chemistry would buy precursors and precursors, and the equipment that goes with it, and then design any drug that you would want. And also, there is a major issue now is the role of internet and social media in promoting use and facilitating traffic. But also, social media and the internet could also be used in prevention. So there is a positive aspect to it. There is an evolution of synthetic drugs, manufacturing, traffic, and use. And that's, of course, poses a huge threat to health and well-being. It's a deadly problem, as you can see. And the thing is, and the main thing is that there is a lot of comparative advantage to criminal actors over plant-based. Easier to design, easier to smuggle, easier to sell. You can send them by Courier Express. You can send them by drones. They're because of the weight, and of course highly potent. So these are the main, and of course also you can earn a lot of money out of them. So these are these are the drugs of the present, and these are the drugs certainly of the future. And of course, we already talked about the NPSs. The neuroactive substances is really catch me if you can. And detect me if you can, and treat me if you can. This is a real problem because they keep popping up, first of all. Very difficult to detect some of them, and many of them, more than 700 now. The core is around 76. But, and also, treat me if you can, because we are not trained in treating something we don't know. So a lot of NPSs actually are not known, and people end up with very strange symptoms in ERs, and physicians are not trained in treating them because they just can't diagnose it, they cannot detect them. I'm going to skip this. This is just to show you, that's the work that we do at the NCB. These are precursor incident communication system that actually traces all the precursors that go through transborder. And you can see from 2012, we have so many notifications and communications, 86 about precursors for illicit, for illicit purposes that are crossing the borders in the GCC area. The role of internet, I'm not going to dwell on it because you can find a very nicely designed chapter 1 and the 2023 INCB report, and I really invite you to go and browse it. I mean, it's really a nicely done one. The increase in substance use, related morbidity and mortality, this is a very, very tough indicator to tackle and to really master, because we don't, and the vast majority of countries don't even actually collect that indicator, and it's a very important one when it comes to designing policy and prevention. So you can see here the deaths, the main cause of deaths in the world, of course, it's hepatitis C now. And if you go to the DALI is, of course, the number of years that we would lose with a given condition compared to the lifespan in that given country. If you go to the DALI, well, then it's of course ODs, because you die sooner that you would be that you would expect. If you go to the region, you see that whereas 21% of 58 million people with chronic hepatitis C infection were diagnosed globally, we have a higher diagnosis rate in our region. It's about 37%. Daily of substance use, all substances, alcohol and tobacco included, the MENA region is at the top of the graph because they're not really often reported. And it's the same thing when it comes to the DALI for drug use, but that's a problem of collecting data. Scarcity of data and poor data collection in many regions, including our region. If you go to one of the nicest studies that have been done with WHO, looking at the national system on collecting data on provision of treatment, you would see that almost half of the countries of the region do not collect data on service provision of treatment. And also, more than a third, actually, they don't collect data at all on psychoactive substances. And even if they do, they don't do it on a regular basis. And not consistently. They do it occasionally and not on a regular basis. So what data are we talking about? What do we collect to actually inform policy making? Some of them we talked about. Of course, the best one, the core one is really general population. General population gives you household surveys give you, and especially the trends, not a snapshot, not a Polaroid one. It's really the trends. It gives you really what's happening in your country, so how you can design your national action plan and national strategic plan in substance use. So it is a crucial one to be carried out. Wastewater analysis is one of them. It's been talked about. And I was joking with Anat, said, most of the time traffickers, they flash out their drugs, and then, it impacts the wastewater analysis, I'm sorry. But once again, it's really the trend that matters and not just a snapshot. If you want to detect the new trends and also the new behaviors and new drugs, there is nothing better than high school students, 15, 17. So that's why we do them. We do them because they base the prevention and the preventive strategy for any country. People with injection drug use, of course, people with substance use in prisons. Also looking at the other indicators, problem drug use, high-risk drug use, and the treatment indicator. We have a very good, solid data that could allow us here in Naufar to have very good TDI picture. And I think with Rama, we decided to do the 2020-2024 TDI compilation. And of course, what we call the consequences of drug use, drug-related deaths, and then drug-related HIV and hepatitis C and all those other indicators. And you have also now new tech-based data through the phones and everything. Again, the national data are really the core monitoring for data, and then, of course, you complement with whatever you want. For example, if you want to focus on Imagine, for example, the wastewater analysis shows you something that's going on in the Pearl area. Well, then you would want to go and do an ACA in the Pearl, epidemiological catchment area, in that region, the Pearl, so you would know exactly what's going on. So and also data on specific populations. Could be migrants, could be people in prison, could be women, could be the elderly, could be you name it. Of course, all data collection methods have their strength and their weaknesses. That's where science actually intervenes. And then, of course, as it's already said, it's about the triangulation. It's how you, of course, cross and tabulate the whole thing and then understand, have a grasp of what's going on. And trends are important. You can't do without the trends. It's really the trends that decide what type of policy. I always state the obvious again. I mean, you can't fix something you don't know, and you can't know something you don't measure. So, and of course, when you measure, you know. When you know, you can anticipate on something. When you anticipate, you can inform policy and policy making. You can alert. You can come up with the alert system, and then you can respond. And of course, you learn from your response and you adjust again. So these are the, and this is where precision policy comes in, which complements precision medicine, which is really a crucial thing. Scarcity of data and poor data collection in many regions, especially in the MENA region. I'm not going to dwell on it because I have many points to go through. So I'm going to skip this one, just to let you know that there are some countries in the region that actually do have observatory on drugs and addictions. They have some of the data collection going on, especially in 15, 17, and then in national household surveys. But none of them has actually mortality and infectious diseases related to drugs. Disparity in access to evidence-based treatment. You see Europe comes top because the Americas are broken down into two. I mean, if you break down the Americas into North America and South America, then North America would go also on top. Unfortunately, Africa is at the bottom of the graph when it comes to access to treatment. Also, no data in the MENA region except for 2 countries on the TDIs. Disparity in access to controlled medications. I'm going to go very quick. This is a funny one. This is a map that we published with a group of people in the Lancet Commission on availability and access to controlled medications. And it shows you by the size when it's whether it's inflated or shrunken, the size correlated to the access. And you can see Africa is almost disappearing, and then you have our region also that's really shrunken because of the access to controlled medication. Going through this. The main concept here, and this is the key message when it comes to access to controlled medication, is access, not excess. You want to make sure that people who need it have access to treatment, to treatment for pain, treatment for neurological conditions, treatment for psychiatric conditions, but without inducing actually the excess and addiction. And that's a balance that one needs to strike. Lack of science-based prevention. We all know what works and what doesn't work in terms of prevention, of course, be it universal, indicated, or selective. Again, obvious, you would need to promote for protective factors and then decrease risk factors. But in the MENA region, majority of countries have only standalone policies in prevention. And very, very little of them have integrated their national prevention plans into national policies. So, and if you look at this slide, when they're asked, those countries, 14 of them from the region, when they're asked about those programs, they responded by either none or some. Parenting skills program, majority none or some. Community-based multi-component initiatives, majority pink and blue. Workplace prevention program, pink and blue, and so on and so forth. Lack of qualified human resources. Health workforce in the MENA region, less than 1 psychiatrist for 100,000 adult population. I'm sorry, less than one health professional dedicated to substance use programs in our region. And it's even lower for specialized addiction health professionals. And even with that huge deficit, if you ask those countries, and now 16 have reported have given answers. Only 7 countries out of 16 reported allocating human resources in line with the estimates. Emergence of laws and regulations, that's also one of the major challenges to international conventions. It's a very complex story. You know that. Let me just remind you that the 1961 Convention, Article 4C, states the following: subject to the provisions of the Convention to limit exclusively to medical and scientific purposes the production, manufacture, export, import, distribution of, trade in, use, and possession of drugs. So that, of course, makes anything that has to do with legalization not in line with the conventions. Again, I'm not discussing the relevance or the feasibility or the philosophy of it. I'm just giving facts. I have a lot of different policies, for example, just give you an example about cannabis. It goes from something that totally in line with the conventions, like cultivating and regulating and, of course, selling whatever derivatives, through regulation for medical use, decriminalization of use, legalization of adult use, up to really the extreme, which is exemption for all drug use. And of course, you know that has not been voted for. It was not voted, it was not validated. Just happy to tell you that MENA countries, parties to the conventions, are all of them fully in line and committed to the international conventions as they currently are. Human rights dimension, of course, you would need anyone to have access to internationally controlled medications when it's needed, have access to acceptable, accessible, affordable, quality, age and gender-appropriate drug prevention. The same applies to treatment, and of course, non-discrimination, non-stigma, and also to have their voice heard, which is very important. The participation into policy is something very important. Always keeping in mind the cultural specificities of the country. It is crucial and important if you want to design a policy and if you want to implement it, of course. I would add something that often forgotten, which is the right to information. Any citizen in any country has a right also to know what's going on, and I think it's important. And I'm going to finish with precision addiction medicine, PAM, and precision policy, PP. Precision addiction medicine, I mean, that's the vision of Naufar's leadership, of course, personalized, predictive, preventive, and participatory. Something that puts the person at the center of care with very specific individual approach, of course, seeking maximum effectiveness. Precision policy is a policy that's informed based on data, that's predictive also, that's preventive, that's holistic, inclusive, and science-based. So precision policy puts the person, but also the community, at the center of public health policies, interventions, and programs. So the best out there for every patient, not only those who reach you. Who are our patients, actually? You have the gray square is about the general population. And within that general population comes the orange one, which is people with substance use. You would never see them because it's only about use. And then you have the red one, which is the VPs and DPs and with SUD, which is voluntary patients. And then you hit me on acronyms, Annette. And then, of course, the directed and diverted patients. And then we forget what I call the UPs. UPs are the unknown, unseen, unwilling, unreached. What do you do with them? And I think this is where really it's important to have some policies that reach out to the community. So precision medicine is really responding in a very specific way, in a very effective way, in a very precise and personalized way to any patient. And precision policy is about also detecting and reaching out also to UPs. So the precision concept applied to policymaking is about really targeted interventions, data-informed policy, and of course, getting also treatment being reimbursed and accessible and affordable. It's really about translating science into policy. And basically, it's about targeting the right people at the right place with the right intervention and at the right time. Examples, there are a lot of them. Real-time overdose data, Indianapolis. I mean, I'm going to skip this, but you have tens of examples of the examples of precision policymaking. You all know the 10 Essential Public Health Services Framework. So you can't do unless you work with other stakeholders or partners. And this is also crucial that you work with people outside the institutions that you partner with. And let me give you, this slide is very interesting. It shows how the countries of the region partner with other institutions. And you see ongoing collaboration in the area of substance use, the red line. Most of them, they say, well, we actually work with National Drug Control Authority. And then you would see all the other institutions and you see very different rates of participation and partnership. And there is where Naufar comes in. I'm taking the risk to speak on behalf of an institution I just came in. It could be a precision addiction medicine center of excellence, but it could also be a center that promotes precision policy. How? It could contribute to designing national action and strategic plans. Some of these, it's already on the table, of course, already done. Collecting and analyzing data, something we can do. Making recommendations for policymakers, we already do. We can continue. Assessing and adjusting programs, we can do. We can be an expertise center for that. Mounting curricula for capacity building, I think it's already done. We can foster that. And also we can carry out qualitative research that really dear to the heart of Professor Mohammed. And we can contribute to community education and, of course, fighting against stigma, taking into account, again, the social and cultural characteristics of the country we're working in. Knowing the scope of magnitude, we can do household surveys, provided there is a will and a possibility of doing it. We can do ECAs. We can anticipate on new trends if we work with the National Education Department. We can respond in a very specific and tailored and culturally adapted national action plans. We can design that. That's something we can do. That's something we're already doing, compile and treat and demand indicator. We can adapt it and adjust with the years, and we can evaluate. And we can also work with the media. Work with the media because they're key partners in terms of reporting and what type of message we can convey to the general population. And of course, we can adjust plans and strategies. So the main objective, once again, unless policies are based on evidence, it's very difficult to advocate for substance use disorders to be a priority. Sustained funding is not guaranteed, not always guaranteed. Conclusions. PALM requires strong willingness, and it's there. I'm talking about addiction medicine. PALM can only be a blessing for all people of Qatar suffering from UCD. PALM needs highly qualified personnel, proper work environment, also needs funding. And PP will bring all that to PALM. Strengthen it by providing evidence through public health perspective, supporting it through solid data, and sustaining it through government and non-governmental funding. So the main goal is really for no Qataris to be left behind. Thank you very much.
Thank you, Professor Jalal. On time. We have a chance for one question, I think, yeah? One, then I will see. One question. No question? Okay. Already a shortage of time, so we will move to. Thank you very much, Professor Jalal. It is our pleasure now to welcome Dr. Khalifa Jaham Al-Kuwari, Assistant Director General at Naufar, a senior healthcare executive and physician. Dr. Al-Kuwari has led major healthcare initiatives nationally and internationally, including roles as a Director General of Espitar Hospital and Chairman of the Medical Commission at the Supreme Committee for Delivery and Legacy. His leadership has helped shape Qatar's national health strategies, and today he continues this work at Naufar. Dr. Al-Kawari will take us through the model of care in Naufar.
Thank you very much, Dr. Sharifa. Good afternoon, everybody. In the beginning, I would like to thank you for attending and participating in Naufar Symposium. And I hope you have found the discussion and presentation in the past 2 days valuable and informative. I have no conflict of interest. In my presentation, I would like to talk to you about the current situation in Naufar and Qatar. Also, I'll talk about strategic goals and model of care in Naufar, some of the Naufar statistics, and also the Naufar professional training, prevention, and awareness. And I will end with our aspiration for the future. Actually, most of my presentation has been already said in the previous presentation as a last speaker, but I will present anyway. Let me summarize some of the points or situation here in Naufar and Qatar. We are all aware that drug use and drug use disorder are having a negative impact in all countries, and Qatar, like other countries, have this negative impact, and including a recent. Also, we noticed a recent increase in methamphetamine use and synthetic cannabinoids. Actually, most of the figures and number here, it's aligned in what Professor Faris said about our region. And I will come to this in the statistics in more details. Naufar provide substance use disorder treatment for more than 1,500 patients a year, and plus evidence-based prevention and professional training. Also, we think that all services providers in Qatar need to be equipped to deal with these changing trends in substance use. And also, as you heard from in the past 2 days, Naufar is growing in the evidence-based and precision medicine and culturally adapted for Qatari patient and Arab patient. Now I'd like just to repeat also what Dr. Mohammed mentioned in his presentation. Our mission in Naufar is to help individuals and families to overcome substance use disorder by providing evidence-based, personalized treatment and recovery and innovative precision medicine approach. Naufar was founded by the Amiri Decree in 2015, and then rewritten or updated in 2020. And the Amiri Decree is recognized the addiction as a health issue and is a chronic and relapsing health condition that may require treatment and support for years before recovery achieved. And here I would like also to emphasize a very important point that also Dr. Mohammed mentioned in his opening speech. And we are really grateful for our leaders here in Qatar giving this issue of substance use disorder this priority. Naufar mandate, as given by the Amiri Decree, covers 6 strategic goals. And before I mention the goals, I want to emphasize that this strategy is aligned with the national and international strategies. It's aligned with the national and with the Qatar National Vision 2030, and it's also aligned with Qatar health strategy. Goal number 1 is to increase the number of patients achieving recovery from substance use disorder. Goal number 2 is to reduce the impact of substance, providing evidence-based targeting prevention initiative, especially to families. Goal number 3 is to increase knowledge in Qatar and substance use disorder are health issues, and also to reduce the stigma. Goal number 4 is to increase the professional knowledge and skills in substance use disorder in Qatar and globally. Goal number 5 is also demonstrated by this conference, is to increase the scientific evidence based on precision substance use disorder medicine and personalized treatment and outcome. And goal number 6 concerns the partnership and corporate excellence. Our model of care here in Naufar is recovery oriented. And by this we mean that the aim is not only to treat the illness, our aim also to help people to achieve recovery from substance use disorder. And recovery has 3 main elements. First is the voluntary control. So we help people overcome their addiction and gain voluntary control over their substance use and overcome it. Also, the second element for the recovery is we help people improve their mental and physical health and well-being. Importantly, they're also spiritual health. And we have Sheikh Badruddin here with us. He's doing a great job in this area. And this is also an important component of the recovery. Thirdly, we help patients reintegrated into society. So they rebuild a family relationship. Also, people finish their education, keep their employment, and contribute to the society. This is a Naufar model of care, and this is cutting edge, actually, the approach of precision medicine. So there is a patient assessment in the beginning, including genetic and metabolomics profiling. Then there is a detailed tailoring for treatment to fit the individual, which leads after to a better outcome. Naufar model of care is also phased and layered approach. So we have 4 phases where patients move from phase to another by achieving goals. It's not by time spending in this phase, but it's by goals. So in the first phase, which is the engage phase, where patients commit to substance use disorder treatment and attends regularly. Then the second phase, which is the stabilize phase, where patients reduce and stop dependent substance use and stabilize their life. The third phase, where the patient is abstinent for at least from 0 to 6 months and build recovery capital. And phase 4, where it's a sustained recovery, where patients achieve abstinence more than 6 months. And patient progress through treatment is often not linear in this journey. So some patients will relapse and move backward and forward through phases, or sometimes drop out from the treatment and come back. Naufar has a very high quality environment and healing environment. As most of you did the tour in Naufar, And this is the unit that we have in Naufar. We have a male outpatient capacity of around 600 and inpatient capacity of 98 beds, with unit covering all the recovery journey from the detoxification to residential rehabilitation, and unit of halfway house. Naufar female outpatient capacity is around 50, and within we have also 12 beds for inpatient detoxification and rehabilitation. Naufar also has 5 VIP villas. Some of Naufar units offer directed care under specific legal framework and alternative to incarceration or prison. Now let me just share with you some of the statistics. Naufar treated over 1,500 patients in 2024. 90% of patients were men. And Naufar has treated a total of 3,216 individual patients since we opened from 2017. And most of Naufar referrals are voluntary self-referrals, around 68%, and quarter are from the justice system. We have 25% through justice system. Only 2% are from the health system, which is unusual for a substance use disorder provider. At any time, around 47 of the Naufar patients are in early or sustained recovery. And most of Naufar patients have moderate to severe substance use disorder, and I will present the pattern now. Here's the first thing to mention here, that most of our patients are polysubstance users. And the second thing that out of this increase is there is, as I mentioned, the stimulants over the past few years, particularly methamphetamine or shabu. This is also a shift. When Naufar first opened, the first drug was the opioids, heroin, but 2-3 years ago, it's shift to methamphetamine and shabu. By 2023 and 2024, almost 70% of patients were stimulants used. With the increase in stimulants, also we noticed increase of sedative hypnotics. Cannabis was used by 56% of patients in 2023. This fell to 51% in 2024. And Naufar has also seen an increase in synthetic cannabinoids. Naufar has an investment in quality and strives to recognize as a high quality provider, and this is some of national and international accreditation, Ministry of Public Health, 6 ISO certifications and CARF accreditation. We are CARF accredited since 2018, and we received in 2024 10 separated accreditation. Naufar's strategic goals 4 concerns providing professional training and education. In 2024, we provide over 21,000 training hours, and this is 83% increase from 2023. This includes 196 staff in qualification and treatment. Most of the other providers are from HMC. training experts by experience and family members to be qualified as recovery coaches, providing also 65 student placement, doctors and physiologists and social worker. For family intervention, providing education and support for family members is crucial for Naufar model of care. And Qatari culture and people often live in extended family, and groups. A patient often attend treatment with family members, so we support family members in their own right, as well as helping family support loved one through their recovery journey. Naufar provides matrix family education for family members of patient. Every patient and family has a dedicated social worker who provides support, and we also offer family therapy sessions for those who need it. This is some of our strategic partnership in developing a comprehensive drug treatment system. So, and Naufar is fortunate to supported by multiple partnerships in the country. I would like to finish looking at what Naufar ambition is for the future. Naufar is a national resource for Qatar and committed to working in partnership to provide expertise and leadership to strengthen all agencies' ability to tackle substance use disorders. Naufar also already Center of Excellence in Substance Use Disorder as recognized by CARF International, and we will continue to provide substance use disorder treatment and recovery intervention for more patients in Qatar. Throughout this seminar, you have heard about Naufar exciting research agenda in precision addiction medicine and committed to increase the evidence based in substance use disorder. Naufar also committed to evidence-based intervention extended to provide prevention and community awareness and interventions to reduce stigma based on the science. Finally, Naufar would like to work in partnership to support the GCC and tackle substance use disorder. Firstly, we need to create a regional research network to be able to assess the size of the problem and the drug trends in the region, including new and emerging drug trends. We need this information to inform what capacity of system we need to inform our prevention work and also to help us to know what type of drug problem we are treating. Secondly, all countries have signed up the United Nations goals increasing in capacity and quality of treatment and prevention by 2030, and we can create a regional targets to help us work together to meet these goals, and we can help each other achieving this. As a provider, we need a multidisciplinary approach to treat out patients, and the same is true for the strategies. We need involvement for all key stakeholder groups and shared GCC strategy and regional network that includes health, criminal justice, social welfare, and research colleagues. And finally, we need to build a strong regional drug treatment research network and build science on what is effective for GCC patient. Our culture is different, our genetic makeup is different, and it would be a huge benefit to have a fully cultured, appropriate research on what works for us. Thank you.
Thank you, Dr. Khaled. I have just time for one question. Dr. Amin.
Thank you very much. It's not a question, just an idea. When I listen to Khalifa, I'm sure Naufar is a comfortable clinic for patients and for practitioners. But Naufar is other, is innovative. We have a vision. We have for the future. I think it is the DNA of Naufar. I work and I live in France. Like Jalal, we have seen much countries, much teams, and when I go now, when I visit, I have Naufar like a model. It's young, but it's for me a model of humanity, a model of managing with Dr. Mohammed, and I said yesterday with a vision. This is very, very important. It's not just a care; it's well-being. It's humanity. It's very important. You have a philosophy, Naufar.
Thank you.
It's very important for us because we are medical and we have ethics. Okay, thank you.
Thank you so much.
Thank you very much. Thank you, Doctor. شكرا.
Thank you all. We will now proceed with the final deliberation and closing. Please welcome to the stage Professor Mohammed Al-Maadid, who will lead the session, and joining him Dr. Khalifa, Professor Amin, Professor Jalal, Professor Vidya, Dr. Hamad, and Dr. Rama.
Thank you very much. I always like this part of the conferences or symposium, that we do a reflection and we say, okay, what did we learn here? Remember when I started that we said, actually this symposium is part of our strategy, because we've been working for 2-3 years now on this. And we've been trying to build an infrastructure, push our research, I have to say, into the quantitative arena, because we had a lot of qualitative work. But I've been talking to Dr. Jalal and the team and this kind of thing, that the future, we need also to push for the qualitative dimension, and I think. So I asked my colleagues here to be here so we can. I asked them. We heard from all our friends that they came from long distances, and we heard from our own teams. Where do we go from here? Okay, and we really need to hear that. So if I start with the ladies first, okay. Rama, I will start with Rama, okay. So where do you think we go? Rama, she's the director of our research, and she's done a great job. Actually, the last few years, she's been working solid day and night, because I know because we correspond with her, and we have meetings during the weekends, Vidya and I, and this kind of thing. So she done a great job in building that unit.
Thank you for the starting compliment for me. And I think one of the things that has been inspiring working here in Naufar is the support of leadership in that perspective. If you say where, and it's very hard to be the first one, I was hoping I could build on others, but I'll be the first. When I look at what we have been doing and the achievement towards research components, I think, as you said, we've done a great job to put the first steps. But I think that now we are mature enough to advance. And I'm quoting what Professor Amin said. What I love that we have a vision, and we want to reach that part. I think for me, if I'm just going to speak from the perspective of both, I am the director of research, but I'm also a clinician. I'd like our next step is to be, again, I don't want to use the word clean, but at least representative data in which will guide us to translate whatever we have learned now into practice. Because we've been doing that part. We have the information data. That's why we had that conversation with Dr. Prof. Jalal of how about trends? How do we look at what we have now, what we've done, what we have achieved? The profile of the patients that we have been treating in the last period, and let that dictate the refining of our model of care that Dr. Khalifa has presented nicely, and amend that. We have the basic data that can inform us to do that. We have, luckily, the caliber of clinicians that can take that work also and make it reality. So my first step to say what further, I'd like to see a translation of this data in changing and refining our clinical programs that we are providing at this point. Starting from refining diagnosis, and I'm talking about also the basic part of psychiatric diagnosis, looking at the psychological aspect, plus, yes, our genetic profiling, but also see that in changing our models. I'll give one small example. We've been saying here today, I think, there is all of the presentation, I'll say, mentioned the increase of methamphetamine use, stimulant use in our population. But I think one of the things that we need to advance on is put specific programs that address that. I think one of the contexts we know internationally that contingency management is kind of the golden standard there, but we didn't implement it yet as we want to implement. So that would be my first thing to say. Hope I said.
Thank you very much.
Of course, FMRI.
Vidya. Tara Vidya, she is our mastermind, scientific mastermind. She will not claim that, but actually, and she was responsible of the whole, designing the whole program for this conference, and we have to give her credit for that. So Vidya, you heard so many dimensions of this research that was going on. Where do you think our research strategy next? Where do you see it?
Yeah, I first of all, let me second, what you said about Rama. I mean, she's been a Trojan worker in the last couple of years, and the whole team. But, you always need an engine, and she's certainly been that for it. And I think in the last 2 years, maybe 3 years, we've been slightly protective of ourselves and said, let's get us to the stage where we feel we can collaborate with all the external people who've come on a level playing field, that we're actually going to sit at the table and not feel like the poor relations where they have to teach us what to do. And we've got to that stage, I think, where we're beginning to feel far more confident, listening to what Amin just said about us and talking to Hamad yesterday and earlier today, that perhaps we can be that. So I would say that one thing we could think about doing confidently is that we could think about look outside and think about collaborating and really we've got all the omics, we can think about circuitry, like Hamad, you mentioned. I thought that was really exciting. And can we map those circuitry at the genetic level or at the omics level? Natalie gave really nice examples where we can think about new, including John, your thing on methamphetamine, the new clinical trials. Can we think about GLP? So we've really learned a lot. And another thing, I think the forensic people are here, enforce here in this country, so we can see what they're seeing in terms of NPS. I think, Jalal, you said, until we know what we don't know, what are we facing? So NPS is going to be a big thing, the novel psychoactive substances. This is the big don't know. It's all very well to say, oh, they're on methamphetamine, they're on this. If you don't know, but you have your patient there, you know he or she is on something, but you haven't got a clue as to what they're on. And I think we should really strengthen our ties with our forensic. And as Dr. Khalifa said, not just forensics in Qatar, you really need to have forensic partners in Saudi, in the region, because it's coming from all of those. And I think that was one of the things when we went to the forensic lab, they said they don't have that jointness. And perhaps Naufar can help bring that jointedness together. And, picking up on what Giuseppe presented, can we learn, even if you don't know what the NPS is, can we, really sit together, especially you guys and the psychiatrists, and look at the clinical symptoms, and be able to kind of take a guess, at least. Because nobody in the lab is going to be able to keep up with the rapidity with which the NPSs are changing. So it's going to have to be very much clinical-led to help us solve this problem, at least initially, and I think, those are the kind of things I would say to start with, is going to be something that we think about. Greater collaboration within the country and outside the country.
Thank you. Who knows what we've been doing together, Vidya and I, the last 15 years. We've never been shy to address the most difficult issues in research, either at our center in London or at the anti-doping laboratory. And as she said, the last few years, actually, we were trying to build the capacity here and address the issues that's going to be. So my leading question now, there is a balance between really pushing research into the cutting edge and translational kind of things, because we need to see benefits for our patient. This is a service at the end of it. So, Professor Amin, where do you think that balance is, or where should we focus into that research?
You know my feeling, Dr. Mohammed. Naufar and his program is rich, demanding, and prices, like the program of this symposium. And I expressed my feeling after Khalifa's presentation. All is what I did is important. And this is your vision, Dr. Mohammed. This is your vision. After hospital, after Naufar, and with the team. It's very important. I want just because Jalal is new with us. Just a little word for Jalal. I know him. And I wanted to see Jalal, and you are in good hands there. It's very important. Naufar so yes, you are in good hands. Naufar is, and you're going to make a long run, I'm sure. I want to finish and to say, in Naufar, addiction is very excited. It's a fantastic discipline. It's not this in other place, in other country, in other services. Yes, it's very important.
We need guidance from your experience and this.
My experience.
Where do we think that critical issues that we need to focus, because we cannot do everything,
Actually, we must go at the global care. It's very important, and to use the innovation of research for patients. For me, the end point is the situation of patients. It's very important for us. Science for practitioner like me. Science without use for patients is not science. Okay, and Naufar we can do this. So for me, it's very important. Okay, to detect, to care, and to rehabilitations in the society. Okay, It's very important. It's the ethics of a clinical like a Naufar. Okay, it is my vision.
Okay.
Thank you, Mohammed.
Thank you. Dr. Hamid, this is not our first time to meet, but
thank you.
It's the same question in a way, because for this neuroimaging, a place like Naufar, maybe you said it in your lecture, but practically, where we can take it, that it is beneficial without, that we can take. Where can we go?
We have been discussing about vision, right?
Slowly,
what is?
You shot, you scared me.
Yeah, that is. Yeah.
You don't need the books.
Yeah. Just yeah. I really like to kind of yeah. I have the passion and I love what I do. So that is the reality. So I just think about what I'm doing during when I'm sleeping. I'm discussing that with my wife, my kids. So that is what I'm really passionate about. And we have been discussing about vision, and I think that vision is about both past and future, right? So future, I think 3 major issues are important for future for Naufar. First of all, next generation of people who are going to basically lead this field. Because the reality is we are going to be in this field for, a few other years. But who is going to be the next generation? We definitely need to develop human resources, bringing brilliant minds to the field of addiction medicine, addiction psychiatry, to be able to have enough human resources. How many medical students we already have here in this room? Okay, 1. How many psychiatry residents that we have here? How many psychology students? How many students from engineering side? Okay, so I was discussing with Dr. Khalifa kind of last night. We have been discussing about the medical schools here, Weill Cornell, Qatar University, how medical students are being trained here in Qatar, and how we can inspire the next generation. So that is one issue, one very important issue. How can we make addiction psychiatry, addiction medicine exciting for the next generation to bring the best brilliant mind to the field? So that is one issue. The second issue, how we can have the best type of evidence-based treatment here in Naufar, and then how we can have the best next level of research here in Naufar. So these are the 3 major issues about the future. And I think that for all 3 of them, I think neuroscience is important, because medical students, psychology students, engineering students, they are excited about brain, because my brain is exciting. Just everything is happening in brain, the circuits, the neurochemicals, all those. And brain is making us who we are, right? All the things that we have, spirituality, and it's always important in Islamic teaching in terms of how you train your mind and soul and all those really important things. So neuroscience can inspire next generation to come to addiction psychiatry. And that is what I've been doing during the last 20 years. In my lab, I have students from electrical engineering, from mathematics, from physics, all those people from different disciplines working with medical students, with psychologists, because the main target for all of them is brain. So I think the next generation are going to be inspired about addiction psychiatry and psychiatry, with informing them about what is happening in the brain and how addiction is, because addiction is affecting the most critical elements of human being and human brain. Decision-making, free will, self-control, all those really exciting human functions in the brain. And if we can tell that story to students, they are going to be inspired about the field of addiction medicine. And that is what basically inspired me. I was the best medical student in the class. So I could be a plastic surgeon, an orthopedic surgeon, but I decided to come to addiction psychiatry because I loved philosophy, I loved physics, and I loved basically doing neuroscience, and I found all of them in addiction neuroscience and addiction psychiatry, and I'm enjoying doing the clinical practice. Every single patient I see in the clinic, when I see them in the structure of how their free will is being impacted, how their self-control, how their insight, how their identity are being impacted, and how we can help them to recover those things, is just an inspiration in a daily practice. And then that is the kind of the next generation of students. Then next generation of treatments. You have fantastic physical rehabilitation here. You have a beautiful spa, all those resources that you have, the physical rehabilitation. I was very inspired by all the kind of physical rehabilitation. They're critically important for addiction treatment. And then we have been discussing about, John was discussing about kind of vocational supports, helping them to be back to job. All those kind of physical activities are critically important. And meanwhile, brain rehabilitation, about circuit-based interventions, all those things are going to be important, and you can definitely do a fantastic job doing both physical and brain rehabilitation and bring them together. So that's another level. And then the next generation of research, you are doing fantastic job developing a clinical registry here. This is what Dr. Khalifa was presenting, Professor Jalal was presenting, others, Annette was presenting. Just you have been able to assess people, 2,000 people, 3,000, 4,000 people, and then following them over the time. So you have a fantastic clinical registry. Honestly, we do not have something like that in the US. I mean, I have been traveling in the US. I mean, Hazelden, which is a fantastic center and collaborating with us. I mean, nobody has that sort of infrastructure in an environment that all these people in Qatar, you can follow them for a long period of time. So you have a fantastic infrastructure. You have already started doing lots of really fantastic omics things. You already have the genetic data, or you are collecting all those pieces of data. If you can add connectomics to that, in terms of you have the clinical level, you have the molecular level, if you have the brain and circuit level to that package, then you can understand how brain is moving forward in the process of recovery. But because the reality is nobody knows how brain is changing in the process of recovery and how we can optimize our recovery in a personalized way for people who are in recovery. And that is going to be a unique thing that you can do. You already have the brain MRI here. I mean, you have all those resources. If you can inspire the next generation of engineers, medical students, physicists, working together, that is going to be the future of work. Dr. Khaled, he is a chemist. He was presenting here because you have been able to bring a chemist to the field of addiction medicine. So this is what we need to have here. We need to bring people from other disciplines, collaborating together and doing fantastic job. And the last point, 2 weeks ago, I was in Egypt. I was visiting Alexandria Bibliotheca, and I was sitting in Al-Azhar Mosque. How many of you have been in Al-Azhar Mosque so far? Okay, so some of you have visited Al-Azhar Mosque. When I was sitting in Al-Azhar Mosque, I was thinking, I mean, there was a fantastic academia there 1,000 years ago, okay? And then when you are reading about what was happening in Baghdad during Abbasid dynasty, Abbasiyun, all those kind of golden areas of Islamic culture and science. And when you look into the Islamic section of the Alexandria Bibliotheca, name of the people that are there, I mean, the wisdom that they had, the leadership, the vision that they had, based on the vision that they have been able to bring people from around the world. So when you look into their family names, they are from places around the world. And I realized here in Naufar, you have people from 27 different nationalities here. So that is the type of vision that you have in Qatar, bringing people together from different places of the world, best of the best, and leading them and having the vision and making things happen. Nobody was thinking that the World Cup 2022 would be such a kind of great success here in Qatar. But you did it, and you showed the entire world that you can make it happen. So if you can take that leadership in the field of addiction kind of treatment, that would be a great, something that everybody would be able to be proud of that in the future.
Really, thank you. I was enjoying what you said. Really, it's enjoyable and stimulating, and and we need. Actually, when you talked about history, Naufar, how did we come to the name? Somebody mentioned it's the water lilies, but where did we get it from? From the Islamic Museum, because they have this medicine jar or button that we had, and written on it Naufar. And it was they used to extract medications for mental diseases. Okay, and it was from Damascus. It was from a hospital in Damascus. I don't know, 1,000 or 1,000 something years ago. That's where we brought the name, and we said, and it was our first CMO, Dr. Muhammad, forgot the name, Sarah. But he saw it and, Muhammad Saleh. So, Dr. Jalal, you talked about, I think you said everything in your presentation, but the dimension of that within the environment, the society, that precision, we really, I think we need this kind of a national kind of approach. And I was, while you were presenting, discussing with Dr. Khalifa on this. And possibly this is something we are seeing that this is one of the gaps we need to push. And this is what we identifying, like what Dr. Hamad was telling us about the brain, for example. We need to approach that. So just to remind everybody, where are we going with that? Because we have to tackle it. We cannot leave it. Okay? So if you would just want to comment on that dimension, please. I just want to, because we've been stimulated and we need to get everything stimulated again. By the way, tomorrow at 10 o'clock, we are going to meet IRAC here, the research committee. And we are going to review everything happened here, and we're going to have a strategy for the next 2 or 3 years or something like this for our research, just to see the dynamic, how we work, Yani. Dr. Jalal.
So the question is how to actually, again, play the role that Naufar could play at national level, more than just local level, right? That's the question.
Yeah, okay. It's what you said. But okay. It's just
how
summarize.
To operationalize it.
Yeah, we need to implement it.
To operationalize it. It's really, I mean, we can talk about this for hours. There are many dimensions in it. I mean, there is a political dimension, there is an epidemiological dimension, there is a social dimension, and there is a cultural dimension in it, and there's also the law and regulation dimension of it. If you think of the political dimension of it, you know better, because you know people. You know how to approach people. You know the reality on the ground. I can't speculate on that because you know better than me, political level. At the policy level, which is, again, it's about epidemiology. It's really, and you ask a very good question about the qualitative studies. Qualitative studies are a very big part of epidemiology. It's when the numbers cannot answer your questions. They're where qualitative studies come in. It's really to tell you exactly what numbers say and what they don't say. And you want to understand, for example, the patterns. You want to understand at the micro and macro. The macro level, for example, is I don't know how the families actually perceive, how the adolescents in Qatar perceive drugs. It's something very important for prevention. At the micro level, how, for example, what are the personal factors for non-compliance with the treatment? This is the micro level. You need to understand that. Why? Because that's exactly what allows you to design your policies, and then you go to the policy level. Now, we have also the social level. And the social level is you need qualitative studies to see what type of environment you will be implementing your policies in. Is it conservative? Is it progressive? Is it both? Is it, how would you, for example, if you draw a message on the boards in Doha, who would you, is that for expats? Or is it for Qatari? Is it for who? How do you design it? How do you go with prevention, universal prevention in school, for example? How do you talk to kids about safe behaviors, about healthy lifestyle? At what age, for example, you start talking about drugs? What type of language? That's I can't know. You know better than me because you live here. And then you have the laws and regulations. You can't do anything if you don't look exactly into the laws and regulations and try to see what fits your policies, how your policies actually articulate and interlink with the laws and regulations, what could be changed, what should be changed, and what's the priority. And the sit in the party in itself is a big, big, big move that needs anticipation, that needs advocacy, that needs really partnership with the main stakeholders.
Thank you, Doctor. I have to say a secret here, okay? And I talked about with you before that we really need to start researching the qualitative dimensions when you joined. I mean, Dr. Jalal just joined us a couple of months ago or something like this, maybe less. So we have to be kind to him in a way. But so we are expecting that he will carry, you know, a lot of the qualitative research as well. The secret is we tried, I've been biased towards quantitative research intentionally. Because if there's something does not exist or was not existing in an organization, what do? You push so far to it. It's not going to stay there. It's good. You know, when you have anything that you do, it goes up and then plateaus. And we wanted to plateau in the middle. And then we bring the qualitative as well. But we needed that quantitative also to become part of the system. We have to keep that momentum of our quantitative and bring qualitative, because we don't want to lose what we've done. At least we have the infrastructure now and things going on, and we have a lot. We are discovering more and more people here that they are joining to our research. I just wanted to comment on that. Who those do not know that I'll be stepping down. I'm retiring from Naufar 1st of June. And Dr. Khalifa will be the Director General. So I'll ask him to, in conclusion.
Thank you very much, Dr. Mohammed. Yes, I would like to comment on your question where we are going. I think, I'm confident that we are in the right direction once we have the clear vision and strategy, and we are, as Dr. Amin also mentioned, that if we are stick to this strategy and focus on our mission, we will reach the place that we are looking. I've been working with Dr. Mohammed now more than 18 years. And my confidence comes from this. And actually, his strategic thinking, or his if he's in charge of any project, he's always focusing on the mission and the strategic objectives for the organization. And the examples are too many. I mean, and he's not accepting unless to be number one. And we saw the anti-doping lab. It's an international lab. Aspetar also. It's a reference in sport medicine. It's if anyone mentions sport medicine, Aspetar is number one. And this is all because of the vision, and they are following what Dr. Mohammed, think about, the vision and the strategy for the organization. So I'm really confident that we are on the right way, and we will reach, inshallah, the place that we desire. Thank you.
You should have continued. I didn't cut you down, so continue. No, seriously, guys, the last 30, 40 years, whatever, my advice, it is strategy, strategy, strategy. If you get the right strategy, how to implement it, you can skin the cat in 1,000 ways. But you need to know what you're going to do, your vision. You have an end point. Whatever your resources, wherever, you're going to reach there. In 1 year, 2 years, 10 years. But the vision, the strategy there have to be there. That's if anybody want my advice. But I'm going to say it anyway. Take it anyway.
From my...
So... First of all, I would like to thank our guest speakers. Really, they took the time. خلصنا.
During my experience with Dr. Muhammad, he don't fire anyone except if he do two things. Either ethical or he is away from the strategy. Really, this is true, wallah.
And I enjoy it, by the way. Okay. So I would like to thank the speakers that he came either from Doha, but especially for those who really took the trips. I mean, I know that when we are invited somewhere else, it is not easy. You take the time, you travel, you prepare, so we really thank you. And now we consider you as one of us. You are a member of this journey. And I hope this will continue and there will be communication because, as we said, we already, by the time we chose that we wanted to invite you, we didn't invite you just because what will you do? And we looked at what you've done before and this kind of thing. We thought these is possibly good collaborators with us. And these are the guys that we want to go with us in a journey, So that's, I think, what I would like to say. Thank you very much. And I think you have something to present, Alicia? Yeah. There is speakers.
Yes,
something there is for speakers. I don't know.
If it's okay, we'll have a certificate of appreciation for all the speakers. Okay, I think there. Diana.
Yeah. Should they go down? Yes.
Okay, we'll start now. So we'll start with our international external speakers, and I apologize in advance. Sorry, I'll just repeat myself again. So we're going to start with our international guest speakers, and I apologize if I don't pronounce your name correctly. So we start with Professor Amin Binyamin. Yeah, please. Okay, next we have Professor Alexander Baldacchino. Okay, next we have Professor Faris Al-Harbi. Okay, next we have Professor Giuseppe Barsani. Okay, next we have Professor John Marsden. Okay, next we have Dr. Natalie Racer. Next we have Dr. Hamid Ikhtiyari. And then, last but not least, from the international guests, we have Dr. Lee Tong Sun. And now we'll start with our local speakers, and we'll start with Professor Vidya Mohammed Ali. And next we have Dr. Jitesh. Then next we have Dr. Khalid Mahmoud. Next, we have Dr. Munira Al-Jaber, but she gives her apologies. So can we have Dr. Karim Al-Khaldi, please, next? Yeah. And now we'll go to our Naufar speakers, and we'll start with Annette Dale. And can we have Professor Jalal Tawfiq? No. Next we have Dr. Rihan Siddiq. Next, we have Dr. Rama Kamal. And then can we have Dr. Akif Khan, please? And then can we have Dr. Oscar Amares? Two more left. Now we have Dr. Khalifa. And of course, not last but least, Professor Muhammad.
Thank you that you're all standing. We just wanted to use this moment to say, before everything, thank you for all of you. But we wanted really, for the success of this day, to actually thank 3 people who took the load. I don't have a mic. Who took the load, who worked hard, who led all the teams that made this day a success. I know they will hate me, all 3 of them, but we really wanted to put them on the spot. And this is a big thank you from the IRIC, saying that without you 3, it couldn't have happened this good. And really a very hard thank from the heart. First, Diane, come up, because we really want everybody to put you on the spot. And we chose the purple thing that you would like. Hope you enjoy it and keep the work that you've been doing. All the sweaty moments living in Naufar and having also pleasure doing what you've been doing. Thank you. Our next person would be, because ladies are first, Fatma. Putting all the efforts with all the externals, the program, chasing all of us, and being so, I know you're going to kill me, being so positive, and I don't know anything more to say. The other word? Another big rosy rose for the ladies. Thank you.
I don't know for the last. I mean, Fatma, she's like a daughter for me. I mean, she's been working with me in so many projects and so many things. You've been with me. How many years? 25 years? I'm afraid if I say a large number, she will say, you know, but I think nearly 10 years, huh? 14 years. And she's been, I'm completely dependent on her. I call her sometimes, what's my password? You know, okay, get me this or that, or she checks all my emails. I mean, I don't think I would ever survive in any one of these projects without her.
And we couldn't have survived here also. So thank you, Fatma, again. And again, my German enemy. No, Oliver. Thank you, and I'm thanking in your, we're saying thank you to you, all the facility. What you have done, how have you started and stand with beside us. So from the heart, thank you. Now, we chose for him the white flowers, hopefully that say something of purity and thankful for what you have been doing for us and how you did everything here, and also will be a good gift for your wife.
Can I say something about Oliver? When we started this project, we had difficulties with our project management. It's an external organization. So we needed help to be able to control the project. So one of the first people, maybe you were the first or second first or something like this. Yeah, anyway, but he's still with us. He was there with us, helped us in controlling the project, managing the project until it was established. And he was solid. And you can see him smiling. It's the same smile. Performance as well. I mean, I was a little bit embarrassed to give a big guy flowers, by the way. It's I mean, I hope you didn't take any pictures. I mean, I have a reputation to keep, you see. But it was a pleasure to be working with him for the last 15 years or 14 years, something like this. Thank you.
Thank you, Oliver. Thank you, Diana. Thank you, Fatma. And thank you, everybody who has participated in making this a big success. All of you. And next year? We are going to do one thing. Hamid's favorite activity. He knows what it is. A picture for all the speakers. So please gather, I think. And I don't know if you want to have a bigger picture, Diane. I don't know. Help me. Do you want all the people who were attending now? Yes, if you can be up on the stage, all of you. I'm sorry asking this, but we would like to have a picture as a family of Naufar.
Better.